chest expansion.
Okay. I'm going to check the carotid pulse for 10 seconds now.
Okay, so you can't feel any pulse.
Okay, no pulse.
And when you were bagging, the child did not cough, and child does not have any movements to suggest signs of life. So
okay. I think I need to start on chest compressions.
Yeah, he's in cardiac arrest, so you need to start
1 and 2
compressions.
and 3 and 4 and 5 and 6 and 7 and 8 and 9 and
So
10
Srilal is giving
11,
cardiac
12,
compressions to the
13,
lower
14,
half of the
15,
sternum
Then
at a
can you
rate
take
of
over
100
on my
per
count?
minute
Three,
and a
two,
ratio
1.
of 15 compressions to 2 breaths. Make sure the chest is compressed 1/3 the depth of the chest. The child should be in the meantime attached to the
Training
automated
mode.
external
Call for
defibrillator.
help. Analyzing heart rhythm. Do not touch the
Do not
patient.
touch the patient.
Shock advised. Charging. Stand clear.
Stand clear. Charging.
Press flashing shock button.
It's charge. Stand clear.
Press shock 1 delivered. It is safe to touch the patient. Begin CPR now.
So chest compressions should be given to the lower half of the
Continue.
sternum. The elbows should be straight and the weight should be on the
Continue
patient.
for 1 minute 45 seconds.
The fingers should be interlocked and in the air, and you should not touch the ribs.
Continue.
This way we can minimize rib fractures. You can see the
Continue
ventilation
for
is
1
done
minute 30
with a
seconds.
double-handed jaw thrust, maintaining the mask. This is done to minimize
Continue.
aerosol generation, especially with the current COVID situation.
Continue for 1 minute 15 seconds.
11 and 12 and 13 and 14 and 15.
Continue.
1 and 2 and 3 and 4 and 5 and 6 and 7.
Continue for 1 minute.
11 and 12 and 13 and 14 and 15.
15 chest compressions to 2 breaths
Continue.
should be
4
continued.
and 5 and 6 and 7. 9 and 10 and 11.
Continue for 45 seconds.
1 and 2 and 3 and 4 and 5.
Continue.
7 and 8 and 9 and 10 and 11 and 12 and 13, 14 and 15.
Continue for 30 seconds.
1 and 2 and 3 and 4 and 5 and 6, 7 and 8 and 9 and 11 and
Continue.
13 and 14 and 15.
Continue for 15 seconds.
4 and 5 and 6 and 7, 11 and 12 and 13 and 14 and 15.
Continue for 5, 4, 3, 2, 1. Stop CPR. Stop now. Do not touch the patient. Analyzing heart rhythm. Do not touch the patient. Analyzing. No shock advised. It is safe to touch the patient. If needed, begin CPR.
So there is spontaneous breathing now. You can feel the breath on your cheek and you can see the chest movements.
Okay.
And
Continue.
there is spontaneous pulse. Regular pulse rhythm is felt.
Continue for 1 minute 45.
So we have put the child in a recovery position, and we need to continuously monitor the child while further help arrives. Now, we have demonstrated arrest. But if the AED says that we don't need to shock. That means the child is in asystole and therefore we need to continue CPR for another 2 minutes. So we conclude basic life support and the important message DRS ABC. Thank you for listening.
This is the airway skill station. Today Dr. Dhananjay is going to demonstrate to us the airway opening maneuvers. So today we are going to demonstrate you the airway positioning. In the sniffing position, this is over the child, and also the opening of the airway using the head tilt and the chin lift, and also the jaw thrust. Thirdly, we will do the use the airway junks, the oropharyngeal airways after suction under the direct vision. And then we will go on for the ventilation using the bag and the mask. So we do use some equipment for this airway opening. So firstly, the oropharyngeal airways. So this is the oropharyngeal airways of different sizes. And we do have some masks. This is the round shaped mask. And this is the anatomical shaped mask. And we do have a Yanker sucker, which we have a hole to use the negative pressure. And we do have some tongue depressors and the bag. So Dhananjay, this is an 8-year-old boy who was brought to the PCU, brought with unresponsiveness, and please manage the airway accordingly.
So I'll read the patient now. First step of that is to look for danger. Is there any danger here?
There is no danger.
So there's no danger. My next step is to see the response of the child. Baba, is the child responding now?
Child is not responding.
Yes, as the child is not responding, my next step is to go for positioning of the airway. For that, this is an 8-year-old child, I will keep the child in the sniffing position, which includes keeping the earlobes and the shoulder in a straight line. So, I'll keep the child in the sniffing position. Is the child breathing now?
Child is not breathing, Dhananjay, after keeping the child in the sniffing position.
So in the sniffing position, child is not breathing. My next step is to open up the airways, which include first the
Head
head
tilt.
tilt and the chin lift. Then I again look, listen and feel for the child's breathing.
So with the head tilt and the chin lift, still you don't get any breathing.
So there's no breathing with the head tilt and the chin lift. My next step is to go for the double-handed jaw thrust. For that, I'll use angle of the mandible, and then I'll open up the airway and see. Is the child breathing now?
Still the child is not breathing.
So there's no breathing now. So because of that, so I will go for the direct vision with the tongue depressor and look whether there's any obstruction or any secretions.
So when you look inside, you see some secretions, and now you're using the Yanker sucker with a negative pressure to suck out the secretions.
So I suck out the secretion with a negative pressure with the Yanker sucker. So then I would like to open the airway with the oropharyngeal airways. So oropharyngeal airways has different sizes. So it comes from the mid-incision to the angle of the mandible. So this extends beyond the angle of the mandible. This is too large. And this look appropriate. So I will insert under direct vision with the use of tongue depressor. Again, I assess the child whether the child is breathing now. Is the child breathing now in the sniffing position?
Child is not breathing, so you have done the clearance of the airway under direct vision using the Yanker sucker, and you have used the airway junk, the oropharyngeal airway. Even with that, you don't observe any breathing.
If a child is breathing, I would go for the face mask ventilation. As the child is not breathing, then I would like to go for bag mask ventilation. For that, this is the anatomical face mask. So, selecting the appropriate size of face mask includes it should not go beyond the eye level. It should not go beyond the chin. So this looks too large, and this look appropriate. So this is the bag with the bag ventilation. I look for the fixed mouth valve. This is functioning. I'll connect the mask to the bag with C and E method. I'll start ventilating the child. Am I getting the chest expansion now?
Yes, we are getting a good chest expansion.
As we are getting the chest expansion, we have stabilized the airway now. So we'll call for help. Until we get the help, we'll connect the child to the pulse oximeter and the multimeter monitor.
Okay.
And we'll wait till the help comes to us for the next step of the management.
Okay, so we have connected to the pulse oximeter and started on the ECG monitoring. So therefore today, Dr. Dhananjay explained to us and demonstrated to manage the airway. So firstly, he opened the airway using the sniffing position, since this is an older child. And secondly, he opened the airway using the head tilt and the chin lift. And since there was no breathing, he went on to open the airway using the double-handed jaw thrust. Since there was no breathing observed after opening the airway using the airway opening maneuvers, he went on to clear the airway under direct vision using a Yanker sucker and a tongue depressor, following which he selected the appropriate size of the oropharyngeal airway, which is an airway adjunct, and inserted it. Even after inserting the airway adjunct, there was no breathing, therefore he went on to ventilation. So he used the bag and the mask for the ventilation. He selected the anatomical face mask since this is an older child, and he selected the appropriate size covering the nose and the mouth. And he checked the bag before starting the ventilation. So the next step would be for the intubation of the child, which we will see in your next video. Thank you.
Good morning, sir. Shilas, are you there?
Yeah, morning, Roshan. Dr. Guani is going to join.
Okay, sir.
Yeah, just hold on for me. Yeah. Okay, good morning, Roshan. Dr. Guani has joined. Can you give the access? Roshan?
Yes,
No,
sir.
I will just, no, I'm there.
Yeah, yeah. Okay. Okay, you can go ahead, Guani. So now we're going to start the pediatric module for the pre-intern. So Dr. Guani is the president of the College of Pediatricians, and she will speak to you a few words before we start the program. So it's over to Guani. Yeah.
Thank you very much, sir. Firstly, on behalf of Sri Lanka College of Pediatricians, I would like to thank Dr. Lalpana Pittiya and Dr. J. Vijay Surya for facilitating this program under the directive of Dr. Selagunawardana, the Director General of Health Services, and also Dr. Srila De Silva, organizing the pediatric, all the professional colleges, as well as Dr. Srila De Silva for organizing the pediatric component. And also a great pleasure to welcome all of you, all of the prospective interns for this program who will be starting their internship very soon. We know that you're coming from different medical colleges from all over the world. So this might be a good forum for everybody to get into and get some overview of what's going to happen, and to get the knowledge and the skills, I mean, to a certain extent, what is expected from an intern during your internship. We know that this was happening actually physically all this time. We know with the COVID-19 pandemic, we were struggling for about a couple of years. And during that time, we transformed ourselves to the new normal. So with that, we got into this online platform. So here we are on a online platform, this time conducting this program. So as I said, you will gain a lot of skills and knowledge related to your internship for the next year. Specifically, I think I should mention that this will help you to improve your communication skills, the patient safety. Those are very important things during your internship, and also to develop the confidence. Because I know that all of you must have spent a significant time after your final year exam till you start your internship. So with that, you may have lost your clinical touch as well. So this is a good program, a preamble for you to get into the momentum, and then to do a good internship, because it's the most important year of your life where you have the first contact with the patient. You won't get it. I mean, sometimes you will never ever get it again when you get into the middle grade. So this is the best opportunity, I think, and make sure that you get into the momentum by participating in this program, and then gain whatever the knowledge and the skills that you need to carry out your the internship program. And also, I must say that you all are coming from different universities, so that you're getting into one forum. So good opportunity for you to get the same messages and sending the same messages right across to all the interns who are participating in this program. So at the end of program, I'm sure you will be equipped with adequate skills and confidence to carry out your duties during your internship. Thank you very much. And over to you, Dr. Srila De Silva, sir.
Okay, thank you, Gwani. Thank you. I think we'll start the next first lecture. It will be with Dr. Shamila Tisera. Just give a little time.
Okay, welcome to the defibrillation demonstration. Here I'm Dr. Brinda, Dr. Shamila, Dr. Dhananjay, and Dr. Manoj. We are going to demonstrate how to defibrillate an arrested patient. So defibrillation is a life-saving technique, and everyone should know to manage the shockable arrest patient. So here, before moving into the skill, I would like to introduce the equipment. So cardiac monitor. So any patient who is arrested, we should immediately correct the cardiac monitor. So in cardiac monitor, there are knobs. So this is monitor on, lead selection, lead 2 we will select, and ECG gain, and then charge button. Here we are mostly using the panels in pediatrics. So here, this is a charge button, again yellow button. Yes. On machine as well, you can charge.
Yeah, Shamila, you can start.
Okay. Good morning, everyone. Sorry for the delay. So I'm Dr. Shamila Tisera. I'm a pediatrician, and today I'll be doing basic life support, which is, I would say, the most important lecture of all these life support lectures, because it's similar to the foundation of a building, where if you don't have a solid foundation, the building is not going to survive long. So therefore, the advanced life support that you do on an arrested patient will not be very effective if your basic life support is not very good. Okay. So what do you mean by basic life support? Anyone? Okay, since we are kind of pressed for time, basic life support is being able to manage the vital cardiac and respiratory functions of a child or an adult without the use of any equipment. So basically, you don't need any equipment, just the knowledge and the skills. So let's see what our objectives for this lecture is: to understand a structured approach to basic life support, to learn the sequence of basic life support, and to describe the skills to be acquired. Now, we follow this algorithm and we will go step by step describing the algorithm. But let me first tell you, in pediatrics, we divide children into 3 groups. So newborn is like from 1 month, newborn is like for the first 1 month. Infant is 1 month to 1 year, and child we consider 1 year to puberty. Now, if you see a child, a person, let's say a person, you don't know whether it's a young adult or adolescent or child. So in the sense, a very small maid, like a 16, 17-year-old lying on your bed, and you don't know whether this is like a young adult or a child, still, you would manage this patient as a child. If you're not very sure, don't worry. Just manage and resuscitate this patient as a child, because that's not going to kill that person, okay? By doing the correct way, you will save this person, all right? So, as I said earlier, you don't need any equipment. It's just the knowledge and the skills. So you can do it anywhere, not only in hospitals, outside, when you're walking in the garden or at a park, roadside, if there's a traffic accident, or at a party. So anywhere you can perform this basic life support. All you need to know is the knowledge and how to do it and the skills, okay? So as you know, we had a major pandemic and of COVID, and therefore we still are precautious about ourselves. So we have to wear whatever personal protective equipment that you have with you. So gloves, masks, face shields, aprons. If you have with you, please wear it. But in hospital, of course, you have the whole the kit. So as shown in the picture, it will be available for you to wear when you're resuscitating a patient. But do not take a long time trying to get into this kit, because time is precious when it comes to arrested patient. Okay, so in children, the commonest cause of arrest is hypoxia, because most of them, I would say 99% of them, the heart is normal. Only very few of them would have congenital heart disease. So therefore, the common cause of arrest is hypoxia, whereas adults, it is primary cardiac problem, where it can be myocardial infarction or it can be an arrhythmia. But in children, since hypoxia is the commonest cause, we always give priority to airway and breathing over circulation. So therefore, when we resuscitate, we follow this ABC approach. A for airway, B for breathing, and C for circulation. Don't forget that structured approach, that is ABC. So always when you're resuscitating a patient outside of hospital, you have to follow this DRS approach. D for danger, R for responsiveness, and S for shout for help. So what do we mean by danger? Let's say you're going for a walk. You see somebody lying in a park. You're not going to go straight and touch this person. And always you have to check whether there's a live wire there. Electricity could be a patient who has been electrocuted. So always check to see whether there's danger. Another example, if a child has been knocked by a vehicle, road traffic accident, and child is on the middle of the road, obviously you're not going to resuscitate this child on the middle of the road, are you? You're going to take this child to a site where it is safe place for the child and for the rescue. Because if you become a victim, then there'll be two people and a lot of people are needed for resuscitation. Okay, so please be aware of the dangers. And then once you're sure there's no danger, next is you have to check whether this child is really unconscious. So how do you check that? So place one hand as it's shown in the picture on the patient's forehead, and that is to stabilize the cervical spine. So if there's any injury to the C-spine, by doing this, you are stabilizing the C-spine. And then you can shake the hand or give a painful stimulus to the sternum and check to see whether this child is really unresponsive. If the child is unresponsive and not responding to your voice or painful stimulus, then you have to shout for help. Please, can somebody get me an ambulance? Or can you call the hospital, get an ambulance? Because it's very difficult to resuscitate a patient all by yourself for more than 10 to 15 minutes. It's very tiring. And also you need to get that patient into a hospital where advanced life support can be given, as well as drugs are available in hospital, okay? So we follow that DRS approach. Doctors, easy to remember. Okay, so what is the commonest cause of upper airway obstruction? Remember, we always follow the ABC approach. A for airway. So commonest cause of airway obstruction is the tongue falling back. As you know, when a person is unconscious, the whole body becomes limp. Then the tongue muscle, the tongue, as you know, is a muscle attached to the jaw, and that also becomes hypotonic and it falls back into towards the pharynx. So that causes an obstruction. In that case, how do we get that tongue out of that pharynx? So what you do is, you do airway opening maneuvers. So we can do two maneuvers. One is shown in the picture, which is head tilt, chin lift. So how do you do that? Place one hand on the child's forehead and push the head down. And with the other hand, the two fingers under the chin should be on the bone and not on the soft tissue. So pull the chin up. So head tilt and chin lift, okay? So in children less than, child less than 1 year, they have, as you know, a large occiput and they tend to flex the neck. And therefore, we do this head tilt chin lift to a neutral position. That is, the ear should be parallel to the surface that they lie. Above 1 year, we do this head tilt chin lift as shown in the second picture to a sniffing position. That is, there is slightly more extension of the neck. So head tilt chin lift to a sniffing position. Say, if you smell something nice in the air, what do? You lift your chin up and put your head back and try to get a good breath of that nice smell. Okay, so you want to forget that. So head till chin lift to a sniffing position, or for children above 1 year and less than 1 year, it is a neutral position. Okay, so once you do that, you look, listen, and feel to see if this child is breathing. I will talk about it in the next slides. So let's talk about the other method of opening the airway, which is the jaw thrust. If you're suspecting cervical spinal injury, say road traffic accident or a child who has fallen from a tree, there is a chance of damage to that cervical spine. So by doing the head till chin lift, as we talked about, there's a certain amount of neck movement, which could damage the spinal cord. So therefore, we normally do this jaw thrust. In jaw thrust, how do we do that? We place 2 fingers on either side of the angle of the mandible and push the mandible up. So 90 degrees, the mandible is pushed up and there is no neck movement. So this is called the jaw thrust. So after doing jaw thrust, then you again check to see whether this child is breathing. Okay. So once you have done a head till chin lift or a jaw thrust, next is you have to check to see whether this child is breathing. So we do the look, listen, and feel method. That is, the person who is resuscitating places his or her face over the child's face. So the rescuer's eyes are looking towards the child's abdomen and the chest to see if the child is breathing. And by placing the face over the child's face, you can hear if the child is breathing and you can feel the breath on the cheek. So look, listen, and feel for breath. Okay. So you do this only for 10 seconds. So after 10 seconds, if the patient is not breathing, then outside of hospital, how do you give that breath? You have to give mouth-to-mouth breathing. So let's see how we give this mouth-to-mouth breathing. So you have to open your mouth. If it is less than 1 year old child, open your mouth, take a deep breath, and place your mouth over the child's nose and the mouth as shown in this picture to cover the nose and the mouth and give exhale breath. A slow, good exhale breath into the child's nose and the mouth. Take your mouth away again, take a deep breath and exhale again. So you do this until you get 2 good chest expansions. So while you're giving, your eyes should be looking towards the child's chest. Okay, you can see in the picture, you can see if the chest is expanding. So if you have 2 good chest expansions, that means the oxygenated air has gone into the lungs. Now, if it is a big child, you cannot open your mouth to cover the nose and the mouth. Okay, in that case, remember you placed 1 hand on the forehead to keep the airway open. That same hand with the fingers pinch the nose. So you close the nose and you place your mouth over the child's mouth and give the exhale breaths. So children less than 1 year, you cover the nose and the mouth, but children more than 1 year and adults, you pinch the nose and give mouth to mouth only to the child's or the adult's mouth, okay, only to the mouth. So make sure 2 good chest expansions are there, okay. I will answer questions at the end. There was a chat box, somebody wants to know, I think, but I will answer any queries at the end. Okay, so mouth to mouth, 2 breaths, and make sure chest expansion is good. Now, in hospital, obviously you have equipment to deliver this oxygen. So how do you do that? As shown in the picture, you get the correct size ambu bag and a well-fitting mask. Attach the high flow oxygen, at least 10 to 15 liters of oxygen should be attached to this ambu bag, and the reservoir also should be there, which we will talk in detail in the next lecture. And then you deliver the ambu ventilation. Give at least 2 good breaths so that the child has 2 good chest expansions. Okay. Now, once you have achieved 2 good chest expansions, we have now completed A, opening the airway, B, checking the breathing and delivering oxygenated air by giving exhale breaths. Next, we move on to C, which is the circulation. Now, how do we check whether circulation is okay? That is by checking pulse. So in children less than 1 year, we check the pulse by feeling for the either the femoral or the brachial, because it's very difficult to palpate the carotids, as you know, the children are less than 1 year, they are quite chubby, they have a short neck, and therefore it's difficult to palpate the carotids. Okay, so children less than 1 year, femoral or brachial, and children over 1 year and adults, we do either of them, either femoral, brachial or carotid. You can use either of the 3, but you feel for the pulse only for 10 seconds. 10 seconds only you waste, okay? And if there's no pulse, slow pulse or no signs of circulation, then you have to start chest compressions. So what do we mean by no signs of life? No signs of life means when you gave exhale breaths or ambu ventilation, the child did not cough or gag, and he does not show any evidence of peripheral circulation like cold, clammy peripheries or cyanosis, and pulse. Obviously, if pulse is not palpable, you will start compressions. But if you are not very sure, look for the other things of no signs of life, no movement, no cough, no gag reflex, pale mottled color, then you immediately start chest compressions. So what is the landmark for giving the chest compressions? It is usually the lower half of the sternum. Okay, so lower half of the sternum, how do you get that landmark? So 1 centimeter above the zippy sternum is the easiest way. Infants, you can also get an idea of the lower half of the sternum by drawing an imaginary line between the 2 nipples and 1 centimeter below. Okay, but in bigger girls and young females, it's difficult to get the intermammary line. So you have to go 1 centimeter above the zippy sternum. So on the lower half of the sternum, that is where the chest compressions are given. So infants, you can use 2-finger technique or hand encircling method. As shown in the picture, you place 2 fingers on the lower half of the sternum. It should be at 90 degrees to the sternum, and compress that sternum at the chest 1/3 its depth. So if the chest is that deep depth, you have to compress 1/3 the depth. 1/3 of it should be pushed down. Okay. Or you can use this hand encircling method, that you encircle the child's chest with both your hands, and the thumb should be on the lower half of the sternum, pressing the sternum down. Okay. So you can use either 2-finger technique or hand encircling method. But if you are the only person to resuscitate this patient, you have to then use this method, because with your other hand, you are keeping it on the forehead, tilting the head back and keeping the airway open. So keep the airway open with one hand, and with your other hand only you are giving the chest compressions. But if you have more than one person in resus, then you can get one person to keep that airway open by doing a head tilt, chin lift or a jaw thrust, and you will be then giving the chest compressions using the 2-handed hand encircling method. Okay, if it is a bigger child, you can use a single hand or double-handed technique. Now, whatever, either you use one hand or both hands, only the ball of the hand should be on the sternum, only this part. And the fingers should be in the air. You can see the fingers are not touching the ribs, because then only if you put pressure with your fingers, the ribs will fracture. So keep the ball of your hand on the lower half of the sternum and compress that chest 1/3 of its depth. So whether you're going to use one hand or both hands, will depend on your build and the patient's build. If you are like a 6 feet tall person, well built, and you have a skinny child in front of you to resusc, then it's best that you use one hand. Because if you put force by using two hands, then soft tissue damage, fractures will occur. But if this doctor is very small made girl and the child is, let's say, a 10-year-old who's about 80 kilos, then it's very difficult to resuscitate with one hand. Then, of course, you have to use both hands. Okay? So you will be the judge to decide whether you're going to use one hand or both hands. Okay? But whatever it is, the finger should not touch the ribs. Another important thing is your elbow should be straight, as shown in this picture. The elbow should be straight and your weight should be on the patient. So in that case, you have to be at a higher level than the patient. So the short people will have to get on top of a stool or the bed and make sure your weight is on the patient and your elbows are straight. So how do you give that compression? And that is 15 to 2 for all children. That is 15 compressions to 2 breaths. So press 15 times and then stop and give 2 breaths. And the rate should be 100 per minute. So it should be faster than the second. Okay. So 100 per minute, 15 to 2 ratio. So that roughly takes about 6 cycles per minute if you are giving correctly. Always push hard, push fast. 1/3 the depth of the chest should be pressed. And do not forget to allow the recoil time. So once you press, take off your hand and quickly, so that the recoil will be there. The chest will recoil and blood will be sucked into the heart again. And when you push, the heart will be compressed between the sternum and the spine behind, and the blood in the heart will be pushed into the coronaries. Okay, it's very easy to understand. So now in hospital, we have a lot of equipments to keep the airway open. So once you do the head tilt, chin lift and jaw thrust, you suck out secretions and you put in the Dell's airway or oropharyngeal airway. Now this airway has to be a correct size, and we will show you in the next lecture how to get the correct size and how to insert the oropharyngeal airway. And then you give, so airway is open, then you give breaths using the bag and mask ventilation. And then you come to circulation. If the pulse is not there, you start chest compressions. Next, you attach the patient to the defibrillator. So A, B, C, and D is for defibrillator. So in cardiac resusc, we call it D for defibrillator. And if you don't have the big defibrillators, the little hospitals, the ambulances, and certain buildings in Colombo has this automatic external defibrillator, okay, which, as you can see in the picture, little box, and there are 2 pads which can be attached, one to the apex and one to the right side of the sternum. So if there is pediatric pads, attach the pediatric pads, but if not, then you will have to do with the adult pads. And this delivers a given amount of shock. You cannot dial according to the patient's weight. Normally we go 4 joules per kg. But in this case, you cannot dial like that. It just delivers a given amount. So once you attach the pads, you on this monitor by pressing that button, and it says stop compressions. Then you stop chest compressions, and then the machine decides whether it's a shockable rhythm or not. So VF or pulseless VT is shockable rhythms, and it says shock needed. And then it starts charging automatically, and you have to make sure everybody is clear, head end, middle end, lower end clear, and you're clear, and then discharge that button. By pressing that, you discharge the shock, and immediately you restart compression. And then the machine gives voice command every 15 seconds for 2 minutes. And then at the end of 2 minutes, it says stop compression. Then you stop compression and then the machine says whether shock is again needed or not. If shock is needed, then you have to deliver a shock. But if shock is not needed, then you have to check to see whether pulse is felt, and then auscultate for the heart sounds, and then you decide and then stop the compressions. But if pulse is not felt, then you have to manage as a asystole, okay, because it's not a shockable rhythm. Pulse is not there, so that means it's a asystole or pulseless electrical activity. So you have to then continue the chest compressions. You will get a good idea of that when we do the defibrillator, how to defibrillate a patient in our next lecture. Okay, so we talked about BLS and we continue chest compressions, how we insert oral airway, attaching the pads, starting the machine and following the voice command. Okay. All right. So remember, we should not stop compression for unwanted reasons, because if you stop compressions, the coronary pressure goes back to zero, and then you have to give several compressions to get that coronary pressure back to the same level it was before you stop the compression. So it is important you continue compressions and you stop compression only to check the rhythm and the same time the pulse. Okay, you cannot check the rhythm and the pulse when somebody is giving chest compressions. Understood? So the moment you get the correct idea on the defibrillator that pulse is not, the rhythm is whatever the rhythm is, then you immediately restart compressions. So we talked about approaching a child on DRS approach, and then we resuscitated the child on the A, B, C, and then D. So I went through all these steps and I hope you understood. So once the child recovers, if at the end of 1 minute, the child has recovered, then you turn this child to a left lateral position, which allows free drainage of secretions and gives you access to monitor this child, cardiac and respiratory functions till help arrives. Now, if nobody heard you initially when you shouted for help, then after 1 minute of resus, you stop and get help. So either you call with your mobile or you run to the closest place and get somebody to call an ambulance, and you come back and start the chest compressions and mouth to mouth outside of hospital. Okay. Now, if it is outside of hospital and you're resuscitating an infant who is less than 1 year, then you can carry this child in your hand, giving mouth to mouth and chest compressions, and you can go for help. Okay, so we did the basic life support, and next is we go for a choking child, which is again a very important component in this basic life support. Now, a choking child is often a normal child who did not have any cough or fever, who was eating some food or was playing with toys and suddenly found to be unresponsive and or is choking and having a stridor. Okay, so how do we then resuscitate this child? Always shout for help and then see if this child has effective coughing or not. So if the child has effective coughing, that means the child is conscious, and you simply encourage this child to cough. You say, Baba, cough as much as you can, and you encourage this child to cough and simply maintain the same position the child is in. Often these children are seated with the neck extended and coughing away. Do not make such a child to lie down just because you want the child to lie down, because that could dislodge that foreign body and cause a partially obstructed airway to be totally obstructed. So please do not change the position of the child. If the child is seated, take this child in the seated position in a vehicle to the closest hospital that has ENT support. Now, and encourage this child to cough. Now, if you find this child does not have effective coughing, he's tired and he's conscious, then you have to do the back blows and the chest thrust, which I will talk to you about. But if the child is unconscious, obviously he can't cough, he's unconscious, then you are doing the basic life support that we did. And we are hoping by giving that mouth-to-mouth ventilation or bag and mask ventilation, we are hoping that air will go between the foreign body and the airway. I'm sure there will be little spaces between the foreign body and the airway so that it will aerate the lungs. So you do the basic life support. Now, child who does not have effective coughing and is conscious, he's tired, he has a marked stridor, then you do the back blows and the chest thrust. So, and also it's important that you do not do a blind finger sweep just because you think there's a foreign body. You do not put your finger in and try to take off things that you cannot see, because your fingernail could damage the palate and that could cause bleeding. You always flash a torch or under direct vision, check to see whether foreign body is visible, and if it is there, you pick it up. We do not do Heimlich maneuver on children because the chest cavity is not formed to cover the liver and the spleen. Liver and spleen are abdominal organs in a child and is not covered by the chest cavity. So by giving excessive pressure on the upper abdomen, you can damage these organs. That's what we do in Heimlich maneuver, right? Okay. So what we do is the back blows and the chest thrust, and how we do it is as shown in the picture. If it is a little infant, you take the child across on your forearm and one finger should be on the chin, opening the mouth, and with your other hand, give 5 back blows between the scapula. So between the 2 scapula of the child, you give 5 back blows. It should be good back blows, okay? So that the foreign body will get dislodged and come into the mouth. Then you turn the child over, look into the mouth. If the foreign body is there, pick it up. If it is not, then you give the 5 chest thrusts. So lower half of the sternum, it is a forwardly directed blow towards the face. So it is basically should be a thrust, not the chest compressions that we do in basic life support. So 5 back blows, 5 chest thrusts, and you continue to do that until you bring this child to the closest hospital. But always check to see if the foreign body is there in the mouth and pick it up if it is seen. Now, if it is a big child, you can take this child across your lap. So you sit on a chair, put the child across your lap with the head down and give the back blows and do the chest thrust, okay? So I have come to the end of my lecture, BLS and choking child. So we talked about the DRS approach, danger, responsiveness, send for help. Then we do the ABCD approach in resus, that is A for airway, opening the airway using the head tilt, chin lift or jaw thrust. Then now that is outside of hospital. Inside, you can suck out secretions after you do the airway opening maneuvers and put in Gedel's airways. And next, check for breathing for 10 seconds. If the child is not breathing, outside of hospital, you give mouth to mouth. And inside hospital, you give bag and mask ventilation using high flow oxygen. And you look to see if there's 2 good chest expansions. If there's 2 good chest expansions, oxygen has gone into the lungs, and then you move on to C, that is you check for pulse and look for signs of circulation. And if it is not there, you start chest compressions on the lower half of the sternum at a rate of 100 per minute and a ratio of 15 to 2 compressions, and compressing 1/3 the depth of that chest, okay? Next, while chest compression and breathing is going on, you attach the patient to the defibrillator, attach the pads, and follow the voice command of an automatic external defibrillator. And always you have to stop compressions for the machine to detect the rhythm, okay, and immediately restart compressions. So follow the voice command and deliver the shock if necessary. And always check the pulse to see whether the child is in asystole. And if so, you have to start going on the pathway of asystole pathway. And if there's the machine says shock needed, that means a shockable pathway. Okay, so very easy. Next, we went on to the choking child. We shouted help, and we have to check whether effective coughing is there or not. And if there's no effective coughing and child unconscious, do BLS. And if there's ineffective coughing but child is conscious, do the back blows and the chest thrust. So that concludes my lecture. Any questions? I'm happy to answer quick questions for you. Anyone? Please, if you do have questions, talk to us and clarify your doubts, because no point going home with doubts in your mind. So always, if you have any questions, any queries, don't be shy. We are all here to learn. So please ask any questions you have. Any questions, children? No. Okay, so in that case, I will conclude my lecture and thank you for listening. And I invite the next lecturer to give the lecture on airway and breathing. Thank you.
Right. Thank you much, madam. That was Dr. Shamila Tissera, consultant senior pediatrician, on the detailed lecture on BLS. So thank you once again. If you all have any questions, please type on the chat box. Madam would answer in a few minutes time. So as madam said, we will go for the next lecture now.
Okay, I think we could be able to stop lecture until our next lecturer joins us. So we have a pre-recorded basic life support video that we did. So probably that will help you get an idea on how to do BLS. So till Dr. Amila joins us, we'll see that video. So I'm happy to answer questions, children, if you have any. Do you all have any questions? Remember, you all will be the first people to encounter a critical ill child. And if basic life support is needed, you're the one who will have to start the basic life support. So always, as we talked about, DRS, ABC approach, and then D. Okay, so that is why I keep asking, if you have questions, please clarify your doubts. Everybody is very silent. Dr. Srila, can we have that video, please?
Madam Sheila also is on another meeting. I think the college will share the video now. I think.
Okay. Okay, so somebody is asking whether they could access the BLS video later. Basically, you can go to our SLCP webpage, and there's like protocols and guidelines on that. There's a link. Always click on that link, and then there'll be a lot of pre-recorded lectures and algorithms on the SLCP website. And also you can access the apls.gov.au, that is Australia APLS website. And when you go there, there is again a lot of algorithms and videos that you all can watch. You don't have to be a member. You can click on it and all the algorithms and videos will be displayed. Okay. For those who do APLS, we do give password for the Heart Association website where there are a lot of videos and lectures. But for you all, the algorithms, the guidelines, everything available on SLCP website and the APLS, the Australia website. Okay. Nadishan, are you there? Okay, there's another question till the video comes up. They're asking if we don't have automatic defibrillator, can we use the usual defibrillator? Yes, that's what I said. In the bigger hospital, we have the main defibrillator. And then if you don't have that, use the automatic defibrillator. Okay. Yes, Nadisha. I think we can't hear.
Okay, madam.
The volume needs to be increased. Yes, Nadisha.
Madam, make maximum download මෙච්චරයි madam මේක මේ Google එකකින් play වෙන නිසා.
It's okay. You put the video. I will talk about it.
Okay madam.
Excuse me. If you could, before sharing the screen, if you could check for whether the sound share is activated, because that may be the reason.
Okay.
There, you have some help. Nadisha, check on that. Or else we can play the video and I can do the verbal stuff because I'm the one who's already talking in that. So,
Right. Okay, madam.
okay, Nadishan, can we have the video?
Yes, madam.
Okay, that's fine. If the volume doesn't come, I will talk because I did that video. So I should be able to talk to you all and talk you through the video. Okay, so there's this child arrested in a ward, and Dr. Srilal and Dr. Dhananjay will be resuscitating this child. And so let's see how they are resuscitating this child. Okay. So you can see Dr. Srilal is going, checking for danger. There's no danger. Next, he checks the responsiveness. He keeps one hand on the forehead and check to see whether the child is unresponsive. And then he says, call for help. And Dr. Dhananjay comes running as person contact first help. And then he opens the airway by doing the head tilt chin lift maneuver, and he's looking, look, listen and feel. He's looking towards the abdomen for chest and abdominal movements, and keeping the face over the child's face to look, listen and feel to see if the child is breathing for 10 seconds. And if the child is not breathing, then you could do the jaw thrust as well. So usually either head tilt chin lift or jaw thrust, and you look, listen and feel. And if the child is not breathing, in a hospital, we start bag and mask ventilation with the C grip and the E grip. So that is that you pull the jaw up with 3 fingers and then give 2 good breaths and then check pulse. So he's checking pulse in the carotid because it's a big child for 10 seconds. And then he realizes child does not have any palpable pulse, that child is in cardiac arrest. So therefore, he will be starting chest compressions. In the lower half of the sternum, you can see only the ball of the hand is on the lower half of the sternum, the fingers in the air, and elbow straight, and the weight is on the patient, and is compressing 1/3 the depth of that chest, and at rate of 100 per minute. And he's swapping with Dr. Dhananjay, and now Dr. Srilal is attaching the pads, one to the apex, one to the right side of the sternum, and then he will be owning the automatic external defibrillator, and it will give the voice command, and it will say stop compression. So that's what he's doing, stop compressions, and allowing the monitor to decide whether it's a shockable rhythm or not. So it says shock needed. So he makes sure nobody is touching the patient, and then he will soon deliver that shock. You can see that flashing red button that he presses and delivers the shock, and immediately restart compression, which is very important, and then starts putting a Goodell's airway and keeping that airway open and starts moving. So 15 compressions to 2 breaths. Okay. So we have to do that for 2 minutes. Continue to do for 2 minutes. So while doing that, we can look for the 4 H's and the 4 T's in hospital. So H, hypoxia, hypovolemia, and then hypothermia, and then the electrolyte imbalances, hyponatremia, hypokalemia, hypoglycemia. So all the hypos. And what are the 4 T's? Tension pneumothorax, cardiac tamponade, toxins, and thromboembolites. So look for reversible causes and revert the reversible causes. And also somebody should withdraw adrenaline into a syringe. So 1 in 10,000, 0.1 ml per kg, and should have a flush ready. Okay, so that's in hospital. But outside of hospital, of course, we do the BLS, just giving mouth to mouth and chest compressions. Okay, so 2 minutes of BLS is being continued, as you can see. So in hospital, usually it's a team, no, not 2 people. There'll be a lot of people there to help. So one will be getting the drugs ready and everything ready for intubation if needed. So it's a teamwork in hospital. So you can see Dr. Srilal is holding on to the mask with a double-handed jaw thrust. Okay, and now again he says stop compression, and the defibrillator decides whether still it's a shockable rhythm or not. And it says shock not needed. So that means there is no shockable rhythm, and therefore he will now check pulse to see whether pulse is there. If pulse is felt and breathing, he is checking. If pulse is there, that means heart has come back to normal. If pulse is not felt, that means it's a asystole or pulseless electrical activity, and child will then need the asystolic algorithm. So now child has recovered, and therefore he has breathing and his pulse and circulation is good. So we have put the child onto left lateral position to allow free drainage of secretions and continue the monitoring till help arrives. Okay. So one person is asking whether we continue CPR for 20 minutes like in adults, if there is asystole, and we stop CPR at the end of 20 minutes. So yes, we research for 20 minutes, but make sure we have done everything correct, A, B, C, D, and all the reversible causes are looked into, and we have attended to it. We have intubated, we have done everything, but still the child is not recovering after 20 minutes. Yes, then like adults, we decide to stop the resource. But we have to do everything which can be done to as reversible causes. So check the electrolytes, the sugar, give fluid boluses, intubate, and do everything. Okay. Right. Okay, Nadishan, can we take off that video? And is Dr. Amila around?
Hello, I'm there.
Amila, are you
Yes,
there?
madam.
Okay.
I'm there.
Good morning, Amila. Welcome, and over to you.
Right. Thank you. That was a real good demonstration, Shamla, and the team.
You're welcome. Thanks.
Hello. Hello.
Yes, Amila, we can hear you.
Can you see the slides now?
No, really. You need to share the slides.
Okay.
Can you share it? Have you been put on sharing? Nadishan, can you please put Amila on sharing?
Yes, madam. Amila sir can share, madam. He's
Okay, Amila, you can share now.
Right. Can you see the slides now?
I think, yeah. Not yet. Yes, now we can see it.
Yes, sir.
Right. Hello, good morning. I'm Amila De Silva. I'm consultant pediatrician at District General Hospital, Ambulapitiya. And today I'm going to discuss about some important points about airway management in children. Can you all hear me now?
Yes,
Hello.
Amila, we can
Yes,
hear
sir, we
you.
can hear you.
Okay. So going through the objectives.
Can you put it on? I think you have clicked it, but it's not still on PowerPoint.
Yeah. So objectives for this lecture are to understand the structured approach to airway and breathing in critically ill children, and then to learn what equipment we need to achieve.
Dr. Amila, sir, just if you could go back, press escape on your keyboard, and then you can see enable editing on the top of the screen. When you exit from the full screen presentation.
Okay.
Yeah, could you click on enable editing? Then when you okay it, you can everybody will be able to see it in full screen. Yeah, and now try to put it on slide share mode.
Right. It's all right now.
I'll give it a minute, sir.
I'm glad we have an IT expert with us. Thank you for your help.
Is it all right now?
It's still kind of processing, but we can see your objective slide, Damila. So
Okay,
you can
right, yeah.
continue
So,
on the
so we were
structured
going
approach.
through that we need to know what equipment we need to use to achieve a successful airway management, and then to learn how to use each of these equipment properly. So in managing the airway in critically ill children, first we will go through some of the basic manuals. So these are what we usually need to do first, and then we will learn the use of airway adjuncts in case our basic manuals do not work well. And then following that, we will see what are the important steps in intubating a child, and then we will discuss options in case of a failed intubation. So you can see that we go through an orderly process, and then we will follow each of these steps. We need to remember that sometimes we might not have access to the hi-fi gadgets immediately, but simple techniques are often quite effective and life-saving. And always remember a gastric tube, because when we are especially doing ambo ventilation, we might distend the abdomen with gas. So putting a gastric tube and decompress that distended abdomen is quite important. And putting a gastric tube will also sometimes help us with intubation as well, because it will tell us where the esophagus is and where the larynx is. Okay, so when managing the airway in critically ill children, we need to consider the anatomic differences between a child and an adult. Especially child below 1 year has significant anatomical differences. First is that they have a very large occiput, so that neck will get flexed and can cause airway obstruction. So in order to overcome this, especially in children below 2 years of age, we can keep a shoulder roll and lift the shoulders a little bit up, and this will prevent the neck flexion and then obstruction of the airway. Then we need to remember, children, they have a comparatively large tongue compared with their oral cavity, and then which will fall back, especially when they are unconscious, and then cause airway obstruction. Also, the anatomical position of the larynx is different in a child. The larynx is placed at a more higher and then in an anterior position. So during intubation, visualizing the larynx can be difficult. So here, a procedure called cricoid pressure will help to bring the larynx into our view, which will help with intubation. And then children, they have a long floppy epiglottis as well. So this will make the use of certain, will help some, we need to make some adjustments in our intubating equipment. For example, we need to use a direct blade or straight blade laryngoscope, because we need to catch this floppy epiglottis and lift it up. We will go through this in more detail. Yeah, and then in managing airway in children, it is important to know the exact position.
Amila, can you please forward the slides, please? We are still at the objective slide.
Okay.
Your computer is still kind of slow, I think. They are processing around Rauma Peno.
I'm sorry about
that. Can you manually forward the slides?
Sir, if you could go back on the screen and do not need to put it on presenter mode, so just the slides are visible on your normals.
All right, that's fine.
Okay.
If you keep it that way, that's fine.
Yeah.
Can you see the correct slide now?
Yeah, airway position. Yes.
Okay. I'm sorry about this.
I think your network is kind of slow.
So we were going about the airway. Yeah, sorry about this. Can you see now the correct slide?
Yes, Amila, we can.
All right, okay. So I'll keep it like this for the time being. We were going about the airway positioning. So it is very important to get the correct position. So you can see in a baby less than 1 year, so that is in an infant, we need to keep the baby's head in what is called the neutral position, because too much flexion and too much extension either way can cause obstruction of the baby's airway. So this neutral position means that we need to do this procedure called head tilting and chin lifting and keep the baby's face parallel to the ceiling. So that is called the neutral position. And in children more than 1 year of age, we can do the head tilt and chin lift and keep the baby's head in the sniffing position. So this will help to open up the airway. Right. So, so the basic airway maneuvers are shown in these pictures. The first is the head tilt and the chin lift. When you apply a slight pressure on the forehead and at the same time do a little bit of neck extension, doing the chin lift, this will open up the airway. And the second picture shows the procedure for a jaw thrust. Here, what you do is you use your hands and lift up the jaw of the child. So by doing this, we will move the tongue out of the airway and make the airway open. So the second technique called the jaw thrust is especially very important when we suspect a cervical spinal injury in a trauma patient, because there, if we do some neck flexion, this might make a cervical spinal injury worse. So in that instance, this jaw thrust maneuver will be very important to prevent any further damage to the cervical spine and at the same time to help to open up and visualize the airway. Right. So next, we need to use airway adjuncts when simple airway maneuvers cannot maintain open airway. First, we will discuss about the oropharyngeal airway, or is also called the Gödel airway. Before using this, the proper size of the oropharyngeal airway should be decided. In this child, so here it is demonstrated. So we measure the size from the center of the mouth to angle of jaw. And then when inserting, we will depress the tongue. So usually we can either use a tongue depressor, or sometimes we can also use a laryngoscope blade for this, because sometimes children will be clenching their teeth and we need some support to open up the airway. So once we have depressed the tongue and open up the airway, then we can push this oropharyngeal airway in the same position or in the same direction along the roof of the mouth. We don't try to rotate it because in small babies, this might cause some damage to their teeth, and also their oral mucosa is quite friable. So this can cause bleeding, and bleeding can further make obstruction of the airway, and then it will also make the visualization of the airway also quite difficult. Sometimes putting this oral pharyngeal airway will be difficult if the patient is having a very intact gag reflex. So then we might need to decide on a different technique if the patient does not tolerate the oropharyngeal airway. Right. So next, another adjunct that we can use is the nasopharyngeal airway. So again, the size of the nasopharyngeal airway needs to be decided. So the size, so the length is from the lateral edge of the nostril to the tragus of the ear. The diameter is either the little finger of the patient or just the one that fits the nostril without making it quite blanched and obstructing the nasal passage. So, so once we have identified the correct size, then we need to lubricate using some gel, and then gradually push this inwards. We need to direct it posteriorly rather than upwards. And with the gentle rotating movement, we can push this inside. So again, a word of caution is this might not be useful if we are suspecting a base of the skull fracture, because it can cause further injury in that kind of a scenario. Right. So in managing a critically ill child, providing adequate oxygenation is very important. When available, we need to provide the highest oxygen concentration to the child to prevent hypoxic injury. So usually this is around 10 to 15 liters of oxygen per minute. So in a critically ill child, don't be afraid to use higher concentrations and then give the best possible oxygen flow available. So oxygenation can be done using several types of masks. So as shown in this picture, a Venturi mask can be used, and there we can give a fixed FiO2, or we can use any type of mask, and especially a mask with a reservoir will be able to provide higher concentrations of oxygen, especially it will reach nearly 100%. And then for small babies, especially below 2 years of age, nasal prawns can also be used. This is a low flow oxygen device. So it might also be useful when we are weaning off from oxygen as well. But for a smaller baby, we can try with the nasal prawns first. And then oxygenation of the neonate. So here we are seeing some more devices to provide oxygenation. So oxygenation of a neonate can be done by using the NeoPuff device. So you might have seen this during your ward rounds, and then during when you are, if you had the chance to resuscitate a newborn baby in the theater or the labor room. So this is a quite handy one and a portable oxygenation device. And this is air driven, so you don't need any electricity to run this machine. And this is quite useful because you can use this while transporting a baby as well. For example, if you are carrying the baby to a procedure, or if you are transporting the baby in an ambulance, this is quite useful as well. And then here, so you can provide oxygenation, and the inflation pressure and a PEEP end expiratory pressure can be given. And then these pressures can be adjusted to provide adequate oxygenation. And then what you can see in the next two pictures are a Cpap device and a BiPAP machine. So these machines are also available in some centers. So the advantage here is that when giving Cpap or BiPAP, you can change the oxygen concentration as desired as well, because these machines also have an air oxygen blender, and then we can adjust the appropriate FiO2 that we can deliver to a patient. And then the oxygen, the oxygenated air that is given to the patient is also getting warmed and humidified. So that is also an advantage. And then, before you, and then, and then one of the most important aspects of airway management in a critically ill child is bag and mask ventilation. So this is a very important skill that everyone involved in emergency pediatrics needs to know, because this simple method can be quite effective and life-saving. So as shown in this picture, various sizes of amber bags are available depending on the child that we are managing. For a newborn or the preterm baby, there's a low tidal volume, which is around 250 milliliters amber bag available. And then generally the one that we use for children is 500 milliliters, the one in the middle, or in a adolescent or a big child, you can use the adult one, which is around 1500 milliliters. So there are different ambu bags available according to the weight and size of the child. And then you can also see a TP device as well. Generally, this is used by the anesthetist on giving general anesthesia. And then when providing bag wall mask ventilation, the correct size mask should be chosen beforehand. The correct size mask should cover both the nostrils and the mouth, and then it should not leak. So for this, it should not go beyond the chin because otherwise it will leak. And then it should not press on the eyes as well, because then it can cause some pressure damage to the eyes. So we need to use the correct size, which will not leak and which will also not cause pressure damage to the baby. So one thing that we need to remember when using the mask is, most of the time in our hurry and excitement, we will try to fix this mask to the ambu bag while keeping the mask on the face of the baby. So this is not recommended. We should first select the correct size and then attach it away from the baby's face, and then after that only keep it on the baby's face. I hope you are clear about that. And then positioning of the mask is also very important. So this positioning of the mask should be done using the C and E technique. So in what you do here is, as you said, you can see in the picture, your thumb and index finger will encircle the mask, while rest of the fingers maintain an open airway. So it is important to keep the fingers at the border of the mandible and should not compress on the soft tissues, because then it will cause airway obstruction. By using this technique, we are able to effectively ventilate the child. So the C is that using your thumb and the index finger, that is the C, and the E, as you can see in the picture, will support the chin and lift the chin up. Right. And then we should also know that we can provide effective ventilation. In order to do that, we should observe for the chest rise as well, because only by observing chest rise, only that after that, if you are giving adequate and effective ventilation, we should be able to see a chest rise. So now you can see that this person is looking at the chest and see if the chest is going up or down. So as you can see in this picture, bag and wall mask ventilation can be provided by a single person or by two people. Single person technique is more difficult and can be less effective because when one person is doing it for a long time, the provider will get very tired. Two-person technique is more effective. So there, one person will hold the mask. So in this C&E technique, using both hands, and then we'll make sure that the airway position is maintained and it is adequately sealed. And the second person will provide ambu ventilation. So this is more effective rather than the single person technique. So before you attempt intubation, so what is called the rapid sequence intubation, you should first get all the equipment ready, and then it is very important to pre-oxygenate the child. using 100% oxygen for 3 to 5 seconds. So attach the pulse oximeter and then so this will show us whether our oxygenation has become effective. So and then we need to use these techniques. So we need to keep the drugs ready, and then we need to have our team ready, organized, where the people have different roles, and then we should have a backup plan if ventilation becomes if we fail the ventilation. So so we'll go through this rapid sequence intubation. So we were telling about the pre-oxygenation. So here we can see that the person responsible for the airway is providing pre-oxygenation for the child, and then so this should be done for few seconds, for 3 to 5 minutes, till we get the saturation up in the baby. So this is very important to prevent any hypoxic damage during our intubation attempt. Right. So so then the nurse who is involved in getting the IV access and preparing the ducts during this rapid sequence intubation should make sure that a sedative drug and then the induction agent or the muscle relaxant and the other drugs that might become useful for any resuscitation during this procedure. For example, keeping the adrenaline drawn up and ready. And then sometimes fluids might also be important, because patient might need a fluid bolus. So depending on the fluid status of the patient. So sometimes we might be handling with the patient who is normotensive, or the patient may be hypotensive, and sometimes we might get a patient with asthma. So that is a patient with a bronchoconstriction. So the drugs we might need to use during each of these instances might be different. For example, in a patient who is having hypotension and bronchoconstriction, we might need to use a induction agent such as ketamine, and then use suxamethonium for muscle relaxation. So depending on the scenario, the drugs that need to be used can differ. And then the second nurse who is involved in managing equipment during the rapid sequence intubation should make sure that the requirement monitors and all the equipments are ready beforehand. So first, we should have a working multi-monitor and then a correct size pulse oximeter attached. And then we should have the working laryngoscope with different blade sizes. So here we can see the straight blade and the curved blade. So straight blade is usually helpful for younger children. As I mentioned, they have a very long and floppy epiglottis which can cover their airways. So we need to lift this up. In order to do that, we need a straight blade laryngoscope, and then we need to use different sizes of ET tubes, and then we need to use a functioning suction machine, sucker machine, and then also different sizes of sucker tubes. And so these equipment are shown in this picture. And then when selecting the correct ET tube size, we can use this equation, which is H divided 4 by 4. This equation will give the internal diameter in millimeters of the ET tube size, ET tube that we need to use. For example, in a 4-year-old child, so H is 4 divided by 4 plus 4, that is 1 plus 4 is 5. So, and for a cuffed ET tube, there's another equation. And then we also need to have a general idea what are the sizes that we use. For example, in a term infant, it is about 3.5 millimeters. In a preterm baby, it will be around 2.5 millimeters. And for around a 1-year-old, it will be around 4 millimeters. But having said that, we calculate it, and always we need to have a one size above and one size below. Now, for example, for this 4-year-old, we should keep a 3.5 and also a 4.5 available, because we don't know until we go and intubate, there are anatomical differences. So we need to have several sizes available. And then on calculating the ET tube length, it is age divided by 2 plus 12 centimeters. So, this end of this length should be from the lip level. So that is what we call the lip level. Again, on deciding this length, we need to use other techniques such as to see the chest expansion and then listen to the air entry as well, because sometimes the calculations might be different from what we actually get in the patient due to the anatomical differences. Right. So, and then, now we see the steps in the intubation. First of all, we need to take the laryngoscope in our left hand, and then we insert it and then try to push the tag to the left side. Sometimes in small babies, you might need to just introduce the blade in the central position, and then what you do is you gradually insert it till you are able to visualize the epiglottis and the vocal cords. And then, as I mentioned, due to the larynx is anterior and higher, sometimes a helper assistant will need to keep the cricoid pressure to bring down the larynx, and then for us to visualize it. So you gradually introduce it inside, and then the assistant gives cricoid pressure, and then as shown in the pictures, we will be able to visualize the vocal cord. Sometimes the epiglottis will be covering this, so we need to then catch hold of the epiglottis and lift it up. Here we should not, this will be demonstrated in your skill station, so we should not leverage, we should just try to lift the epiglottis up. So once we get a good view of the vocal cords, then we are ready to intubate. And then we should also have the pulse oximeter, and then if possible also need to have the entitled carbon dioxide available, because this will tell us have we been able to successfully intubate the patient, or have we done a esophageal intubation. So if it is available, this is quite useful as well. So this is a mnemonic for intubation, which is SOAP-ME. The S stands for suction. So we need to have a working suction catheter ready, and then as we mentioned, O stands for oxygenation. So begin pre-oxygenation, and also, if available, make sure that you have the entitled carbon dioxide available as well. And then sometimes we might not be able to open up the airway, so and pre-oxygenate well. So then consider having the adjuncts as well. For example, the oropharyngeal and laryngeal mask air, which we'll discuss again in this lecture. And then proper positioning is important. So you should keep the patient's head height, and then place the older child in the sniffing position, and then the infant's head in the neutral position, and then keeping all the drugs ready, as we mentioned, a sedative agent and the induction agent and the muscle relaxant available, and any drugs that we need for resuscitation, and have all the equipment ready, the saturation, heart rate, that's our multi-monitor, the blood pressure device, and the entitled carbon dioxide if available. And then finally, the E stands for escape plan. And the endotracheal tube. So we might have a failed intubation attempt. So then we should be ready. Okay, what are we going to do if we do not succeed. So that is the escape plan. And then we should have several different sizes of endotracheal tubes. So then after we have successfully intubated the child, we need to check the position of the, or we need to confirm the position of the our tube clinically. So as I mentioned previously as well, so we need to look at the chest expansion, whether the both sides of the chest are moving equally, and then auscultate over the anterior chest and the axillary region on both sides to see, okay, have we gone too much to one side, or is the tube in the adequate equal position? And then also we should listen over the stomach as well to see, okay, have we gone into the stomach? And then if we have successfully intubated, then the saturation will start to rise and the color of the child should also improve. And after confirming the size, then we are able to generally hear a small leak on either side of the neck. So usually in an uncuffed tube, we can check for this leak. And in a cuffed tube, we should make sure that the cuff is not overinflated, because then it can cause pressure necrosis to the that laryngeal tracheal region. So we can confirm whether we have been successful by using the entitled carbon dioxide, which will show a particular type of a wave. And once we are sure that we are in the correct position, then we secure the tube very well. And then to confirm the tube length and the position, we should do a chest X-ray. Usually, the tip of the ET tube should be above the carinal angle, and it is usually placed in the T2 to T3 thoracic levels. So again, the most important thing is oxygenation to prevent any hypoxic damage during our procedure. So before the intubation, there is pre-oxygenation, and if we fail the intubation, again we need to, without rushing to intubate again, we should oxygenate the child and make sure the child does not get any intubation, any hypoxic damage. Yeah, and then so this picture shows a nasal intubation. So usually the size for the nasal endotracheal tube is one size below the our calculated one if we are going to do it endotracheally. That is through the mouth, it is one size below. So there are some special reinforced ET tubes available, and it might be useful in certain special instances. And then when we are doing again, we lubricate and then keep the head in the correct position, and then advance it gradually below through the nasal cavity while visualizing with the laryngoscope. And then we might need to use a Magill forceps to introduce this ET tube tip below the vocal cords. So this is shown in this picture. And then, so as the team leader, we always need to have a backup plan for failed intubation. So now if the most experienced person in the team has failed twice, then we need to think about the options available. So don't panic. If you have a failed intubation, do not stop oxygenation. So use the bag and valve mask and try to oxygenate the child. Get help. There may be more senior people, for example, the anesthetic team who are more experienced in managing the airways, and then the emergency pediatric team, they will be able to help. And then while the help is on the way, we should try to oxygenate the patient, and then we can at this point, think of using airway agents. For example, laryngeal mask airway as well. So then these are the other options. So these are usually for more experienced people, where a person will be able to put a bougie and then railroad the endotracheal tube, or use gadgets like video laryngoscope. But these are for more experienced people who have used it. And then finally, if our attempts fail at each of these, then the final option is to have a surgical airway. So this picture shows the algorithm for a rapid sequence intubation. So now, we do the rapid sequence intubation, and so we can visualize the vocal cords very well. So we do the laryngoscopy and intubation, we succeed. And then, then we confirm the position and then go on ventilating the patient. Now, then we try to intubate, and then we fail, and then we call for help. So while help is on the way, we try to do the bag valve mask ventilation. So are we able to manually ventilate? So if we can ventilate the patient, then what we can do is we can reposition the patient and do one more direct laryngoscopy attempt. And then if we succeed, then we confirm the position and keep on ventilating the patient. So if we are able to manually ventilate, but when we do the reattempt, we fail. So then we can maintain the ventilation till we get the help available. Or either, so if it is, for example, in a for some surgical procedure, we can awake the patient or go for advanced airway techniques when the help is available. Now we are not able to manually ventilate this child. So what are we going to do at this level? So here, now if you are unable to manually ventilate, we can try the laryngeal mask airway. We'll show how to do this in the next slides. So we insert the laryngeal mask airway and then we succeed. We are able to ventilate the patient. Right, okay. So then we maintain the ventilation and wait till the help is available. Now we put the laryngeal mask airway, but still we are unable to ventilate the patient. There's no chest rise, and then the patient does not have improvement in the oxygen saturation. The airway is not opened up. So in this kind of scenario where we cannot intubate, we cannot oxygenate, then we need to go for the surgical airway. So this is our algorithm for intubation. Now, this picture shows the vortex. Now, which say you need to perform at least 3 attempts in all non-surgical airway procedures. That is bag valve, mask ventilation, and then supraglottic airway such as laryngeal mask airway, and then endotracheal intubation. So we should have 3 attempts in all of these non-surgical airway procedures before we consider a surgical airway, and at least 1 attempt should be by the most senior and experienced clinician around. So this is the vortex for airway management. So the laryngeal mask airway can be used in instances where we cannot intubate the patient. We can, this is a very useful technique, instrument, which we can use until we get experienced help available to oxygenate and ventilate the patient. So what we do here is, again, we need to use the correct size. So there are several sizes available. So this is usually according to the weight of the child. So if we know the weight, then we are able to use the appropriate size. So here we can see different sizes. So it has a initial the tube part, and then a cuff, rubber cuff, and then there's a small introducer of air to inflate this cuff. So this shows how we insert or the laryngeal mask airway. So before we insert it, we deflate the cuff a little bit and then apply some gel and lubricate it, and then holding the laryngeal mask airway. So usually we can keep our index finger on the side of the inside, and the thumb it will hold the endotracheal tube. So what we do is we gently push, open up the mouth and keep the head in the proper position, and then we gradually push it down the center of the palate. We do not rotate, we just push it down till we can get a slight of a giveaway. So then we know that we may be in the correct position in the supraglottic region, and then what we do is we inflate the cuff a little bit, and then if the patient, so we can attach the if we have a T-piece device, we can attach it and see if the bag is moving, or we can feel over the endotracheal, sorry, the laryngeal mask airway tube opening and see whether we can feel any air flowing through and the patient is able to breathe. So, so this is a very useful technique if we are unable to intubate a patient, and this will help us to provide oxygenation till more experienced help is available. Right, so these steps show the procedure, and then so sometimes these are hi-fi gadgets in the scenario where we can't intubate and can't oxygenate. So there are some devices, usually these are not available, for example called iGel, Fast Track, Air Track. So here they might help to place the endotracheal tube as well, but usually these are not available in our scenarios. But we should not worry. By using the previous techniques that we described, we are most of the time able to oxygenate the patient. So finally, and then as you see in this picture, and then when you are placed in the can't intubate and can't ventilate situation, to save the life of the patient, we should then attempt the surgical airway. So this should be done by the surgical team because they are the most experienced people to perform this procedure. But if you are placed in a situation where no surgical help is available and then the patient is going to die anyway, then we should be able to do it. So we have to previously think about this procedure, and then should have practiced this. So how to do this procedure in case of a dire emergency. So attending for APLS course is quite useful because it will have a station on how to achieve this surgical airway. And then finally, coming to the summary. So one of the most important thing is bag and mask ventilation, which is quite effective and then life-saving. And intubation, also we need to know, but intubation is a skill that require a lot of practicing, and then it needs some time and practice to acquire the skill of proper intubation. But bag and mask ventilation, usually the equipment is quite readily available, and if we understand the principles and if we know the how to use it properly, it is a quite useful one. And then we should never hesitate to call for help, should not waste time. And there are a lot of other experienced people who are there in the hospital to help us. Maybe some senior doctors of the same unit or some senior nurses who are quite thorough with this resuscitation, and then we have our anesthetic and the emergency pediatric team. So never hesitate to call for help, and always we should have a plan in case of failed intubation. So if a patient is deteriorating, in a critically ill patient, if the patient is getting exhausted, and if we know that patient is airways not open, don't be afraid to assist in these procedures, and then don't be afraid to ventilate the patient, because waiting will cause hypoptic damage for the patient. And then always monitor for the effectiveness. So we can do this using the various techniques such as saturation, the chest expansion, air entry, and all the procedures that we discussed. So I have come to the end of our presentation. I don't know whether there is any time for any questions. Thank you. Hello. Hello.
share වෙන්න දාලා මේක කරගන්න. Okay, share වෙලා තියෙනවා. share වෙලා තියෙනවා. මේ සාර ක්‍රොමැටික් එක. මොකද? ක්‍රොමැටික් එක තමයි ඔපරේටර්. මේ share එක මෙතන වෙන්නේ. close කරලා. Yeah, that's right. Good morning, everybody. Hope you all can hear me. Thank you, Dr. Amila, for your presentation. So we are going to moving forward with the next session. So if you have any questions, put in the chat box at the end, that we will answer all the questions. Whatever the questions regarding to we will the next lecture. So the next lecture will be cardiac arrest. So I'm Pradeep Nawal-Surya, one of the intensivists in Laryngeal Hospital. So we are going to, for the next 20 minutes or 30 minutes or so, we are going to discuss about rhythms in cardiac arrest. So, yeah, when it comes to cardiac arrest, the main problem is that, like, as a house visitors, you guys will be in the ward. Most of the time the arrest occurs in the night time, so you are the only person who will be in the floor who have to manage that patient who is in arrest. So what you will do and how you're going to safely resuscitate the patient when it comes to the shockable and non-shockable rhythms. So you have learned the BLS, the basic life support, and how to stabilize the airway from the next section. Now from there we will take it on for the cardiac arrest. So just a quick recap. So DRS ABCD approach for the any arrest child. So the DRS means the dangers. So you are taken away from the danger. So usually if you're in a hospital, assume that there is a place is a safe place. And then you have to assess the patient is responsive. So you check the response if the patient is having any signs of life. And then the moment you say that, you immediately send for help. Then we learned about the airway opening maneuvers in the previous one. So immediately open up the airway and start the 2 rescue breaths, and you are going to start the CPR from there. So we will see one by one. The aim in the cardiac arrest is to identify which part of the process I am in, whether I am in a shockable rhythm or non-shockable rhythm. That is really important to identify which rhythm. So to identify the rhythm, you must connect to the monitor. So we will see one by one. So this is a overall picture how we are going to approach to it. So at the end that we will summarize. So this is a summary slide. So when it comes to the cardiac arrest, we have two main categories of rhythms. So which is shockable and not shockable rhythms. And one is non-shockable rhythms are asystole and pulsus electrical activity, and shockable rhythms are ventricular fibrillation and pulsus VT. So why we need to differentiate is mainly because that it's totally different in terms of management. So remember, when you have a patient who is having no signs of life, you start the resuscitation, and the next step is to identify which rhythm you are on. So your main goal is to continue to give the chest compression and the breathing in view of maintaining the oxygenation and the perfusion. So we will look one by one. So in a patient who is already, imagine you are in a ward, so where there's a child is suddenly arrested and you connect to the monitor. So where that you find the child is having a pulsus electrical activity or asystole, what you need to do, you need to continue the CPR. So CPR is 2 breaths to 15 chest compressions. You need to continue. And basically you have to give adrenaline every second loop. That means 1 loop is equal to 2 minutes. Every 4 minutes, you have to repeat the adrenaline. So we will look at the doses of the adrenaline in the next couple of slides. First thing, how are you going to give the CPR? You already learned about the CPR in the BLS lecture. Just a recap. So you need to give the breath, 2 rescue breaths while maintaining the while opening up the airway, and then you have to check the pulse. So where do you check the pulse? We already discussed. So one is in the carotid or the femoral in a bigger child, and the infants or neonates, you have to check in the brachial pulse or the femoral pulse, because carotid is very difficult to feel in a young age, especially the infants or neonates. So if the heart rate is less or there is no pulse and there is no signs of life, you have to immediately start the CPR. So same times the other picture shows that you are looking for a opening up the airway and looking for the signs of breathing. So immediately you have to start the CPR. So if you have a bag, so ambu bag, so if it's outside the hospital that you give mouth to mouth, but here that now that you are going to do is you have a advanced setting. So you have a mask and the bag, so bag valve. So you have to give the 2 rescue breaths to that. And what's really important to observe is that with that particular respiratory support, whether you have adequate chest drive to that, then you need to do the chest compression. So chest compression is you need to keep your hand just the lower half of the sternum. And it's really important to give a compression at least 1/3 of the chest diameter have to go in. Equally, you have to relaxation, because when you are relaxing only, the perfusion goes to the coronaries. And the elbows, you have to keep it straight. So, and also you have to achieve the rate of 100 to 120 per minute. So most of us, when we are giving a chest compression, we are not aware what rate we are giving. So make sure you have to have an intrinsic rhythm. Whenever you are giving a chest compression, if you connect the monitors will give you some idea what is the rate you are giving. Or you can have an intrinsic rhythms with the beats. So at least to reach about 100 to 120 per minute. So that means so at least 2, so close to 2 chest compressions per seconds you have to give. So it's really fast when you're giving the pediatric chest compression. So where to keep the hand? So lower half of the sternum. How we are going to keep the hand is basically either you can use a one-handed technique or a double-handed technique. So the prime factor here is that you have to keep your elbow straight and move with the shoulders rather than bending the knee, elbow and doing it, because it's really important. Otherwise, your force is not going to be enough to resuscitate, especially when you are resuscitating a bigger. And in a bigger kids that you can, smaller kids, you can use the 2-finger breaths or encircling breath methods as well. So now you have started the CPR, and the next thing is you need to know which rhythm you are dealing with. For that, you need to connect to the monitor. So you have a monitor in the screen, like in the board side, that you can connect that monitor. But it is preferable if you have a defibrillator, always connect it with a defibrillator, because if the patient is in shockable rhythm, you don't need to do it again, the connection with the defibrillator machine. So if the defibrillator in a ward, any arrest, always connect to the defibrillator and then assess the rhythm. That is really important. If you don't have a defibrillator, then go for your normal monitor to connect it. So then what you assess is what is the underlying rhythm is. So what is you can see in the screen is a flat line. So normal ECG, as you can see in the other one, so where that you can see on there is a QRS P wave followed by the QRS complex, that is a sinus rhythm. But when it comes to the asystole, there's just a flat line. There is no electrical activity which is in the heart. So in order to identify the rhythm, what you need to do, you need to stop the chest compression to identify the rhythm. So why we need to stop the chest compression is, if you are continuing the chest compression, what's going to happen? The artifacts will come as and mimics with maybe a VT or a VF-like picture, but actual rhythm may be a flat line asystole. So always stop the CPR and then assess for the rhythm. So immediately you identify the rhythm as an asystole, you need to recommence the CPR at the rate of 1:15:2. So now you identify the rhythm. What is the next step you need to do? You need to get an IV access, because what's the next part in the algorithm? You need to give the adrenaline. So it's real challenge in an arrest child to get an IV access. So immediately you try to get an IV access. So if you are successful in IV access, then the blood sugars, electrolytes, if possible, send a blood gas, and the full blood count and CRP if possible. Give the priority to the blood sugar and the blood gas if possible. If you are not successful in the IV access, more than 2 attempts, don't waste your time by attempting again and again. You never get the IV access in an arrest child more than 2 attempts. So make sure you just quickly go for an intraosseous line. So if you don't have a proper intraosseous line, you can use the wide bore needle, the one we are using it for taking the blood donations. You can use that needle. That's the biggest needle that we have. That's you can place it in the just medial aspect of the tibia. That's a very safe and easier way to get an IV access in an arrest child. So you need to prepare the adrenaline. If already the IV access is there, you can give the adrenaline 0.1 ml per kg, 1 in 10,000 dilution, followed by the flush. So what I mean by 1 in 10,000 dilution, 0.1 ml per kg. So usually the usual resuscitation dose of adrenaline is 10 mics per kg. So usually when you have a vial, that vial comes in 1 ml. So you have to dilute to the 10 ml. So usual concentration is 1 in 1,000 dilution in the vial, in the undiluted vial. When you take that vial and dilute up to 10 times, that will become 1 in 10,000. So in an emergency, you take the new vial, dilute up to 10 and give the 0.1 ml per kg. That will do for an exact dose. So basically, if you are already there, that you can give the adrenaline and you can continue the CPR for the next 2 minutes. So next adrenaline is not going to be due for the next 4 minutes. So during those period, what you need to do, you need to continue the CPR, and every 2 minutes you are going to assess the rhythm. So during this, we need to assess what causes the cardiac arrest. What are the common causes of cardiac arrest in pediatrics? The airway and breathing is the prime important factors or causative reasons for the cardiac arrest. So always look for the hypoxia as a cause. So make sure that the oxygen source is connected, you are achieving adequate chest expansion, your air entry is good. So that means you are adequately oxygenated. And hypovolemia is possible, but it's very difficult to assess the hypovolemia in an arrest child because their peripheries will be cold and they are not having a pulse. Very difficult to assess that part as well. So the benefit of the doubt, you have to give 20 ml per kg of fluid bolus with the in order to correct the hypovolemia. So first one was hypoxia, second one was hypovolemia, third one was hypothermia. So when you are dealing with the arrest child, always look for the temperature. So check the temperature and correct the temperature. Warm the child up. If their temperature is low, make sure that their temperature you are bringing back to normal range. And when you are getting an IV access, always remember to get an electrolyte and the blood gas, so you can check the hyperkalemia or hypocalcemia as a cause for the cardiac arrest. So that's your 4 H's and 4 T's. So 4 H's means hypoxia, hypovolemia, hypothermia, and hypo or hyperelectrolyte abnormalities. Hyperkalemia or hypocalcemia can cause the cardiac arrest. So what are the 4 T's? 4 T's means, first one is that you are going to always exclude the tension pneumothorax. How do you exclude the tension pneumothorax in an arrest child? You have to auscultate for the chest expansion, air entry, and also you have to look for the chest expansion and check the trachea. If you have ultrasound scan, you can check the pneumothorax by the ultrasonically as well. If you are in an emergency setup, always they have an ultrasound machine. You can confirm that as well. Cardiac tamponades, very difficult to identify clinically in cardiac tamponade if the patient already gone into the cardiac arrest. So the way that you can identify is that you can use the ultrasonically with the probe. If the patient is having a peri-arrest, having at least some heart rate, then you can look for a muffled heart sounds and the ECG trace may be low. But if the patient is on asystole and not having any signs of life, it's very difficult to get the clinical diagnosis of tamponade. So always you have to exclude by the bedside ultrasound. Then your toxins and the thromboembolic phenomena are other two, but it's very rare in pediatric setups. So 4 H's and 4 T's, those are the one you are going to actively check for during this 2 minutes window. And every 2 minutes you are checking for that. And already you have given the adrenaline. So next 2 minutes, if still the asystole is there, you are checking for these parameters, 4 H's and 4 T's, you continue. If the next pulse check, if the patient is having the rhythm back, you will stop it. The CPR, as long as they have a pulse. If the rhythm is still asystole, you have to repeat another cycle. What is the rhythm? You can see it in the screen, is a sinus rhythm. So whenever you are doing a rhythm check, what you have to do is you have to check the pulse as well. If you see the ECG looks like a sinus, but if you can't feel the pulse, including the central pulse, then this patient is most likely having a pulse's electrical activity. So that's again an arrest rhythm. So you need to restart the CPR. Now you have to repeat the adrenaline dose. The same dose to recap our dose of adrenaline. So the adrenaline dose is usually 10 mics per kg. So if you convert it to ml, that is 0.1 ml per kg of 1 in 10,000 dilution of adrenaline, given as a bolus, followed by the saline flush. So adrenaline is given and CPR to be continued. PPR ratio is 15:2 to achieve the total heart rate of 100 per minute. And during this whole period, you are going to look for the 4 H's and 4 T's: hypovolemia, hypoxia, hyperkalemia or hypocalcemia, and hypothermia. And 4 T's are toxins, thromboembolic phenomenon, tension pneumothorax, and tamponade. So pulses electrical activity continues. So make sure during the arrest, so you have to consider all these 4 H's and 4 T's. In addition to that, you have to make sure if you are if you have to continue the resuscitation for the longer period, make sure that you are arranging for the intubation. If you are not competent enough in intubation, don't worry. You can safely maintain the airway with the oropharyngeal airway and the back with a good chest expansion, because ET tube is not going to do anything else. So you clear the secretions. Don't get panic. No need to intubate immediately, but you have to arrange with a senior person to get the things done. So what you do, you correctly maintain the airway. You make sure you put the oropharyngeal airway, and you make sure you are looking for a chest expansion and checking the air entry, and oxygen source is adequately connected, and you continue the bagging and the resuscitation 15:2 ratio until your senior help arrives. Don't get panicked, because you must be the only person as a doctor in the floor, usually when arrest is happening. If you panic, what's going to happen? People around you also going to be get panicked. So your heart rate may be going inside very high, but don't show it. Looks confident, because everybody else will be panicked. So you also panic, means that nothing going to happen to the patient. So make sure you stay calm and get the senior help. Until that, nothing much to do. You maintain the airway, continue the CPR. Uninterrupted CPR will give good perfusion. So that will even the delayed intubation, but patient will recover completely once the senior helps is there. So once your sinus rhythm is back, when you can feel the pulse, then that means the return of spontaneous circulation is back, so that you can stop the CPR. Any child who has a cardiac arrest, even though the patient is now back to the sinus rhythm and having a good pulse, but that patient have to be monitored in a high dependency unit, either ICU or a high dependency unit, because whatever the cause for the arrest, which can recur again, so patient have to be closely monitored. So remember about the intraosseous line. Don't waste your time for the IV cannulas more than 2 times. If you can't, make sure you go for an intraosseous. You may fail, don't worry, because it's a life-saving. Don't panic to prick the tibia, because child, that is a survival way that you are going to do. So Google it and see how to put the intraosseous lines. And if you have a chance, don't stop by doing it because of the reluctancy. Just do it. That is a very, very good way of getting an access, and child might survive. So recently I had a child that I have to resuscitate. So I called from the ward, they called for help. So they were trying for the IV access. We went there, they are already resuscitating for about 15 minutes. And we went there, put the intraosseous line, give only 1 dose of adrenaline, everything came back. So that's the magic the intraosseous line can do. So just get to know about the intraosseous and see the videos and see in an emergency how to put it, because it's maybe a really lifesaver, because in an emergency, very difficult to get an IV access. So that's a summary of the non-shockable rhythm. So there are 2 main non-shockable rhythms are there. So pulses electrical activity, there is normal ECG pattern, but there is no pulse. Second one is asystole. There is flat ECG line, there is no pulse. Both the ones, what you have to do, you have to give adrenaline 10 micrograms per kg, that is 0.1 ml per kg of 1 in 10,000 dilution, and have to repeat every second cycle. That means every 4 minutes you need to continue. Every 2 minutes you check the rhythm, and if the rhythm is there, same, that you have to continue the resuscitation, and also you have to look for your 4Hs and 4Ts. So now we are moving to the shockable rhythm. So this is a machine most of the time you will get familiar with when you enter the ward. So as a house officer, there are 2 prime duties for you. Whenever you are on duty in a pediatric ward, it's mandatory that you individually go and check the emergency trolley, and there is a book which is maintained the emergency trolley. You have to tick that, okay, what are the emergency medications already there, which is stocked there. So one nursing officer will be in charge for that particular emergency trolley, but you also have to cross-check as a house officer, because in an emergency, that's the thing that's going to help you to have, because at the emergency, nothing's going to be coming to your hand. So if you are not prepared, so make sure every day in the morning before starting the shift with the nurse, quickly check all the equipments are in place, and then only you start your normal rounds. That's get it as a habit. That will really help when you are in a real emergency. Otherwise, what's going to happen is you get into the emergency, then only you start searching for the equipments, you never get it. Likewise, for the defibrillator also, there's a defibrillator currently in most of the pediatric wards. So if the defibrillator is in your ward, make sure you are familiar with that particular machine, and that machine is charged, plug and charge. It is mandatory. The defibrillator machine in your unit should be charged and available for the. So next is how to use the defibrillator machine. So defibrillator machine has 3 points, you can see that like 1, 2, 3. So switch on is number 1. That is a universal standard in the most of the defibrillator machines. Then the number 2, that you have to select the energy, how much of energy you have to give. And the number 3 is for charging, and the number 4 is basically for the delivering the shock, right? So this is the machine. So you can see that there are paddles and pads. So when you go to the ward, just get familiar with the defibrillator machine. So what is shockable rhythm? So where that like you have a VF or a VT. So if you see that you need to give the shock, how much of shock you need to give? In joules, 4 joules per kg. So for example, the 10 kilo child, you need to give 40 joules of energy you need to give. And you need to continue the CPR, and every second, every cycle you need to give the shock, and after the second shock, you need to give the adrenaline bolus and continue every second cycle, right? And after the third shock, you have to give the amiodarone as well when you are in shockable rhythm. So we will see one by one. So if the patient is not breathing and no pulse, that you have to continue the CPR 15:2, and the continuous chest compression. Remember what is the effective chest compression? You have to at least 1/3 you have to go in, and your elbows have to be straight, and you have to be compress the lower half sternum, and you have to adequately relax as well. And we have to connect to the monitor, and you have to check the rhythm. So what you can see in the screen is a really chaotic waveforms. This is called VF. So remember this pattern. If you see it, that is VF, right? So if you don't see a flat line, so make sure you stop the CPR. If you don't stop the CPR, artifact also exactly going to mimic this one. So you have to stop the CPR and assess the rhythm. The rhythm is VF. So this is what you are going to see in the screen, the ECG. And once you see it, what you have to do, you have to restart the CPR immediately, because you have to prepare for the shock now. How do you prepare for the shock? So how do you prepare for the shock? So you have to get familiar with your machine. First thing, you have to switch on the machine, and then you have to select the energy for this patient. So weight, so guess the weight depending on the age, and then put it to multiply by 4. For 10 kilos is 40. If it is a 40 joules is not available as a number, select the whatever the number one above. For example, 50 joules is there in the machine. The calculated joules for the 10 kilo is 40. So you select 50. So always go for a highest energy rather than the lowest one. Then you have to make sure that you select the lead 2 and increase the size. And in addition to that, you have to make sure that you have to do the safety check. So I'm going to tell you how to do the safety check. So main thing is you have to deliver a safe shock. So you run 2 safety checks. How do you do the safety check? Make sure oxygen is away, stops CPR, and you have to actively screen for head area, middle area, and the leg area, that everybody is clear and you are clear as well. And then you have to give the shock. So you have to tell off oxygen, stop CPR, head clear, middle clear, legs clear, I am clear, and others clear. Charging. So that is your safety check 1, right? So I'm going to repeat again. So off oxygen, stop CPR, head clear, middle clear, legs clear, I am clear, and others clear. Or you can say stand clear as well. But I used to say that every area has to screen. So head clear, middle clear, legs clear means that you are going to actively screen all 3 areas, so that you are not going to miss, and you are not going to give an additional shock to the bystander as well. So don't give a medical error. So that's your safety check 1. So with the safety check 1, you are charging, and the safety check 2, you are going to discharge the shock. So there is a red button to discharge the shock. So you press the discharge button, and then that will work, right? So you have to, when you come to the practical sessions or when you do it in the ward, always try to practice and see whether you can deliver a safe shock, because that's maybe life saving, especially not only in pediatrics, mostly the LOS is really a life saving one. So immediately after the shock, you need to recommence the CPR and continue the CPR while continuing the CPR, there are two things you need to do. You need to give it an IV access, and you need to prepare the adrenaline 0.1 ml per kg, 1 in 10,000. With the second shot, you need to give the adrenaline. And with the IV access, if you can get the blood samples, send the blood samples, and blood sugar, electrolytes, full blood count, CRP, whatever is possible, and the blood gas. So now, once the 2 minutes is over, you have to stop the CPR, and you have to check the rhythm. Again, the VF. So what you need to do, you need to give the shock again. So restart the CPR, and again, we already selected the energy, and also we have selected the lead, so we don't need to do it anything. Apply some gel and place the paddles. Where to put the paddles? One is in the apex of the heart, other one is just below the sternum, and you have to deliver the shock. So that's the picture is exactly showing. So one is just below the clavicle on the right side, and the other one is exactly on the apex. Then you can give the shock. So once you give the shock, so you have to run the safety check twice. One is before the charging, and one is before the defibrillator. How do you do the safety check? Off oxygen, stop CPR, head clear, middle clear, legs clear, I am clear, and others clear. And you are delivering the shock. So again, off oxygen, stop CPR, head clear, middle clear, legs clear, I am clear, others clear, and deliver the shock. So now you have run a safety check, deliver the shock. You need to restart the CPR and continue. During that 2 minutes, what you need to do is you need to actively look for 4Hs and 4Ts. You remember the 4Hs, 4Ts we discussed? Hypothermia, hypovolemia, hypoxia, and hyperkalemia or hypercalcemia. So how do you know hypoxia is not there? Make sure oxygen is connected, and also you make sure that is all other equipments are connected to the ambu bag is working, and your chest expansion is good, and the air entry is good. And you exclude the pneumothorax by checking the air entry as well in the trachea. In addition, you send the electrolytes so that you can check for the hyperkalemia and hypercalcemia. And also you suspect the hypovolemia and give in anticipation about 20 ml per kg of fluid. So that is hypovolemia management. And check the temperature and warm up the child if the child is cold. And tamponade, usually need ultrasound, bedside ultrasound to exclude the cardiac tamponade. Pneumothorax also you can exclude by this one. And the toxin you have to always suspect, and also the thromboembolic phenomena, and always suspect is the bigger child. So that is your 4Hs and 4Ts. You don't need to intubate all the times. You can use the laryngeal mask airway. So it's already explained in the previous lecture. I'm not going to go into the details. And so at the end of the 2 minutes, you check the rhythm. If you check the rhythm and the rhythm is sinus, you check the pulse as well. If the pulse is there, you stop the CPR and put it to the recovery position, and you have to go for a post-resuscitation care. So what is important in both the non-shockable and the shockable rhythm is uninterrupted CPR. So you are stopping the CPR only for 2 instances. One is to rhythm check. So rhythm check, how long you can stop the CPR for rhythm check? Maximum of 10 seconds, not more than that. Second one, for charging and discharging a shock. Right? Rest of the time, you are not stopping the CPR. You have to continue the CPR uninterruptedly. So that is actually maintain the brain perfusion. So if the patient recovers, patient's brain functions may be still intact if you are giving an effective CPR. So consider amiodarone after the third shock and adrenaline after the second shock in the shockable rhythm. And if it is a non-shockable rhythm, then adrenaline have to be every second cycle. So our quick summary, shockable rhythm, VT and VF. You know how to identify the VT and VF. Shock 4 joules per kg. Every cycle you have to shock if the rhythm is shockable. And after the second shock, you need to deliver the adrenaline. Third shock, you need to give amiodarone. Amiodarone, remember the dose is 5 milligrams per kg. Then the non-shockable rhythm. Non-shockable rhythm is basically you have pulses electrically and asystole. So you have to give adrenaline, and every second cycle you need to continue that. So every 4 minutes you need to repeat the adrenaline. Adrenaline dose is 0.1 ml per kg, 1 in 10,000 dilution. So you have to continue that. So most of the time, make sure that it's like one of the emergency nurses aware and quickly how to prepare it. So when you start the HA period, make sure you yourself know how to prepare the adrenaline, because some emergency, some junior staff may not be even knowing how to prepare it. So as a doctor, you should be able to know how to prepare the adrenaline. So get to know that. So take the vial and prepare yourself the correct concentration and get to know. That is really important in emergency. So COVID situation, so it's basically the minimizing the exposure. So any procedures, any aerosol generating procedures have to be approached with the proper PPE. So treatment recommendation, so exactly the same. Only thing is, whenever you are disconnecting, circuit will be closed. So make sure if you are disconnecting the oxygen, you off the oxygen and then only you are going to disconnect the oxygen. If the ET tube is connected to the patient, if you are going to disconnect the ET tube, you off the ventilator and then only you are going to disconnect, so that you can minimize the air spread. So then your post-arrest care, so usually they will be monitored in the high dependency or the. So that's the end of the session. So any questions you guys have, you can put it in the chat box, and we are happy to answer. So we are already running behind the time, so we are already 10 minutes late. So if you have any questions, we are happy to answer. Otherwise, over to you guys. What's the next section? We are continuing without a break, or we are. So Michael sir will be on. He's already there. So next lecture will be by Dr. Michael. Over to you, Dr. Michael.
Thanks, Pradeep.
Thanks a lot, guys.
Okay. Okay, so good morning. I'm Dr. Michael Jans, consultant pediatrician, and I'm doing the next lecture, which is a little bit of a child with breathing difficulties. So in this lecture, we'll try to understand the structured approach to approaching a child with breathing difficulties, and to try to describe the assessment and resuscitation of child with breathing difficulties, and learn a little bit about the key features that you will see in each condition, and describe some of the emergency treatment. So why is a child different, and why are they so vulnerable than adults? So there are a lot of reasons. One is that immunologically they are immature, so they are more likely to get very ill with illnesses that might not affect adults, and so because of the immature immunological system, and they can become ill very quickly because of this immaturity. And airway sizes are smaller, so any obstruction in the airway will cause a relatively more serious effect and more resistance. Their chest walls are very compliant, so they can have much more resistance, and also their lungs are more prone to collapse because of this. Their respiratory muscles are weak, so they can get exhausted quickly. And sometimes in the smaller children, the respiratory centers can be immature, and they can get apneic very easily. So a lot of changes that make children very vulnerable to respiratory conditions. So if you're looking for the signs of deterioration, so increase in recessions, increase in respiratory rate, increase in pulse rate, fatigue, altered mental status, cyanosis. So if you see a child who's working hard to breathe, rates are going up, recessions increasing, pulse rate going up, conscious level going down, you have to take action quickly. So in any resuscitation, our child's always first go in a sequence, open airway, give some oxygen. If the child is not breathing, you might have to give ventilator support, as you learned in the previous lectures. So there are some key features. So depending on some features, you can get an idea of what the diagnosis of a child with the breathing difficulties. So if you have a stridor, it's an upper airway obstruction. V is lower airway obstructions. If you have a fever in a child with difficulty in breathing, tachypneic, it most likely is a pneumonia. So don't forget, if you have a child who is breathing fast, don't forget heart disease. So look for features of heart disease, murmurs, gallop rhythms, hepatomegaly, basal crepitations. So go through the history. Sometimes with poison ingestions, you can have tachypneic children. They may have metabolic acidosis to poisonings. So if there's a urticaria, a history of allergen ingestion, it could be anaphylaxis. So if there's secretions, there could be a poor cough reflex. If you hear snoring sound, the child's conscious level may be low and the tongue may be fallen back. So you might have to open the airway, as you learned in the previous lectures. A loud stridor and a cough is suggestive of croup or foreign bladder. A soft stridor and septic child is suggestive of tracheitis or epiglottitis. So sudden onset cough and stridor, think of a foreign body. So if you have viral cough, it's generally a well-looking child who develops a loud stridor and has respiratory difficulty, might have a prodromal phase of fever for a couple of days and cough and cold, may have a barking cough. So this child, most important thing is it's a partial upper airway obstruction. So don't upset the child. Keep the child in the most comfortable position. So ideally on the mother's lap. If the child is in respiratory distress, you might have to give some oxygen. So when giving oxygen, you don't want to upset the child. So try to get the mother to hold the mask. So that will, if the child gets disturbed and cries, it's distress, the obstruction might worsen. So we try to do everything possible to keep the child calm. So get the mother to hold the child, get the mother to hold the oxygen mask. And if the severe distress, we can nebulize with adrenaline. So the dose is 0.5 ml per kg or 1 in 1000 adrenaline. So a maximum of 5 ml. So we can give dexamethasone 150 micrograms per kg. And always remember to call for help. So if you have a child with a stridor, it's a partial upper airway obstruction, call for help early. So if not getting better, you might have to take over the airway if child is getting severely distressed, or you might reassess and see after this treatment. So epiglottitis, difference from viral croup is they are very ill and toxic looking, and they may have this difficulty in speaking, difficulty in swallowing, drooling. They might have difficulty keeping the airway. So this child, be very careful. Don't try to upset the child. Don't try to examine the throat. If you do, you might cause a complete obstruction of the airway and child might arrest. So call for help early. Keep the child calm. Keep the child in the most comfortable position. You can give some oxygen. Again, get the mother to hold the mask. Call for help. So in this child, you probably epiglottitis child, you'll probably have to take to the theater. So you have to inform the theater, the anesthetist, ENT surgeons. So once they take to the theater, the anesthetist will give gas induction and secure the airway. And after securing the airway, they will give put a cannula, get the cultures, and start some IV antibiotics. So most likely a third generation cephalosporin. So bacterial tracheitis, again, there will be ill children with a soft stridor. So again, similar to the epiglottitis, so avoid unnecessary upset to the child. You probably have to get help quickly, and probably need to take to the theater and examine the airway under gas induction and take over the airway. After taking over the airway, cannula will be inserted and start IV antibiotics. So foreign body, I think you did in the first lecture. So if you have a child with foreign body, I think they were told in the first lecture, if there is a effective cough, that means a loud cough, allow the child to cough. If there is ineffective cough, 5 back blows, 5 chest thrusts. An unconscious patient, BLS. So while you're doing BLS, you might take to the child comes to hospital and you start the BLS, you'll need to relieve the obstruction. So call for help early. You might need the anesthetist and ENT surgeon to take over the airway. So you might have to take remove the forehead either by direct laryngoscopy or cricothyrotomy. So you might need the expert in the airway, you might need the ENT surgeon to do a surgical airway. And, so once they have stabilized the patient, the ENT surgeon will might have to do a bronchoscopy or laryngoscopy under anesthesia. So a child with wheeze. So if you're generally wheezing above 1 year and recurrent wheeze with a history of atopy, it's most likely asthma. So if your first time wheezing less than 1 year, most likely it will be a bronchiolitis. So Dr. Ganganath will be doing wheezing in the asthma in the next lecture, so we won't go into much detail. So just a few features of asthma. So if you have a feature, if you should suspect a severe disease, there's a long duration of symptoms, and there was a previous attack needing ICU or IV therapy, and if there's poor response to treatment in the current episode, they've been nebulized several times and not improving, so these are suggestive that this is going to be a severe disease. And generally the good indicators of the severity asthma is saturation is a good indicator, wheeze is not. So you might have a silent chest. So even without much rhonchi, you might be having a severe wheezing. And chest X-rays are not very useful in the acute thing. And you always remember the trends are better than observation. So if you're having a child, you have to see their respiratory rates and their respiratory effort and saturations and see how they're getting better with treatment. So the treatment for the asthma will be done in the next lecture. So just a little bit about the classification. It's very important to classify how ill the child is. So it's important to know with the mild, moderate, severe, life-threatening. So life-threatening is very important to know these signs. So exhausted child, poor respiration, silent chest, hypertension, reduced conscious level, agitated, depressed. That is life-threatening asthma. So the acute severe asthma good sign is if they are too breathless to talk or feed, or their respirates are heart rates are higher than this amount for the age. So more than 5 years, more than 30 per minute, 2 to 5 years, more than 50 per minute. In the heart rates, more than 120 for more than 5 years, more than 130 for 2 to 5 years. So the rest, they can speak with a sentence without being breathless, and their rates are less than this, but still slightly tachypneic, then they'll be more in the moderate range. So if you can identify the severity, it's a first step in the treatment. So the treatment wise, Dr. Ganganath will be doing the next lecture. So a little bit about bronchiolitis. So this is an important condition. So if you have a child less than 1 year coming with cough and cold, maybe mild fever and tachypneic, and you hear rhonchi, you might hear some crypts as well. So think of bronchiolitis. So it's caused by a virus, respiratory syncytial virus. In Western countries, in the colder countries, it's generally a seasonal disease, but in our country, we get it all year round, little bit more with the rainy season. So, like I said, characteristics, cough, wheezing, respiratory distress. Sometimes you might get apneas, especially in preterm children. So, to get an idea how severe there are a few red flags. So, if you have the younger the child, the more likely that the child will get ill. So, if you have a 1 month-old child and a 6 month-old child, the one more likely to get ill is the smaller child. And especially preterm children are more likely to get a severe disease. So on the age itself, you can get an idea how carefully you should monitor the child. So ability to feed is a good indication of the severity. So if you have a child with bronchiolitis and poor feeding, that's a bad sign. And oxygen saturations in the eye is an important thing to monitor in these children. So also comorbidities like cardiac or respiratory, again, it's a red flag. You might get a more severe disease course if you get the baby gets bronchiolitis. So bronchiolitis, actually the main treatment is oxygenation. So it's symptomatic management. So you have to have close monitoring, keep the airways clear. So you might have to suck out any secretion, put some nasal drops. You might have to nebulize with some 3% saline to clear the airways. And the mainstay is oxygen. So you can give oxygen either through nasal prongs. So you can give up to 2 liters per minute through nasal prongs. So if you want to give more oxygen, you might have to give through a mask. And if still not getting better, you might have to give humidified high flow oxygen therapy with the high flow machine. Also, you have to manage symptoms to maintain the hydration, maintain nutrition. So in bronchiolitis, we will be giving oxygen, but we almost always monitor and see if the child is getting worse. So if the child is getting apneic and getting exhausted and saturations are going down, we'll probably have to take over the airways. You might have to bag and mask and get ready for an intubation if the child is deteriorating. So in bronchiolitis, it's a mainly clinical diagnosis. We rarely need X-rays. Main treatment is oxygenation. So the other condition where child with breathing difficulties is in this X-ray, you can see a left upper lobe pneumonia. So fever, difficulty in breathing, with increased work of breathing, think of a pneumonia. So they might have alar nasal flaring, they might have tachypnea, there might be lung signs, crepitations, bronchial breathing, reduced air entry. So with the clinic, generally you should be able to diagnose clinically. So, but we'll do X-ray, especially if there's focal lung signs. Ultrasound is useful in detecting effusions. So treatment is oxygenation and antibiotics. So it will depend on the organism. So like in this, it's lobar pneumonia. So we'll probably give some IV third generation cephalosporin. So we have pleural effusions. You might need drainage if there's large effusions. Rarely, these children might get exhausted. So you have to monitor their respiration, respirations, and saturations. If they're becoming exhausted and becoming apneic, you will have to get ready for artificial ventilation, get ready to take over the airways. So all children with breathing difficulty are not wheezers, so not having respiratory problems. They might be having cardiac problems. So you can get this in with various cardiac diseases. So if you have a left to right shunt, you might present with heart failure, like in a VSD. You might have left side heart obstructions, like aortic stenosis, or pump failure, like myocarditis, or dysrhythmias, like SVT. So these can present with breathing difficulties. So you have to take a good history and examine and make sure you get the diagnosis. So because our treatment will be different. So important things to look for in heart failure is look for clinically enlarged heart, tachycardia, gallop rhythm, hepatomegaly, basal crepitations, and listen for the murmurs, look for the cardiac signs. So in the X-ray, of course, you might see enlarged heart and vascular markings, but try and detect these clinically. So treatment, most of the pediatric will be either oxygen diuretics, and in some conditions we might need some inotropes. So yeah, if there are any questions, you can just type in the chat box and we'll try and answer. Okay. So the next lecture will be by Dr. Ganganath. So he'll be doing asthma. So over to Ganganath.
Welcome to the defibrillation demonstration. Here I'm Dr. Brinda, Dr. Shamila, Dr. Dhananjay, and Dr. Manoj. We are going to demonstrate how to defibrillate an arrested patient. So defibrillation is a life-saving technique, and everyone should know to manage a shockable arrest patient. So here, before moving into the skill, I would like to introduce the equipment. So cardiac monitor. So any patient who is arrested, we should immediately correct the cardiac monitor. So in cardiac monitor, there are knobs. So this is monitor on, lead selection, lead 2 we will select, and ECG gain, and then charge button. Here we are mostly using the paddles in pediatrics. So here, this is the charge button, again yellow button, that is on machine as well. You can charge either on paddle or on machine. And the orange buttons you have to press simultaneously in order to deliver the charge. Then if the child is less than 13 kilos, you can use the pediatric paddles to defibrillate the patient. So having said that, we are going to manage a 25-kilo child who found arrested, and Shamila and Dhananjay started the basic life support, and Manoj is coming to help them.
Myself, Dr. Manoj, I'm the on-call consultant for today. I get some details regarding this patient.
Yeah, so we have this child who arrested, and we have started effective basic life support.
Okay.
And we are giving at a rate of 15 compressions to 2 breaths.
Right, that's very good. I see you're doing a very effective CPR. Please continue with that while I connect the chest leads to the patient.
So chest leads are connected.
On the monitor.
Lead selection.
I would select lead 2.
Increase the gain. Your monitor is ready.
Stop CPR, please. Am I getting a pulse?
No pulse.
Okay, it's a pulseless ventricular fibrillation. Please continue with your CPR while I prepare the patient for the first shot. Since the patient's weight is 25 kilograms, I set the joules at a rate of 4 joules per kg, which is 100 joules. After taking the pads, I apply some gel onto both pads.
Place the paddles below the right clavicle, right to the sternum, 5th intercostal space, mid-axillary line.
Stop CPR. Stop oxygen. Head clear, middle clear, leg clear, visual check.
Safety first.
Charge. Head clear, middle clear, leg clear, I am clear, visual check. Shock delivered. Continue with the CPR.
So the team is continuing CPR for 2 minutes. Manoj is preparing for the next cycle.
I've inserted the cannula, taken the blood for CBS, serum electrolytes, and full blood count as BVG. Preparing the drug IV adrenaline, 1:10,000 of 2.5 cc with a flush.
2 minutes up.
Stop CPR, please. Am I getting the pulse?
No pulse.
Again, it's still
Ventricular fibrillation.
Please continue with the CPR while I prepare the patient for the second shock.
Same placement of the paddles.
Stand by. Stop CPR. Stop oxygen. Head clear, middle clear, leg clear, I am clear. Charge. Head clear, middle clear, leg clear, I am clear. Visual check. Discharge. Continue with the CPR, please. I'm giving the first dose of IV adrenaline, followed by a flush. I want to check for 4 H's and 4 T's, that is, those are the connectable causes at this point of time. How about the oxygen? Is the oxygen connected well?
Yeah, it is connected and fine.
You are getting chest expansion.
Okay. How about the temperature of this child?
It's cold peripheries, and he is running a temperature of 39 degrees Celsius.
Okay. How's the color of this child?
Color is very pale, looking pale.
Okay. I will prepare for a 20 cc per kg of normal saline and give it.
Okay, normal saline 20 ml per kg given.
Have I got any of the blood results such as blood sugar?
Sugar seems to be normal.
Okay. How about the iron tree?
Entry is good and equal.
Any abnormal heart sounds?
No muffled heart sounds.
Please continue with the CPR.
Two minutes up.
Stop CPR, please. Am I getting the pulse?
There is pulse.
Okay. And the ECG rhythm says sinus tachycardia, and the patient has shown return of spontaneous circulation. Please continue with the ambient ventilation, please.
Return of spontaneous circulation, and he stopped the CPR, and we will end the sessions there. Okay, here we have demonstrated the defibrillation skill, and where Dr. Manoj approached the patient while they were giving the basic life support. So Manoj first concentrated to wanted to assess the airway, breathing and circulation in order to stabilize the patient. That's the end of the demonstration. That's the end of the demonstration. Okay, welcome to the defibrillation demonstration. Here I'm Dr. Brinda, Dr. Shamila, Dr. Dhananjay and Dr. Manoj. We are going to demonstrate how to defibrillate an arrested patient. So defibrillation is a life-saving technique, and everyone should know to manage a shockable arrest patient. So here, before moving into the skill, I would like to introduce the equipment. So cardiac monitor. So any patient who is arrested, we should immediately correct the cardiac monitor. So in cardiac monitor, there are knobs. So this is monitor on, lead selection, lead 2 we will select, and ECG gain, and then charge button. Here we are mostly using the paddles in pediatrics. So here, this is the charge button, again yellow button, that is on machine as well. You can charge either on paddle or on machine. And the orange buttons you have to press simultaneously in order to deliver the charge. Then if the child is less than 13 kilos, you can use the pediatric paddles to defibrillate the patient. So having said that, we are going to manage a 25 kilo child who found arrested, and Shamila and Dhananjay started the basic life support, and Manoj is coming to help them.
Myself, Dr. Manoj, I'm the on-call consultant for today. I get some details regarding this patient.
Yeah, so we have this child who arrested, and we have started effective basic life support. And we are giving at a rate of 15 compressions to 2 breaths.
Right, that's very good. I see you are doing a very effective CPR. Please continue with that while I connect the chest leads to the patient.
So chest leads are connected.
On the monitor.
Lead selection.
I would select lead 2.
Increase the gain. Your monitor is ready.
Stop CPR, please. Am I getting the pulse?
No pulse.
Okay, it's a pulseless ventricular fibrillation. Please continue with your CPR. while I prepare the patient for the first shock. Since the patient's weight is 25 kg, I set the joules at a rate of 4 joules per kg, which is 100 joules. After taking the pads, I apply some gel onto the both pads.
Place the paddles below the right clavicle, right to the sternum, 5th intercostal space, mid-axillary line.
Stop CPR. Stop oxygen. Head clear, middle clear, leg clear, visual check.
Safety first.
Charge. Head clear, middle clear, leg clear, I am clear, visual check. Shock delivered, continue with the CPR.
So the team is continuing CPR for 2 minutes. Manoj is preparing for the next cycle.
I've inserted the cannula, taken the blood for CBS, serum electrolytes, and full blood count as VVG. Preparing the drug IV adrenaline, 1:10,000 of 2.5 cc with a flush.
2 minutes up.
Stop CPR, please. Am I getting the pulse?
No pulse.
Again, it's still
Ventricular fibrillation.
Please continue with the CPR while I prepare the patient for the second shock.
Same placement of the paddles.
Stand by. Stop CPR. Stop oxygen. Head clear, middle clear, leg clear.
Next lecture will be delivered by Dr. Asanga Rajapaksa.
Can I start now?
Yes, sir.
Okay. Okay. Thank you very much. I hope everyone can see my slides. So I can see there are about more than 200 people joined in. We will speak about shock and dehydration in children in about 40 minutes time. If you have any questions, you can post them in the chat box. And if we have time at the end, I can answer questions as well. So I'm Dr. Asanga Rajapaksa, pediatrician from Base Hospital, Maravilla. So in the next 40 minutes, we'll discuss about shock and dehydration in children, right? Some of the slides, of course, I will skip. I will only discuss the important things and the physiological basics. Okay. Now the first thing is, dehydration in children. Now, when we discuss about dehydration in children, now in pediatric practice, you will get dehydrated children fairly commonly. So commonest reason is vomiting and diarrhea, but there will be other causes as well. So when you see a child who is dehydrated, you have to assess their level of dehydration. So they can be having no dehydration, some dehydration, or severe dehydration. So no dehydration means that it's about 5% or less than 5% of total body weight is lost due to the dehydration. Some means it's 5 to 10%. Severe means it's more than 10% of the body weight lost from fluid loss. Okay. So then if you detect dehydration, then you have to decide how much fluid to give, because now
If the child is dehydrated, there's a deficit. So you have to correct that deficit. So the deficit in no dehydration will be like less than 50 ml per kg. Whereas if it is 5 to 10% dehydration, then it's 50 to 100 ml per kg. And severe dehydration more than 100 ml per kg. So that is how you calculate the deficit. Now, how do you clinically identify the child, whether this child is having mild, moderate or severe, or in other words, no dehydration, some dehydration or severe dehydration in these children? So when a child is having mild degree of vomiting and diarrhea, but not significantly dehydrated, that means child is well and alert, eyes are normal, moist, tears are present, tongue is moist, mouth is moist, and child may be a bit thirsty, and the skin turquoise is normal. But when the child is having some dehydration, the child is a bit restless and irritable, eyes are sunken, tears are absent, mouth is dry, and child is now thirsty, eagerly drinking, asking for fluid a lot. And the skin turquoise is now reduced. So when you pinch the skin, the skin fold will go back very slowly. Severe dehydration, the child is either lethargic or unconscious, so floppy, right? Because they are now acidotic. In severe dehydration, they become acidotic due to the poor tissue perfusion and lactic acid accumulation. The eyes are very sunken, tears are totally dry, absent, mouth is very dry. Sometimes you can have parched tongue and lips. And now, because of the lethargy or the unconsciousness or the floppiness, child is not drinking, not showing the thirst, right? And the skin pinch, if you do the skin pinch or skin tuggle, it will go back very slowly. So this is how you identify that the child is having no dehydration, some dehydration, or severe dehydration. So in this next slide, we will discuss how to manage severe dehydration, because that is life-threatening. So if a child is severely dehydrated, but remember this now, this child is dehydrated but not in shock. Shock we will discuss later. Shock means there will be poor capillary fill time, low volume pulse, low BP. That is different. Now this is dehydration without shock. Okay. So severe dehydration, you start IV fluids. But if the patient can drink, you can give oral rehydration solution by mouth until you cannulate and set up a drip. It might take a few minutes, right? Now, this is the WHO formula for managing severe dehydration without shock. So what they recommend is rigorous lactate or Hartmann solution. So this is how you give. So if the infant is less than 12 months, then your severe dehydration deficit is 100 ml per kg. So you divide that into two parts, 30 ml per kg and 70 ml per kg. So the first 30 ml per kg you give over 1 hour, next 70 ml you give over 5 hours. But if the child is more than 1 year, you can give it faster. So the first 30 ml per kg you give over 30 minutes, and the next 70 ml per kg you give over 2.5 hours. Right? So this is how you correct severe dehydration without shock. All right. Okay. Now we'll move on to the next topic, which is shock. Right. Now, management of shock. You have to identify you have to understand the physiology also. Right. Now, just forget about this. If I roughly define shock, shock simply means it's an acute life-threatening situation where there's poor tissue perfusion and inadequate delivery of oxygen and nutrient to the tissues. And you can add the defective removal of waste products from the tissues as well. Right? So basically, it's an acute event which occurs at tissue level. Now, if you look at the oxygen delivery to tissues and oxygen consumption by tissues, right? Normally, the oxygen delivery should be more or equal to the oxygen consumption. Because if you don't have enough oxygen delivery, then the tissues will not have enough to consume, isn't it? So the delivery should be either more or same to the consumption. So the oxygen delivery is equal to cardiac output, hemoglobin, and arterial oxygen saturation, right? So now, if you have a child in shock, anyway, the oxygen delivery to tissues is affected. Therefore, you have to take actions to reduce oxygen consumption by the child's tissue. So what can you do? If you control fever, that will reduce the energy consumption. If you control seizures, that will help. And in severe shock, and not if the child is not improving with fluid, then you generally intubate and ventilate. Why? Because now your respiratory function is taking up a lot of energy. So if you intubate and paralyze and ventilate the child, then that energy is preserved. So you are taking over one system completely. Okay, and then you can sedate if the child is agitated, like and wasting a lot of energy. You can sedate. So these are measures that can be taken in a critically ill child or child with shock to reduce oxygen consumption at tissue level. Okay, right now. I will skip this because this same thing will be discussed in the next slide. Okay. Now, I think you all know these things from your physiology. Just it's nothing confusing. Very simple, really. This is what I told you earlier. Oxygen delivery to tissues. It depends on the cardiac output, hemoglobin level, and the arterial oxygen saturation. Then the cardiac output is related to mean arterial pressure. So the mean arterial pressure is a product of cardiac output and total peripheral resistance. Okay, then cardiac output, is a product of heart rate and stroke volume. Stroke volume depends on preload, afterload, and contractility. Right. So now we will see. Now we can't assess all these things in a patient in the ward. So what we assess are certain physical signs. So let's see how these physiological parameters are measured with physical signs. Right now, heart rate. Now, that of course we are directly measuring. Pulse rate, pulse volume, we can check. Then the total peripheral resistance, we are looking at peripheral perfusion. So if the child has cold peripheries and prolonged capillary refill time, then the peripheral perfusion is poor. Mean arterial pressure, you don't directly measure mean arterial pressure, but what you measure is the blood pressure. And you can measure it both supine and seated. But if the child is in shock, then it's better not to seat up the child and check, because it can cause further reduction of blood flow to the brain. Okay, so blood pressure. Then preload. So how do you check the preload on the heart? So the jugular venous pressure will be elevated if the preload is high. There will be hepatomegaly, as in heart failure, isn't it? And the central venous pressure will be high and PO. Then contractility of the heart, of course, if there's some sort of cardiac muscle problem and contractility is impaired, then you might see galloped rhythm and other preload features due to heart failure. Okay, so this is how these physiological parameters are related to the physical parameters we check. Right. So when you have a child who is critically ill, you have to assess the circulation. So now you want to assess the circulation and whether they are shocked. So one thing you check is the capillary refill time. Okay, so the capillary refill time you can check by pressing on the sternum or some bony, some firm area for 5 seconds and then release and wait and see whether it fills up within 5 seconds. Okay, so that is the capillary refill. Sorry, it should fill within 2 seconds. It should fill within 2 seconds. And then, so what are the things you assess in a child who is having, whom you are suspecting having shock? You have to check the pulse, radial pulse or femoral pulse. You can check. If peripheral pulses are not easily seen, you can check central pulses as well. Yeah. And you can check the pulse volume. You can check the capillary refill time, as I told you earlier. And you can look at the peripheries, whether they are pale and mottled. In shock, the peripheries will be pale and mottled, right? And then you can check the blood pressure. So you have to quickly assess these things in any child who is critically ill, and especially if you think the child has shock, you have to check these things quickly and determine whether the child is in shock or not. Okay, right. So if the child is in shock, also look for bleeding wounds, because if it is especially after trauma, a child may be in shock due to bleeding, right? So you have to look for focus on bleeding. So capillary refill time, I told you how to check. You press for 5 seconds and then it should fill up within 2 seconds, right? Okay. Now, causes of shock. Now, again, don't get confused with all these large slides, large boxes here. Just look at this side. So, what are the different types of shock? You have hypovolemic shock. Simply, you lose fluid, right? So, you can get hypovolemia due to hemorrhage, gastroenteritis, interception, various things. Then you have distributive shock. Distributive means two things. One is you get vasodilatation and you get increased capillary permeability. So, you have dilated system, so the amount of circulating blood is not enough to fill the system, and you have leaking of fluids, causing again sort of contributing to the shock. So even dengue hemorrhagic fever is now considered a distributive shock because of the fluid leakage. Then sepsis and anaphylaxis are the other two common causes. Cardiogenic shock, you know, it's basically failing of the heart. Obstructive shock, that is, there's an obstruction in the circulatory system, something like congenital heart disease causing obstruction, tension pneumothorax, you know, something like that. Dissociative shock means the problem is at oxygen delivery to tissues. So either there's something wrong with hemoglobin, there's severe anemia, or there is some problem with the hemoglobin release of oxygen to tissues like carbon monoxide poison. Okay, so we look at these things. Right now, you know, the body has a homeostasis. So the body tries to keep everything in a proper order. So if something goes wrong, the body has compensatory mechanisms. All right. So one is now when the blood pressure is high or low, what happens? So if the BP, the mean arterial pressure, when the BP is high due to some reason, the body will have some vasodilatation and reduction in heart rate to bring the BP down. But in a condition like shock, where the BP is low, they'll have peripheral vasoconstriction and the heart rate will go up. So try to keep the BP stable. Okay, right. Now, when you have a problem like say hypovolemia or something, when the circulation is not happening properly, so now the body can increase the cardiac output when you increase the volume load. So if you increase the end-diastolic volume of the heart by giving more fluids, the cardiac output will increase up to a certain level. In a shocked child, the same thing will happen. So this is a shocked child, this is a normal child, this is a shocked child. In a shocked child, the response to fluid is less because in a shocked child is acidotic. So there's less response to the fluid we give. So again, with volume loading, with end-diastolic volume increasing, the heart cardiac output will increase. So that will help to keep the blood pressure going up to a certain level, right? Now, what are the differences between children and adults when it comes to shock? Now, in children, the heart rate is very sensitive. So even if the child has fever, even if the child is crying, the heart rate will go up. So it is very sensitive. So it will go up in the shock as well. But it's not specific. So it can go up in so many conditions, right? Then vasodilatory shock is less common. I mean, adults it's more common, but in children, vasodilatory shock, that is what we call warm shock, is not very common. Commonly, what you get is anaphylactic shock and septic shock, right? Then hypertension is a late feature. So initially, the body will have some compensatory mechanism.
අසංග ඔයාගේ වීඩියෝ එක ඔෆ් කරලා කතා කරන්න පොඩ්ඩක් කැඩි කැඩි යනවා නැත්තම්. අසංග වන් ඩොක්ටර් ශ්‍රීලා ඩිසිලා ඔයාගේ වීඩියෝ එක ඔෆ් කරලා කතා කරන්නකෝ එතකොට.
The absolute circulating volume
අසන් ගා වීඩියෝ එක ඔෆ් කරලා කතා කරන්න. එතකොට මේ කැඩි කැඩි එන්නේ නැත්තම්. හරි. අරුෂන් මම අසංගට කිව්වා
Okay, yeah, hope you can see it now. Yeah, okay. So then in children, the absolute circulating volume is very low. Therefore, if they lose, say, let's say 100 ml of blood or fluid, that will cause more serious effects than in an adult. Then the CO, that is cardiac output, is more heart rate dependent rather than stroke volume. And the vascular access can be difficult in children, right? Okay. Now, when you have a child with shock, you have to look at whether it's compensated shock or uncompensated shock, right? So compensated means that now the body compensated mechanisms are working and the body has compensated to a certain level. So the vital organ perfusion is happening in the expense of peripheries. So in compensated shock, what happens? The extremities will be cold, the skin will be, the peripheries will look pale, a child will have tachycardia, peripheral pulses will be weak, the capillary refill time will be prolonged, but still the central pulses will be normal volume, and still the systolic and diastolic BP will be normal. But what will happen is the pulse pressure will start getting narrower now. The difference between the systolic and diastolic pressure will start getting narrow, but still the absolute pressures will be within normal range. The child might show a bit mild agitation, urine output will be reduced. Okay, so basically now, the important thing is for interns at your level is to identify a child when they are in compensated shock. Don't wait till they go into uncompensated shock, because that is very serious. So you have to be able to identify them at this level, right? Before their blood pressure starts crashing, right? So if they go into uncompensated shock, what will happen is the peripheries will be very cold, the skin will be pale and mottled, severe tachycardia, weak pulses, and prolonged capillary refill time. Now the central pulses also will become weak. The carotid pulse and the femoral pulse will be weak. Now the blood pressure will start falling. Child will be sort of comatose or drowsy, depressed cerebral state. Urine output will be absent for a very long time. And now the breathing will be acidotic, because what happens is when you are having severe shock, tissues become hypoxic. So you develop anaerobic metabolism, lactic acidosis will occur, right? So acidotic breathing pattern. So these are the features of compensated and uncompensated shock. Again, I will emphasize it's important for you to detect it at this level, compensated shock, and act on it, right? So what are the signs of compensated shock? Again, tachycardia, low volume pulse, and there will be something called a cold light. So if you feel the peripheries will be cold, but if you keep feeling from the periphery towards the body, at some point you will feel that the coldness ends and the warmth will start. So that is what you call the cold light. So if the shock is progressive, if the shock is worsening, that cold light will move towards the body. But if you are giving fluids and if you are doing some other maybe inotropes, and if the shock is improving, then the cold light will progress towards the periphery and disappear, right? So the capillary refill time will be prolonged, blood pressure still will be normal, and there might be a difference between supine and seated blood pressure, postural hypotension in a compensated shock. But uncompensated shock, again, as I told earlier, there will be severe tachycardia, low volume pulse, sometimes peripheral pulses are not palpable in severe shock. There will be a cold line, this time it has to have moved towards the body, and prolonged capillary refill time. Now the blood pressure is falling. So they will also show some features due to effect on other organs apart from the cardiovascular system. So because of the hypoxia and acidosis, you will get reduced cognitive state and reduced level of consciousness, which will be a late feature. Urine output will be reduced, and respiratory rate will be high again due to lactic acidosis. So it's like this rapid breathing, what we call Kussmaul breathing. Okay. Now, as I told earlier, common error is failing to recognize compensated shock, and you allow it to progress to uncompensated shock, where the management will be more difficult. Okay, and child will be more critically ill. Okay. Now, hypotension is a pre-terminal sign. So that, as I said, if you wait for the BP to drop, that means it's a pre-terminal sign. If you don't do anything quickly, the child will actually die. So you have to detect the narrowing of pulse pressure, the narrowing of pulse pressure, and the peripheral coldness, the poor capillary refill time, all these things, and then act before the BP starts dropping. Okay. Now, when you check blood pressure, how do you check the blood pressure? The readings on the multi-para monitors are not very reliable. Okay. So manual reading is the best. So as HOs, make sure you check manually whenever you have a doubt, especially critically ill child. When you monitor, check it manually and document. Don't rely on these machines which are notoriously unreliable. Right? Okay. Now, initial stabilization of circulation in both compensated or uncompensated shock. So any child with shock, you have to get access. So you have to get IV access. If not possible to get IV access due to completely collapsed circulation, you have to get intraosseous access, right? So then once you get IV access, so IU access, you have to take blood. So normally in a shock child, you do a blood sugar, full blood count, blood culture, serum electrolytes, venous blood gas, and grouping. And now, depending on the etiology, you might do different tests, but these are the basics you will do in most situations. Okay, blood sugar is a must, electrolytes is a must, full blood count is a must, and gas, if you have a blood gas machine, do it. In some peripheral hospitals, you may not have one. So you take blood. Now, another important thing I want to emphasize is, now if the child is in shock and very difficult to put a cannula, you get a cannula in, and blood is not coming when you want to take investigations, but blood is not coming, then don't waste a lot of time trying to pull out blood from that cannula. Just give your fluid bolus, because child is in shock. So when you give fluid bolus, the child will improve. Then while you are doing that, you put another cannula when the circulation is improving, put another cannula, and then take these bloods for investigation. Okay, don't delay giving fluids when you have a child with shock. So fluid bolus, normally it is normal saline, 0.9% saline, 20 ml per kg is a normal standard bolus in children. Remember, in children, it's always per kilogram, right? Not like in adults. So if you don't know the child's weight, you should have a rough idea what is the weight of the child. There are certain ways to calculate, certain rough formulas. So you have to give this fluid bolus. So if you don't get intravenous access, you can have what is called intraosseous access. It's difficult to explain everything in this lecture, but I'm sure you know these intraosseous needles, and you know the site where you go in normally, right? Okay. So colloids versus crystalloids. Now, normally when you treat shock, you use crystalloids. In our setup, I told you it's normal saline. But what about colloids? So there are colloids as well. Now, whatever you use, it has to be isotonic fluid. Okay, so to correct shock, you never use N/2 saline. Okay, so you use normal saline. And theoretically, colloids may be better, because as you know, colloids have large molecular size, and so they may stay longer in the circulation. But in practice, there is no difference. So generally, in most cases, basically, in pediatrics, what we teach is give crystalloid as a first bolus, and actually it has the additional advantage of opening up the microcirculation, because if you have a shock, say let's say dengue shock with peripheral circulation shut down, colloids have large molecules, so they will not go into these tiny capillaries well, but crystalloids will go. So therefore, always the first bolus we advise to give crystalloids. Now, there are problems with colloids. Colloids cost more, and you can have anaphylaxis and the risk of infection, because some of the colloids are derived from human blood. Okay. So now there are situations where you give only 10 ml per kg bolus. Now, earlier I said we give normally 20 ml per kg bolus, but there are situations where we give only 10 ml per kg bolus. So what are those situations? In newborn babies, you give 10 ml per kg bolus. Under 1 year, again, you don't give just 20 ml as a single bolus, you give 10 ml per kg. Reassess. If the child needs more fluid, you give again. Okay. Heart disease, like shock due to cardiac disease, heart failure, that is cardiogenic shock, you give 10 ml per kg because you can't overload with fluid when you have a heart failure. Diabetic ketoacidosis, if you give too much fluids, it can exacerbate or it can cause cerebral edema. So you give only 10 ml per kg. Then dengue shock syndrome. Okay, there will be a separate lecture on dengue. You will be told about that. So this is where you give the smaller bolus. Right. So we look at hypovolemic shock. Now, what happens in hypovolemic shock? Now, there are different types of hypovolemic shock. You can have hemorrhagic hypovolemia due to blood loss, or you can have hypovolemia which is non-hemorrhagic. So what are the causes of hemorrhagic hypovolemic shock? Trauma, GI bleeds, post-operative blood loss, ectopic pregnancy. So these will be hemorrhagic hypovolemic causes. Then non-hemorrhagic causes will be vomiting and diarrhea, which is very common in children. And you will see children, if you do pediatrics, you will see at least 1 or 2 children who has gone into shock with vomiting and diarrhea. Bowel obstruction can cause a lot of internal fluid loss. Okay, burns, diabetic ketoacidosis or dehydration due to any reason, and neglect and environmental. Now, if a child is neglected for a long time, not fed, not given fluids, breastfeeds, and it's a very hot environment, they lose a lot of fluid from sweating, they can go into shock, right? So these are the causes of hypovolemic shock. So what happens, the primary problem is the system is empty. There is very little amount of fluid in the system. So when that happens, now there's sympathetic overactivity, which leads to vasoconstriction to maintain the blood pressure, right? So initially the BP will be normal, but because of the vasoconstriction, the organs are poorly perfused. And finally what will happen is inadequate myocardial contractility will also be there. So this is hypovolemic shock. So these are the common causes. Basically hypovolemic shock you manage by giving rapid fluid boluses. Generally you give 20 ml per kg boluses, but if it is a blood loss, of course, you consider, until blood is available, you can give a fluid bolus. In trauma also you give 10 ml per kg bolus initially. Then as soon as possible you get blood and give blood in hemorrhagic hypovolemia. But otherwise, in these cases you give normal saline boluses. Right. Now distributive shock. So what is distributive shock? I told you earlier, that is basically you have vasodilatation and increased capillary permeability. So you have a change in peripheral arterial resistance due to vasodilatation, change in venous capacitance, venodilatation causing pooling of blood in veins, and a change in vessel permeability causing leaking, right? So what are the types of distributive shock? Anaphylaxis, dengue shock syndrome, sepsis, and neurogenic. So dengue shock syndrome is partially hypovolemic because they lose fluids and there's hypovolemia, but because of the increased vascular permeability, you can consider it under distributive shock. Neurogenic shock means if you get, say, a spinal injury somewhere higher up, you can get vasodilatation. Okay, so these are the types of distributive shock. So what happens? The pipes are too big and too leaky. So the pipes have dilated, so too big to fill, and also there is leaking. So what happens? Vessels dilate, causing relative hypovolemia and a reduction in systemic vascular resistance. Capillary leak worsens hypovolemia and causes edema, including pulmonary edema. Changes above leads to a reduction in blood pressure and organ perfusion. So with adequate fluid therapy, the heart usually compensates by increasing the heart rate and contractility, although this might not be enough. So this is distributive shock. So now, if you do pediatrics, definitely you will see a few children with anaphylactic shock. So they can come with anaphylaxis following vaccination, following wasp bites, following ingestion of some drugs, right? So what are the signs? So like in any shock, you have tachycardia, low volume pulse, and peripheries will be cold and you will have a cold line. The skin capillary refill time will be prolonged. Blood pressure will be low. if it goes into uncompensated shock. Now here, remember, anaphylaxis usually causes vasodilatation. So therefore, the pulse pressure may be wide. So in most shocks, as I told earlier, the pulse pressure will be narrow. But in these types of vasodilatory shocks, you can have wide pulse pressure. And you may actually feel bounding pulse initially. Okay? But you have to look at the whole picture to see this is shock. And you might have postural hypotension. Okay? So how do you manage anaphylactic shock? Remove the causative agent. So if you have, say, a child has sprayed on some perfume and got shock, you have to wash it off, right? Then position the patient flat and raise the legs to make sure the brain perfusion is preserved. And here, remember, anaphylactic shock, adrenaline is the most important drug. So IM adrenaline, the dose is 1 in 1000 adrenaline, 0.01 ml per kg, given IM immediately. Okay. If the child has trido, you can nebulize with adrenaline as well. Okay. And get a cannula in and give a fluid bolus of 20 ml per kg. In anaphylaxis, it's always 20 ml per kg. And you can repeat the adrenaline every 5 minutes, and you can repeat the fluid bolus. But remember, in anaphylactic shock, even before putting the cannula in, if it is anaphylaxis, adrenaline is the most important thing. IM adrenaline. That will actually make the circulation better, and it's easier to put the cannula in. Okay, right. So, what are the important things? Be prepared. You organize a team. Organize adrenaline. If it's anaphylaxis, you have to get adrenaline very quickly. You should have a monitored resuscitation area and how much adrenaline to give. This is a very rough guide. Now, under 1 year, you give 0.05 ml IM, 1 in 1000 adrenaline. 10 years, you give about 0.5 because maximum is that. Adult, you can give 0.5 to 1, but in a child, maximum you give is 0.5. That is the amount you give for a 50 kilogram patient. But if the child's weight is, say, roughly 30 kilos, you can give 0.3. 20 kilos, you can give 0.2. Okay, so you can roughly calculate the amount and give. Okay. Yeah, this is about dengue, but you will have a separate lecture on dengue, so I will skip that. Okay. Now, the next type of shock we'll discuss is septic shock. Now, septic shock has this vicious cycle. What happens? You have infection. Infection causes systemic inflammation. It will cause immune dysregulation. It will cause activation of pro and anticoagulant pathways. So there will be microcirculatory and endothelial dysfunction causing fluid leaking, and there will be vasodilatation also due to these reactants, and there will be endogen damage, right? And endogen damage itself can lead to further inflammation. So this is a vicious cycle, and you can see here typically sort of very severe meningococcal septicemic rash, hemorrhagic non-blanching rash, right? Okay. So this is again meningococcal septic non-blanching rash, okay, hemorrhagic rash which will not blanch, right? Okay. So now if you look at sepsis, severe sepsis and septic shock. So how do you identify these? So you have an infection. Okay, so you have an infection. So infection can be viral, bacterial, or anything, mild, severe, anything. Then you have this, what is called the systemic inflammatory response syndrome, or SIRS. So what is SIRS? I'm sure you know all these things. So either the temperature should be high or low. WBC should be high, more than 12,000, or low, less than 4,000. Okay, or more than 10% band form, so immature forms of white blood cells. Plus, you should have heart rate more than 2 SD above normal range, or less than 1 year old children, you can have bradycardia, and respiratory rate again high. So tachycardia, tachypnea, plus one of these things. So this is SIRS. So when you have SIRS, systemic inflammatory response syndrome due to infection, you call it sepsis. Okay. Then what is severe sepsis? Severe sepsis is sepsis with organ dysfunction. So you have either cardiovascular system dysfunction or respiratory system dysfunction, or 2 other organ failure. So that is severe sepsis. Septic shock means now you have severe sepsis and serious dysfunction needing fluid resuscitation. That is septic shock. Okay. Right. Now we'll talk about septic shock. So septic shock is a vasodilatory shock, and the key features are either the child can be hypothermic or hyperthermic. There will be inappropriate tachycardia. So when you have fever, child will have tachycardia. But here, the tachycardia will be inappropriately high for that degree of fever. Okay. And the altered mental state may be there. And there may be reduced peripheral perfusion and prolonged capillary refill. Now, to call it septic shock, there has to be suspected or proven infection and has at least 2 of the signs of septic shock, which we described before. Now, okay, what are the signs and symptoms of severe sepsis and septic shock? Yeah, these are the general signs. So you can have fever, or hypothermia, either can be there. Tachycardia, tachypnea, altered mental status. Then you can have inflammatory variables. When you do full blood count, you can have high WBC or low WBC. And more than 10% immature forms if you do blood picture. Then hemodynamically, there might be hypotension and hypoperfusion indicated by poor peripheral perfusion. Then organ dysfunction variable. So problems due to organ dysfunction. So hypoxemia, you can check with pulse oximeter or blood gas. Oliguria due to poor renal perfusion. Raised serum creatinine. Abnormal coagulation factors. Raised transaminases and plus or minus raised bilirubin. It doesn't happen always, can happen sometimes. And ileus. Okay. Sepsis can cause ileus. Okay. Right. Now it's very important. Yeah. Other thing is tissue perfusion variables. Now, when you have tissue perfusion is impaired, you can have anaerobic metabolism and lactate level will be elevated. Capillary refill time will be prolonged. Peripheral mottling may be there, and pallor and cold extremities. Now, it's very important to listen to the parents. So you have the critically ill child, you put the cannula in, you take blood for investigations, you give fluids and manage the child according to your guidelines, but make sure somebody speak to the parents and get a history to see what has happened, because sometimes there may be very important clues in the history to see what is wrong with the patient. And because sometimes it's not very evident. When a child is in shock, you don't know what is the cause of the shock. So you have to listen to the parent. Was there fever, right? Was there any agent which could have caused anaphylaxis? Or is this septic shock? Was the child having fever? Any other problems, right? So you have to listen to the parents. Okay. So again, you don't have to worry much about this slide. So this is like American College of Critical Care Medicine, hemodynamic definitions of shock. So just they have defined shock as cold shock. So you know the peripheries are cold with shutting down of peripheries. Or warm shock. You can have warm shock with vasodilatation, like in septic shock and anaphylactic shock. Okay. Then you can have fluid refractory or dopamine resistant shock. Catecholamine resistant shock, which is resistant to like adrenaline or noradrenaline, and refractory shock, which is like refractory to everything. But you don't diagnose refractory shock until you have tried everything and failed. So until you have failed everything, you don't call it refractory shock. Okay. You have your compensated shock, uncompensated shock, and you manage accordingly and try to reverse the shock. Right. So when you have sepsis, you can have, as I said, sepsis, and some of them will become severe sepsis and some of them go into septic shock. So the mortality will be more as you go up. So more mortality in severe sepsis than sepsis, and more mortality in septic shock than in severe sepsis. Okay, easy to understand. Now, key differences between adults and children. Okay, how it looks. So prominence of hypovolemia, right? So in children, more than this Hypovolemia may be more prominent due to fluid leakage. And warm shock versus cold shock, right? So in children, warm shock is less common. Hypotension is a late sign. And signs of severe sepsis and septic shock may be very subtle in children. Okay. And remember, because you always associate fever with shock, in fever with sepsis and septic shock. But remember, in children, you might have severe sepsis, even meningitis without fever, right? So fever is not the only sign of sepsis. So you look at the other things as well. So how it is managed? Now, I think I told you earlier also in the lecture, mechanical ventilation should be considered even in the absence of respiratory failure. So sometimes you have severe shock, septic shock is very severe, you give fluid, maybe 2 boluses, 3 boluses, you start inotropes, child is not improving, and then you decide, okay, you are going to intubate and ventilate, because then you are going to completely take over respiration. So that will preserve a lot of energy for the child, and you stabilize that system. Okay. And with appropriate treatment, the survival is quite high. Okay, so if you manage properly and give antibiotics early enough, the survival is quite high. Right. So management of septic shock, you give high flow oxygen. Any child with shock, you give high flow oxygen. Get access, take blood for investigations. Give a fluid bolus of 20 ml per kg. You can give up to 3 or more boluses. And in septic shock, if you suspect septic shock, never delay antibiotics. So as soon as you get your cannula in and you give your fluid bolus, give a dose of IV antibiotics as soon as possible. Usually you give cefotaxime, okay, or ceftriaxone, third generation cephalosporins. And if the child does not improve after 2 boluses, consider inotrope support early. After 2 boluses, definitely if the child is not improving, you have to consider inotropes. Okay. Now, another point I want to emphasize is any shock, right? You get a cannula in, you give a fluid bolus, and you get a second cannula in. Always have 2 cannulas, 2 functioning cannulas in a child with shock, right? Because one cannula may go out, right? You may have to give, like, while giving fluids, you have to give maybe antibiotics, some other drugs. You may have to control seizures, right? So you should have 2 cannulas. Okay. So this is an example, 2-year-old child admitted with peripheral shutdown with a fluid bolus, child's condition got worse. Okay, so now forget about septic shock. This is a new topic. So you have a 2-year-old child admitted with evidence of peripheral shutdown. Cold peripheries, very low volume pulse, tachycardia. So you give fluid bolus. Child's condition got worse. So now you consider heart disease. So if you give a fluid bolus to a child with shock, and condition got worse, then you think of heart disease. So what are the bedside signs in favor of heart disease causing shock? They might have a gallop rhythm, because when you have a heart failure, poor contractility of the heart, you can have gallop rhythm, and you might have a murmur, right? And the very important, you look for an enlarged liver. If you have a heart failure, there will definitely be a hepatomegaly. Okay, and if you give a fluid bolus, the hepatomegaly will actually get worse. Attend the hepatomegaly, and there will be marked tachycardia. They might have cyanosis despite giving oxygen, and absent femoral pulses in some newborn patients. Now that is depending on the condition. Sometimes they can have maybe a severe aortic stenosis or severe coarctation of the aorta will present with shutdown of peripheries, right? So there the femoral pulses will be absent. Okay. So mainly at any age, most important thing is hepatomegaly, and look for gallop rhythm and murmur, right? Very important. Okay, so cardiogenic shock can be caused by structural defects like septal defects, like large VSDs. Okay, the large PDS can cause heart failure and later go into cardiogenic shock. Then arrhythmias, cardiomyopathy. So child who has been perfectly well before can have a viral infection and get viral myocarditis and go into cardiogenic shock. Okay, then hypertrophic of the heart due to various reasons. Okay, hypertrophic cardiomyopathy, obstructive lesions. Okay, so any of these things can cause cardiogenic shock. So in cardiogenic shock, the central problem is the pump is failing. Right, so you can check for hepatojugular response. You press on the lever and see whether the JVP goes up. sympathetic overactivity leads to vasoconstriction in order to maintain blood pressure. So initially the BP may be normal or high due to sympathetic overactivity, but organs are poorly perfused due to reduction in blood flow. And because of the high venous pressure, the back pressure from the failing heart, it leads to edema, and there's poor myocardial contractility. Okay, so I think I discussed this earlier also. So when you increase your volume, end-diastolic volume, by giving more fluids, the cardiac output will increase up to a certain level, which is called the Starling relationship. Okay, but if you give too much fluids, it will not improve any further. So if you look at what happens in cardiogenic shock, so this is your end-diastolic volume, this is your end-diastolic pressure. So in a normal patient where the compliance of the heart is very good, you can increase the end-diastolic volume. You can give more and more fluids, increase the end-diastolic volume, and the end-diastolic pressure will not rise to a fairly large volume because the heart compliance is good. But in a child with heart failure, somebody with a cardiogenic shock, the heart is quite stiff. So the compliance is poor. So when you give fluid, the end-diastolic volume you can increase up to a certain level, then the end-diastolic pressure will rise and they will develop pulmonary edema. So that's why you can give only a small fluid bolus to a child with cardiogenic shock. Okay, right. Then you have obstructive shock, another type of shock. This is basically obstruction of the cardiovascular system. So it can happen due to compression of the heart, like cardiac tamponade. Okay, so you can have fluid or blood accumulating here, compress the heart. It basically causes obstruction of the circulation. Then you can have pressure onto the great vessels. Now, for example, you have massive hemothorax or pneumothorax, causing mediastinal pushing, mediastinum being pushed to one side, and the aorta and the great vessels are obstructed. Okay, so these are the causes of obstructive shock: cardiac tamponade, tension pneumothorax, pulmonary embolism, or structural obstruction. Right. So what happens in obstructive shock? The pump is obstructed. Myocardium will contract against the afterload. Sympathetic overactivity leads to vasoconstriction in order to maintain the blood pressure. And despite normal blood pressure, organs are poorly perfused due to a reduction in blood flow. So back pressure leads to venous congestion. So here, of course, you don't give fluid bolus. If the cause of the shock is obstructive, you have to relieve the obstruction, because obviously when you have an obstruction, no point giving fluids, right? So if it is a cardiac tamponade, you have to relieve that. If there's a tension pneumothorax, you have to relieve that. So whatever the relevant surgical intervention, right? So if you look at causes of shock and their effect on the heart rate, jugular venous pressure or central venous pressure and the peripheries, cardiogenic shock will have tachycardia. But remember, you can have bradycardia. Now, if the cause of cardiogenic shock is an arrhythmia or a conduction defect like complete heart block, then there will be bradycardia. Or there will be severe tachycardia if it due to something like SVT, supraventricular tachycardia. So cardiogenic shock can occur with normally mild tachycardia, severe tachycardia, or even bradycardia. Right? So it may be confusing. But the jugular venous pressure will definitely be high and the peripheries will be cold. Hypovolemic shock, the heart rate will be high, JVP will be low because of the low fluid volume. Peripheries will be cold. Distributive shock, like in septic shock, anaphylactic shock, the heart rate will be high, jugular venous pressure will be low or normal, but the peripheries can be initially warm, what you call warm shock. Right? Obstructive shock, heart rate will be high. Now the jugular venous pressure will be very high because of the obstruction. The peripheries will be cold. Right. So dissociative shock, as I told earlier under the previous slide with different types of shock. So the profound anemia can cause dissociative shock, carbon monoxide poisoning, methemoglobinemia. So these can affect the oxygen delivery to tissues. So as I told you, oxygen delivery to tissues depends on hemoglobin and arterial oxygen saturation. So this is affected in severe anemia and this is affected in the carbon monoxide poisoning and methemoglobinemia, because the oxygen will not be released to tissues properly. Okay. So again, what are the features of cardiogenic shock? Same thing I discussed earlier. Liver will be enlarged, gallop rhythm may be there, femoral pulses may be absent, murmurs may be present, and hepatocellular response will be present, as opposed to other causes of shock, where normally there's no hepatomegaly, no gallop rhythm, femoral pulses are present, and the murmurs are absent. Okay. Right. Now, general principles of management of shock. So, shock is a medical emergency. Call for help. Can you switch off your mics, please? There are some disturbances. Yeah. Yeah. So, shock is a medical emergency. Call for help. Do not delay therapy. Every hour of delayed therapy increases the mortality. Remember. So, fluid resuscitation in shock starts immediately. So, you start fluid isotonic solution, normal saline I told you earlier. Size of the bolus depends on the type of shock. Hypovolemic shock 20 ml per kg. Septic shock and anaphylactic again 20 ml per kg. Cardiogenic, smaller bolus. Obstructive shock, you have to treat the cause. And immediately life-threatening hypotension, you might have to start an adrenaline or noradrenaline infusion. Okay. So treatment goals, you have to make sure the cardiac output is normal, the blood pressure remains normal in order to keep the tissue perfusion properly. So if you look at the homeostasis of tissues, now when the blood pressure increases, at a certain range of blood pressure, the tissues will be perfused normally. But if the blood pressure is below a certain level, then the blood flow to tissues will be reduced. In a child with shock, especially septic shock, it is even more important to maintain the blood pressure, because their response to fluids will be actually a bit, your autoregulation responses will be a bit impaired. So as you increase your perfusion pressure, the tissue perfusion will improve. Okay, so that's why it's very important to keep the blood pressure up. Now again, if you look at the response to fluids, so when you give fluid, your BP will pick up, your perfusion will improve. But in a child with shock, right, because of the acidosis and in sepsis due to some other reasons as well, your response is impaired. So you have to give a higher dose of fluids to achieve the same effect. Okay, right. So management, immediate priorities: make sure the airway is open, make sure the breathing is happening, give high flow oxygen, monitor saturation, get IV access. I told you earlier, 2 large bore cannula, and if in some cases you might need central venous lines or intra-arterial lines, then inotropes. So you give inotropes generally in distributive shock. You can't say only in distributive shock. Sorry, there's some mistake here. So in sepsis, you can give adrenaline or noradrenaline. And in severe sepsis, refractory to anything else, you might give vasopressin and steroids. Anaphylaxis, again, you give fluids, adrenaline. And if not improving, you can start an adrenaline or noradrenaline infusion. Dengue shock, you can give fluid. If not improving with your initial boluses of normal saline, you can give dextran. You can give blood if there's blood loss. But in dengue shock, remember, you don't normally give inotropes. Okay, right. Now, this is a chart on the actions of vasoactive agents. Of course, you can read this up on what receptors they will act, right? So the resuscitation targets of a child with shock. So your target is to normalize the global perfusion, to keep the BP to at least to the low normal range, keep the warm extremities, sort of make the extremities warmer. There's no pulse differential. Capillary refill time less than 2 seconds, or at least 2 to 3 seconds. And you have to normalize the end organ perfusion. So urine output has to be more than 1 ml per kg power. Mental status should be normal. Lactate levels should become normal. Acidosis should improve. SCVO2 is central venous oxygen saturation, which is something you measure in the ICU setup. You don't have to worry about that. So anyway, basically what you want to do is to normalize the organ perfusion. Now, just one or two things. Neonate with shock. So you might have newborn babies who are normal at birth, but maybe in a day or two they come with shock. So then you have to think of what is called the duct-dependent heart lesions. Okay, so the ductus is open when they are born, but when the ductus closes, they go into shock. So in that situation, you have to start prostaglandin infusion and get immediate cardiology advice. Then another rare cause of shock in neonate is inborn errors of metabolism. Things like hypocalcemia, acidosis. They can present with hypocalcemia, hypoglycemia, severe acidosis, seizures, liver failure, hyperammonemia, right? So these are rare causes, but you will encounter some of them if you do pediatrics. So there are basically three main causes of neonates presenting with shock. One is septic shock is the commonest, then duct-dependent circulation, then inborn errors of metabolism, right? Right. Thank you very much. So I think I've taken like nearly 50 minutes. If you have any questions, I am happy to answer if I have any time left.
Thank you very much, sir.
Okay.
Next lecture will be delivered by Nalin Chitulata, sir.
I can't share my slides. So
Okay, sir. Just
okay, so we'll discuss about dengue management. So here, what I'm going to discuss is early detection and management of dengue hemorrhagic fever. So I'm going to discuss about the current concepts. So this is our national guidelines. So if you read, so this is 2012. So very soon we'll be issuing the new guidelines. So you will see the new guidelines very soon. So anyway, the first thing that I want to highlight is management of dengue is not try to give minimum amount of fluid. So, and management of dengue is not somehow try to give only maintenance plus 5% fluid during the critical phase. But management of dengue HF means maintaining the hemodynamics with minimum amount of fluid. I think you can appreciate the difference between this slide and first two slides. So this is the take-home messages. You have to give minimum fluid in febrile phase, just sufficient fluid in critical phase, minimum fluid in recovery phase, and don't give unnecessary boluses. Because by doing that, we can treat shock, we can avoid organ damage. By doing that, we can prevent fluid overload. We go through, these are the two main causes of death in dengue. You think about the dengue hemorrhagic fever, two main causes of deaths are shock causing organ damage and fluid overload. So if you can prevent both, that should be the way forward. And remember, all the diseases are behaving like this. the normal distribution curve. So there's no exception for dengue. So most of the patients we can manage with maintenance plus 5% fluid guidelines in district hospital. Some may need only about maintenance fluid. So, but remember, about 2.5% of the patients may need huge amount of fluid, interventions beyond guidelines, tertiary care hospitals, and sometimes admission to EIC. Right, we go to the early diagnosis. Any disease, we are relying on diagnosis with history, examination, and investigation. But in dengue, history and examination alone cannot diagnose this properly. So you need an investigation to diagnose dengue properly. So out of these investigations, full blood count in day 3 is the most important. It's a very simple investigation, but that's the most important investigation. Full blood count in day 3, that means after 48 hours of fever, you're doing a full blood count. If your white cell count is less than 5,000, platelet count is less than 150,000, unless proven otherwise, that is dengue in Sri Lanka. So what about NS1 antigen? It's very famous. Nowadays, since we are familiar with the COVID antigens, now we know what is antigen is. So antigens, early detection of antigen can be done in day 1 to 3 of fever, because this is a part of the virus. So until our body produces antibodies, the antigen will be there. So whenever you produce antibodies, this antigen will be neutralized by the antibodies. So antigen will be detected early part of the disease. That is one thing. So you have seen this common graph. So this is the NS1 antigen. So first 3 to 4 days you can detect it. Then IgM coming, IgG coming. So whenever you get the IgG and IgM, those are antibodies, the antigen will be disappearing. And this is very important in primary and secondary diseases. What will happen to the antigen? In primary disease, antigen detection rate is more than 90%. That is obvious because now we take some time to produce antibodies. So the antigen will be there for you to detect. But in secondary disease, antigen detection rate is 55 to 70 because we produce antibodies very quickly. So that's the antigen will be disappearing from the body very quickly. So secondary dengue, it's about 50 to 70%. So be careful because our problem is secondary dengue in Sri Lanka. So to detect our problem, NS1 antigen is basically useless. So be careful when you're doing it. If it is positive, yes, that is dengue. But even if it is negative, it could be dengue. So be careful when you are interpreting NS1 antigen. Then dengue fever versus dengue hemorrhagic fever. Even though we call this hemorrhagic disease, this nomenclature of the hemorrhage is a misnomer. So even without hemorrhages, you can have dengue hemorrhagic fever. So the difference between DF and DHF is plasma leakage. So if you have plasma leakage, we call it DHF. If you don't have plasma leakage, we call it DF. The difference between dengue hemorrhagic fever and dengue fever is plasma leakage. So here I'm highlighting DF versus DHF. The difference is plasma leakage. So you have to detect plasma leakage if you want to diagnose DHF. So then about the clinical course of the DHFs. Now I'm going to discuss about DHF only after this point onwards because that is the important stuff. So I'm going to discuss about DHF. So we have 3 main phases of DHF: either febrile phase, critical phase, and recovery phase. So febrile phase is like any other viral infection. It will be high fever, facial flushing, positive tourniquet test, hemorrhagic diathesis, enlarged liver, they are there. In critical phase, Usually that is after 3 to 5 days of the onset of fever. Rapid drop of temperature will be there, and your starting capillary leak, abdominal pain, hematocrit will be going up, platelets are going down, liver derangement, clotting profile, bleeding, hypoalbuminemia, respiratory failure, fluid overload. You name all the problems of DHF are in critical phase. In recovery phase, you have itchy recovery rash, bradycardia, platelets are going up, and hematocrit is normalizing. So you can see that recovery phase, the child is gradually recovering. So critical phase is the dangerous phase. So if you think about dengue fever, we have febrile and recovery phases, no critical phase. So there's no danger. But in DHF, we have febrile, critical, and recovery phases because it's dangerous. It's in the red area. So that is why DHF is dangerous. So there are some high-risk patients. So if these patients develop in dengue, you have to be more vigilant, you have to be more careful. Infants, obese patients, prolonged shock, bleeding, encephalopathy, underlying diseases, and pregnancy. If one of these patients are having DHF, remember, you will have problems. And this slide is from Thailand. What they say is more than 10 hours untreated shock. We have discussed about shock in the previous lecture. So if there's more than 10 hours untreated shock, death is inevitable. That doesn't mean that the child is going to die after 10 hours. The child will die after about 2-3 days, or sometimes even 2-3 weeks. So after developing multi-organ dysfunction. So more than 10 hours untreated, death is inevitable. More than 4 hours untreated with liver failure, prognosis is 50%. With liver plus renal failure, prognosis is 10%. 3 organ failures plus respiratory failure, prognosis is a miracle. So that is the important stuff. So ideally, we should prevent shock. If you cannot prevent shock, at least treat shock as soon as possible. Shock means, I think previously a gentleman have discussed about this. Shock, early detection of shock means the earliest sign of shock is prolonged capillary refilling time. So if the capillary refilling time is more than 2 seconds, unless proven otherwise, that is dengue, that is shock. So we have to treat, we have to detect shock at that level. Right. So as I explained previously, major causes of deaths in dengue is 2. If you give more fluid, child will end up with fluid overload. If you give less fluid, it can cause prolonged shock. So both are bad. So what we have to do is, we have to give sufficient fluid in critical phase, not more, not less. So if you are giving only sufficient fluid in critical phase, you can prevent death. That's the aim. So if you want to prevent death, sufficient fluid in critical phase. So fluid management should address this. So we are giving minimum fluid in febrile phase because we are not worried about the fluid in febrile phase. We are giving minimum fluid in recovery phase. Again, we are not that worried about the fluid in recovery phase, but you have to give just sufficient fluid in critical phase because then only you can prevent shock. How can you do that? So for that, we have to do certain things. We have to identify the beginning of the leak very correctly. We have to predict the end. Try to give only maintenance plus 5% fluid during this time. Very importantly, match the leak. So we go one by one, identify the beginning of the leak. So how can you identify the beginning of the leak? If your platelets are less than 100,000, if the PCV is rising towards 20%, you have pleural effusion, ascites, low albumin, low cholesterol. If they are there, you know that the child is in leaking phase. Child is having leaking. So that's the beginning of the leak. Then this is also very important. You can see this is my febrile phase, this is my critical phase, this is my recovery phase. So first consider about this platelet graph. During the febrile phase, platelets are gradually coming down. And even in critical phase, platelets are going down. Even in recovery phase, sometimes platelets are going down. But later, it can go up. Now consider about the white cell count. So white cell count initially dropping, but when the patient is entering into the critical phase, white cell count is rising. So initially dropping, and when the patient is entering into the critical phase, white cell count is rising. So if you can detect this point, platelets are still dropping, white cell count is now rising. If you can detect this point, that is the point of entry into the critical phase. That is again very simple way of analyzing this, because as pediatricians, we are so lucky because sometimes parents are doing every day, twice a day, sometimes 4 hours full blood counts. So what we have to do is critically analyze these full blood counts so you can get the answer. Right. Then predict the end. So this is what happens naturally. So initially, you're starting leaking here. Gradually, leak will go up. Maximum leak is around 24 hours. Then leak will go down and leak will stop by 48 hours. 90% of the chance that this is what happens to your patient. So if the patient is starting with critical phase today 12 noon, till tomorrow 12 noon, first 24 hours, child is in ascending limb. We call it ascending limb. Gradually leak will go up. And maximum leak is around tomorrow 12 noon. That is where you expect more shock type of problems. Then after tomorrow 12 noon, gradually leak is going down and leak will stop by another 24 hours, then the day after tomorrow 12 noon. So this triangular picture, we call it, this part is descending limb. This is the start. Ascending limb can develop shock, then descending limb can stop the leaking. So this triangular type of graph, it should be in your mind, in your mind whenever you are planning the fluid in your patient. So then it's the plan of management is very simple. Right. Then you try to give only maintenance plus 5% fluid during this time. So for that, we should calculate fluid for the ideal body weight in obese children. So now we know most of the patients, most of the children are obese these days. So you should not calculate for the real body weight. You should calculate for the ideal body weight. And give only the amount needed to maintain hemodynamics. So again, not to give too much fluid. And frequent monitoring and adjusting fluid, and don't give unnecessary boluses. That is very important. Sometimes people are giving unnecessary boluses. So here, what happens is leaky capillaries. There are so many holes in the capillaries. That is why the fluid is leaking in the. So when you give unnecessary boluses, when you give more and more fluid, the more fluid will getting out of the intravascular compartment. So more and more ascites, more and more pleural effusion. So to avoid that, don't give unnecessary boluses. So this is the most important part. When there is a leak, if I can match the leak, you see the leaking is about 500 ml over 1 hour. If I am giving only 500 ml over 1 hour, I'm not causing fluid overload. I'm not causing poor organ perfusion because I'm replacing what is leaking out from the capillary. For that, we have to do certain monitoring parameters. So important things are you have monitoring urine output, and I have mentioned is 0.5, but with the new guideline, it will be 0.75 to 1 ml per kg power. So what we say is maintain urine output at least 0.75 ml per kg power. PCV, pulse volume, peripheral coldness, capillary refilling time, blood pressure. So we are measuring these parameters to get an idea about the intravascular volume. So maintain intravascular volume, you have to give fluid. So if you go through these parameters, if you have done PCV, it's very cumbersome in children. Sometimes you're getting only very small amount of tissue fluid. So you are putting that into the machine, PCV machine. So machine will evaporate half of it and you will get the number at the end. So we are not 100% sure. Pulse volume, very junior doctor like you will come and say, I can't feel pulse. But senior consultant, like senior intensivist, will come and say, okay, this pulse is enough. Peripheral coldness, same. Capillary refilling time, same. Blood pressure, nowadays is a digital era. You are measuring blood pressure. If the blood pressure is low, you say, okay, we'll check again with another machine. Probably the Japanese one or the German one. So that is also low. Then you are measuring with the manual machine, manual BP count. So now we have 3 readings. Which one is correct? I don't know. So what I'm trying to say is all these parameters are subjective, depending on the patient's, depending on the observer's experience, depending on the quality of the machine, they will change. But the only objective parameter that we have is urine output. So if you have a catheter, if that catheter is not blocked, if the child has passed about 10 ml urine for last 1 hour, it should be 10 ml for me, it should be 10 ml for you, even for the bystander, it should be 10 ml. So that is why we are going behind urine output. So please monitor urine output when you are managing dengue. So when there is a low urine output, so why we are measuring urine output? So when you are having a good urine output, that gives an idea that your renal perfusion is good. So you can't have isolated good renal perfusion. In other words, only kidneys are getting perfusion. So if the kidneys are getting good perfusion, all the other vital organs should get good perfusion. In other words, urine output is good means your perfusion is good. That means your cardiac output should be good. So by measuring urine output, you are trying to get an idea about the cardiac output, trying to get an idea about the tissue perfusion. So when there's low urine output, you have to give more fluid. You increase the amount of fluid, increase the intravascular volume. That is how you react. Please don't give furosemide. So this is again commonly happening. So what will happen? The low urine output is due to low intravascular volume. So you are giving furosemide. The kidneys are forced to produce some more urine, so at the expense of your intravascular volume. So intravascular volume will be depleted further. You are asking trouble. So please don't give furosemide when you are having low urine output. So ideally you should do, you should increase the amount of fluid that you are giving. So because the urine output is very important, in our guidelines, we have put the indications for urinary catheterization. All high-risk patients during critical phase, patient with first shock, patient with complications, patients with platelets of less than 50,000 needs a catheter, because if you want to monitor the urine output in a child, you need a catheter. Otherwise, what will happen? First hour, no urine. People will think, okay, child will pass in the second hour. Second hour, no urine. You are thinking that child will pass in the third hour. The third hour, no urine. Fourth hour, no urine. Now, for 4 hours, child has not passed urine. 4 hours, child has not get adequate renal perfusion. 4 hours, child was in shock. So I told you, if it is more than 4 hours, the outcome will be poor. So to avoid that, you need a catheter. So then and there, you know that the child is producing urine or not. Then this is the natural history of the disease. I told you again. So we are starting leaking here. Gradually leak will go up. Maximum leak is around 24 hours. Then leak will go down. Leak will stop by 48 hours. Starting leaking here. Your ascending leak will go up. Maximum leak is around 24 hours. Then leak will go down. We call it descending leak, and leak will stop by 48 hours. So that's the natural course of the disease. So if I am managing properly, if I am matching the leak, my fluid chart also should be like this. So initially starting with a small amount of fluid, gradually increase the amount of fluid. Maximum fluid amount is at 24 hours. Then rate should come down. And at the end of 48 hours, the fluid is minimum. So basically, you are simulating the leaking in DHM. So this is the natural history. This is what we are trying to do during our fluid management. So they are simulating. So basically, we are matching the leak. See the patient present with shock. Usually, shock occurs at the middle. So first, starting, gradually leak will go up. Usually shock occurs around 24 hours. That means if the patient presented with shock, this 24 hours has already occurred at home. So you have to start monitoring and start managing at this point. So gradually, so initially you need huge amount of fluid, and gradually the fluid rate should come down. After 24 hours, we should be able to cut down or stop fluid. So since this 24 hours is already gone, we have to look after only for about 24 hours. So my fluid chart also should be like this. So initially you need huge amount of fluid. Gradually fluid rate should come down. And at the end of 24 hours, you can stop or minimum amount of fluid. Again, you are simulating the natural course of the disease. So this is the natural course, and this is what happens during the fluid management. But most of the patients are managed like this. We are trying to give very small amount of fluid, and you are waiting without doing anything. So you cannot manage dengue like this, because that dengue is a disease which has a natural history. We have to respect that natural history. We have to match the leak according to this natural history. So what are the fluids that we can give? Only 2 types of fluid. isotonic crystalloid for infusion as well as boluses. Most of the time we are using normal saline. You can use Hartmann's. This is for the infusion as well as boluses. But hypertonic colloid only for boluses. Now we are using only 40% dextran, nothing else as colloid. So this colloid should be only used, should be only as boluses, not as infusion. So what are the indications of colloid? So if the child develops shock, we are giving normal saline. So if you're suspecting dengue, your first bolus should be 10 ml per kilo normal saline. So there are few conditions that we should give 10 ml per kilo in the management of shock. One is dengue, one is DKA, then trauma, and neonate. Those are the 4 conditions that use 10 ml per kilo as the management of shock. All the other places is 20 per kilo in a way. So in dengue shock, you are starting with the first bolus, 10 per kilo normal saline. You are reassessing the child. The child is still in shock. You give the second bolus, again 10 ml per kilo normal saline. So after the second bolus, you are reassessing the child. The child is still in shock. Now this is the time to give dextran. So after 2 crystalloid boluses, we are giving dextran. So if the patient is having shock and already having fluid overload, then we have to give dextran. Then if the child is having shock and going towards fluid overload, again, you have to give dextran. So these are the indications for dextran. And how do you give colloid? This is only during the critical phase. Please don't give dextran beyond critical phase. Only as boluses, no infusions. Bolus is 10 ml per kilo dextran. No halfway, no 5 per kilo, it should be 10 per kilo. Maximum 3 boluses in 24 hours, 6 in 48 hours. Right. So when there's the response is poor, so you are giving first bolus normal saline, reassessing, still in shock. Second bolus normal saline, 10 per kilo, reassessing the child, still in shock. Third bolus dextran, 10 ml per kilo, reassessing the child. So if the child is still in shock, then you have to think about A, B, C, and S. A for acidosis, B for bleeding, C for calcium and electrolyte, S for sugar. So first bolus 10 per kilo normal saline, second bolus 10 per kilo normal saline, third bolus 10 per kilo dextran, after that ABCS. Little bit about bleeding in DHF. So there will be 2 types of bleeding in DHF. One is overt bleeding, that you can see the blood, hematemesis, melena, sometimes menorrhagia, so you can see the blood. And more commonly, you will have concealed bleeding. That means bleeding is there, but you cannot see the blood. You cannot see the bleeding. So how can you detect? That is very important. So when we are managing dengue, we know if the child is deteriorating, my PCV is going up because it's leaking, the PCV is going up. So when the child is improving, your PCV is going down. So in our child, if the PCV is going down and child is clinically deteriorating, that is not telling, right? So usually when the PCV is going down, we are expecting improvement. If the PCV is going down, but the child is not improving, that's the time that you have to think about bleeding. So low PCV without clinical improvement, that means bleeding. So then we have to give blood. So management of bleeding is by blood transfusion and not by other blood products. No FFP, no cryo, no platelet. We have to give blood. So usually we are giving blood. This is what I mentioned initially. So suspicion of concealed bleeding, PCV drops without clinical improvement. So we have to give blood. So when you are giving blood, it should be 5 ml per kilo pack cells, nothing else. No whole blood available in Sri Lanka. No 10 per kilo, no 7 per kilo, no 3 per kilo. It should be 5 ml per kilo over 1 hour. So if you give 5 ml per kilo over 1 hour, your PCV will increase by 5 points. That is also very important in the management of DHF. So if you are having bleeding, management is blood. In hypocalcemia, again common cause of conversion in DHF. So you have to use empirical calcium in complicated DHF and deteriorating DHF. Again, not for all. So just by diagnosing DHF all the children doesn't need calcium. So dose is 10% calcium gluconate, 1 ml per kilo, maximum is 10 per kilo, and dilute in equal volume of normal saline, give as a bolus. Hyponatremia, again common, cause of conversion in DHF, can cause cell edema and coning. So use only isotonic fluid in DHF. The 2012 guidelines says in certain categories, we can use N/2, but we are going to remove that during the 2022 guidelines. So only isotonic fluid. Normal saline is the ideal fluid. So I told you, this is the natural history of the disease. So you are starting leaking here, gradually leak will go up, maximum leak is around 24 hours, then leak will go down and leak will stop by 48 hours. Starting leaking, ascending leak, maximum leak is around 24 hours, child can develop shock. Then descending leak, gradually leak is going down and leak will stop by 48 hours. If you are managing, this should be the way to manage. If the patient present with shock, you know the patient is somewhere here. The first 24 hours is at home. So now patient is here, you have to use huge amount of fluid initially and fluid rate should gradually come down. So if you analyze the chart, ideal chart should be like this. Initially you are giving high amount of fluid, gradually fluid rate should come down. So, but most of the time, what we have seen in our practical setup in ICUs is this. Then I thought we have to think about the treating physician's mentality. Why this is happening again and again. So you are trying to give minimum amount of fluid. You are giving only 2 ml per kilo. Then all of a sudden, we need to give a bolus. Why is that? The child develops shock. The child develops shock because this 2 ml per kilo is not enough to match the leak. This 2 ml per kilo is not enough. Child develops shock. You are giving a bolus. So after the bolus, child is improving. Capillary repeating time is improving. Urine output is improving. So we think, okay, we have done a marvelous job. So we are cutting down fluid back to the 2 ml per kilo. That is not rational at all. This 2 ml per kilo is not enough. That is why this child develops shock. At least after treating the shock, we should have increased this 2 ml per kilo for about 4 to 5 ml per kilo. After about 2-3 hours, since we are not given fluid, again child develops shock. This time we are giving a dextran. Now again cutting down fluid because the child is improving and go back to the 2 ml per kilo. And again child develops shock. Normal saline, blood, and MICU. This is happening again and again and again. So please try not to do that. That is why I call management of DHA is not try to give minimum amount of fluid. It is not somehow try to give only maintenance plus 5% fluid in the critical phase, but the management of DHA maintain the hemodynamics with minimum amount of fluid. So our aim is somehow maintain the hemodynamics. We want to maintain the intravascular volume. We have to maintain the urine output. We have to maintain the capillary refill time, but with minimum amount of fluid. Not like in septic shock, we are not free to give huge amount of fluids. That is what the management of DHF means. We are very happy to see this type of graphs. So initially you are starting with a small amount, gradually fluid rate is going up, then it is going down. So that's the ideal chart in the management of DHF. So this child is a real child that we have managed. This is our ICU. So you can see that there is an ET tube. There are 2 IC tubes, 2 PD catheters. So 3 organ failures on ventilator. We know the prognosis is miracle. In fact, this child died, but we tried maximally. Even with that, we are trying maximally, but we want to avoid this happens. So briefly, 2 case scenarios, just to illustrate, just to give some overview of the management. These are 2 real cases. 8-year-old child, weight is 40 kilos, admitted to district hospital on day 2 of fever. Henderson antigen was positive. So there's no delay in the part of parents. So they have admitted the child very early. The first shock was detected in day 4. Child had melena and pancreasite bleeding, transferred to Laryngeal Children's Hospital in latter part of day 4. So they have given normal saline with 5% dextrose, 2 ml per kilo for 11 hours, 2.5 ml per kilo for 9 hours, dextran, so-called 5 ml per kilo, 3 boluses, and 10 per kilo, 1 bolus. If I put into a chart, it's like this. So you're giving very small amount of fluid. You can see the PCV is 37, 48, 47, 50. PCV is rising. The pulse rate is high, tachycardic. Blood pressure is marginal. And look at the urine output. No, 1.1, 0.9, 1.04, no, 0.6, 1.04, 0.4, 0.4, no, 0.3, 0.4. 1, 2, 3, 4, 5. So 5 hours, child was not having good urine output. And the PCV is going up. So that means you are not giving adequate amount of fluid. So you are giving very small amount of dextran, again cutting down fluid to 2 ml kilo, another dextran again. So that is how it happens. So not catheterize, not mesh the leak, ignore the pulse rate, urine output, and the PCV. So this is what happens. So this is the saturation on admission was 85, dyspneic, peripheries are cold, pulse volume is very low with rapid rate with 161, BP 91 by 36, abdomen is distended, PCV is 42. So this is what happens. Initial SGPT was 67, going up to 7,500. Initial SGOT was 41, going up to 20,039. So at the end, child died of liver failure. So we could have easily managed this child, prevent this death if we have given adequate or sufficient amount of fluid. So another one, a 5-year-old child with 16 kilos. And this one directly admitted to MICU LRH because his mother is a dermatologist. We have done the same thing. We have started with the 3 ml per kilo fluid. We have monitored carefully. Look at the urine output: 1.8, 1.5, 1.2, 0.75, 0.71. So I don't have to have a big brain to say that initially when you are giving 1.8, when you are giving 2 ml, 3 ml per kilo fluid, child is producing 1.8 urine. Now we are giving same amount of fluid, 3 ml per kilo. Now the child is producing 0.71 of urine. Urine output is gradually coming down. So you don't have to wait till this magic mark of 0.5 to say that we are not giving adequate fluid. We thought, okay, urine output is coming down gradually, so we should give more fluid. So we have increased fluid to 5 ml per kilo. As soon as we increase the fluid to 5 ml per kilo, 1.2, 2.6. So is it too much? We are giving down 5 ml per kilo fluid. Then we cut down to 4, even with that 1.8. Then we thought, okay, we should be able to come down to 3. So when you come down to 3, the urine output drops again. So this child's leak is between 3 to 4 ml per kg power. So we have increased the fluid rate to 4 ml per kg power. Later we had to give 2 blood transfusions, 1 dextran, but we have maintained all the parameters. So SGPT initially 49 goes up to 103, and 110 has got up to 225. So child went home without any complication because we have maintained the intravascular volume. Right. I'm going to skip these. So the difference between life and death in DHF is urine output. So if you are maintaining urine output without giving fusimide, the child will go home. If you are not maintaining urine output, child will die. So that is the simple message that I want to say. Please give sufficient amount of fluid when you're managing DHF. And as I mentioned, 2 causes of deaths of DHF is fluid overload and poor organ perfusion and multi-organ dysfunction. So if I want to select, I would definitely select the fluid overload, because as an intensivist, I know a lot of ways to manage fluid overload than managing multi-organ dysfunction. So whenever you're having a choice, please go to the fluid overload side rather than multi-organ dysfunction and the poor organ perfusion side. So these are the common pitfalls. Not simulating natural cause of the disease. Try to give minimum amount of fluids. Cutting down fluid just after bolus. Not try to prevent shock. Not giving blood early. Not sending the child to ICU early. Because ICU care is critical care, not fulminant care. So take home messages: minimum fluid in febrile phase, just sufficient fluid in critical phase, minimum fluid in recovery phase. Don't give unnecessary boluses. So by doing that, we can treat shock, avoid organ damage, and we can prevent fluid overload also. As I mentioned, these are the 2 main causes of death in dengue. So if you can prevent both, invariably child should survive. So thank you very much. So we want this type of patients, not the previous type of patient. Thank you very much.
Thank you very much, sir. Next, there will be lunch time until 1:45. Please join once again sharply at 1:45. Thank you.
So lunch break till 1:45. Join by 1:45.
IV fluid lecture will be done by Dr. Viraj Jasina, sir.
Good afternoon. Thanks, Nadishan. So, good afternoon, everyone. I'm Viraj Jasina, pediatrician at PCU at LRH. So, I'll be discussing about IV fluids. And if you have any questions on the way through, you can always put up in the chat box and I'll be happy to answer, right? So, just a basic discussion. Basically, now, since the topic is IV fluids, doesn't mean that you have to start IV fluids in the first instance that you get an opportunity. So it's always like trying to delay all sorts of invasive procedures for children, like if possible, right? Of course, if a child is in shock and is in severe dehydration or in heavy moderate dehydration with continuous vomiting, if there's a real indication, of course, yes, by all means, you should not delay starting IV fluids. But in other instances, please try the oral route first and see whether that works or not. Because by giving IV fluids, actually, it's a bit of a traumatizing experience for the kid, right? Mentally as well as physically, it's quite painful, right? We don't use analgesic, and local anesthetics like in other countries. So try not to do many invasive procedures as possible. And also, it's a portal for infection. So it can lead to sepsis if you leave a cannula, right? So by all means, try to avoid it if possible. And the other thing is, if the cannula goes out, then there is fluid accumulation around that limb, can cause severe pain, right? So that is also not very good. And then again, when we give various IV fluids, even though we look at it very carefully and give, still it can lead to fluid overload, then electrolyte imbalances. So whenever possible, try the oral route, failing which we go for IV, right? And of course, since you're starting an internship, you can always get the help of your seniors, right? Whenever you're in doubt. Right? So that doesn't mean that if there's a real indication that you're going to delay, you're going to start straight away then. But doubtful cases, you can always discuss. Right. So first of all, right. So just to get an idea, since we are talking about IV fluids, just to get an idea about the fluid compartments in the body, as you all know, intracellular compartment, which is the fluid that is inside the cells, comprises about 2/3 of the whole body fluid volume, and extracellular contains about 1/3 of it. Then again, in extracellular space, there are three main areas. The one we are very concerned about is the plasma. That is the intravascular compartment, the amount of fluid that is inside the cells. So it contains plasma. Then, of course, the interstitial fluids, that is around the cells, there is some amount of fluid, and the CSF, right? So these are the main compartments. Right. Now, again, the compositions. If you look at sodium and potassium, sodium is more in the extracellular compartment, that is inside the vessels, the intravascular compartment. It has more sodium than inside cells, whereas potassium, it's the opposite, right? Chloride again is more in the intravascular compartment or outside the cells, right? So the importance here is, we discussed about these two main anions. Sodium is the key molecule which is responsible for osmolality in the body. So if there is a huge shift of sodium, that can cause an osmotic gradient, and then can cause either cerebral edema or cerebral shrinkage and cause a lot of issues. Same with potassium. If potassium values go up and down, it can cause life-threatening cardiac arrhythmias, right? So you have to be very careful with these electrolytes as well. Right. Now, okay, just you can put up in the chat box now. So if you are the house officer and you get a call saying that, okay, sodium is 180 in a patient whom you have set the electrolytes in, are you worried or not? Worried? Just put up in the chat box so that I can know whether you're worried or not. If someone says sodium is 180, are you happy? Is it difficult to just put up in the chat box so that we can see? Yes, worried. Right. Why would you be worried? So it can cause Actually, what it says, high sodium levels can cause acute pontine myelinolysis. That is one thing. And the other thing is, due to cerebral shrinkage, it can cause hemorrhages in the intracranial hemorrhages, as well as if you treat it very quickly, right, very ambitiously, if you start treating and sodium drops very fast, can cause cerebral edema, right? It's a killer. So high sodium, it's a red flag. Call your seniors, manage appropriately, right? Then you get another report, right? Another report. 120 or 124. Are you equally for it or not, like slightly less for it? What do you think? Just put up in the chat box so that, you know, it's like a discussion so you understand, right, what I tell you all. Would you be worried? Now, you are worried about high sodium. Now, are you worried about low sodium as well? Anyone? Okay. So, seems that you are not too worried, right? So, no one's answering. Less worried. Okay. But I would say it's the same, right? So, that's what we are always, like, you know, trained to worry about a high sodium level, but not a low sodium level. Again, I would say now here, high sodium, when you're treating, you're worried about cerebral edema. But low sodium itself can cause cerebral edema. So we'll see how it causes, right? So this is also equally life-threatening. Can cause convulsions, right? So you need to be careful about hyponatremia as well. Good. We'll go to the next slide. Right, just a case. Now, a 7-year-old child is a real case who had come to LRH, had fever for 7 days. And then, so child was supposedly in the recovery phase and was asked to give fluids overnight. So, but the mother was not specified what sort of fluid to be given. So what was available to her was water. So she was giving plenty of water to her to the child overnight. And then in the morning, child was found to have convulsions next day morning. And then child needed ventilation and died 2 days after. So what do you think is the cause here? Anyone? What is the cause? Just put up there. We'll be quick, otherwise we won't have time. What do you think is the cause for this convulsion and the deterioration? Okay, difficult to think? Okay, let me put the answer. Right. Okay, someone answered. Let me see. Yes, very good. Hyponatremia. So what is the reason for the hyponatremia here? Can someone put it up here in the chat box? What do you think is the reason for the hyponatremia? Because as we discussed earlier, in the intravascular compartment, it has a sodium value of 135 to 145 or 150, right? Now, what happens? You start giving plenty of okay, someone has is hypotonic fluid. That's the answer, right? That's the answer. Fluid overdose can occur, but the main issue here is hypotonic fluids. So we are giving a lot of hypotonic fluids and sodium gets diluted. So it was 150 earlier. Now it drops to 140 earlier. Now it drops to 130, then becomes 120, 110, hyponatremia, hyponatremic convulsions, cerebral edema, and the child dies. So that is the danger of just giving plain water to a ill child. Okay, next case. Ten-year-old acute liver failure having hepatic encephalopathy was being given N-acetylcysteine IV and unequal pupils and ventilated. Again, the cause is hyponatremia, right? Sodium 122. Why do you think the sodium became 122 here? Okay, one thing is hepatic encephalopathy itself is a known like a precipitating factor for hyponatremia. That is one thing. What is the other reason? What do you think of this NAC infusion or the N-acetylcysteine infusion? Any reason why it could cause hyponatremia? So classically, people used to give N-acetylcysteine in 5% dextrose. So 5% dextrose is again a hypotonic fluid, right? Okay, isotonic. So there are 3 types of fluid: isotonic, hypotonic, and hypertonic. So isotonic fluid is the osmolality of the IV fluid is equivalent or compatible with the intravascular osmolality. That is isotonic, right? Something like normal saline or 0.9% saline or in the lactate. And then you have half normal saline, which has half the sodium of normal saline. So it has the osmolality is half that of normal saline, or half that of intravascular osmolality. So that is a hypoosmolar or hypotonic fluid. And then you have 3% saline, which has a lot of sodium, which is a hypoosmolar or a hypertonic fluid, right? So those are the three types of fluid, right? Okay, so remember now here again, hypertonic fluids were given with the NAC causing hyponatremia. Right? Then again, another child, paracetamol overdose, same issue. NAC given the 20-hour protocol, lot of fluids. Again, with 5% dextrose. Child coming to ICU, needing intubation for several convulsions and cerebral edema, and then having a lot of issues. Right? Okay. What do you think of this? A 7-year-old herpes encephalitis, right? And then CT shows cerebral edema, low GCS, admitted to a laryngeal mask. Child had been on N/2, 5% dextrose. What do you think of this fluid? N/2, 5% dextrose. Isotonic, hypertonic, hypertonic. Can someone put up in the chat box so that I know that you got what I told? Is it hypertonic, this fluid? Is it hypertonic, isotonic, or hypotonic? Okay, so N/2 is hypotonic, right? Because as I said, sodium is low, right? But when you add 5% dextrose, the actual osmolality goes up. It's almost equivalent to, it's quite high osmolality. But the moment you give 5% dextrose, what happens to that in the body? When you give 5%, yeah, okay. When you give 5% dextrose, what happens to it? Dextrose is taken up by the liver, glycogen. Then the osmolality drops. So actual osmolality is hypotonic. So it's a hypotonic fluid, right? So which can cause the same issues, hyponatremia, hypoosmolality, and then cerebral edema, right? Okay, good. If you don't understand, please ask any questions, right? Right now, so we were talking about osmolality. Osmolality is mainly dependent on these three components: sodium, glucose, and blood urea nitrogen. But if you can remember, blood urea nitrogen goes inside the cell as well as it's there in the intravascular compartment, equally distributed. Does not cause an osmotic gradient, so doesn't affect many fluid shifts. Glucose, when there is adequate amounts of insulin properly regulated, so then again it doesn't cause many fluid shifts. But sodium, on the other hand, is a very variable sort of a molecule if you are giving IV fluids, because most of the fluids contain sodium, right? Or doesn't contain sodium. So if the sodium level goes up or down, it can change the osmolality in the intravascular compartment, right? Which will cause fluid shifts. So which is very dangerous, right? So we look at this. Now this is the intravascular compartment. This is a cell. So this is a blood vessel. This is a cell. Now you see sodium is equally dispersed, right? So sodium is more on this side, and then there are osmoles inside the cell as well. So here the osmolality is 280. Here again 280. There is no major fluid shift. So in good equilibrium. But now if you look at this one, this is a diabetic child where there is no insulin. So more glucose on this side. Insulin without insulin, glucose cannot enter the cell. So high osmolality here. Okay. Normal osmolality here. So comparatively low osmolality. So there is a fluid the osmotic gradient. So fluid shifts from low osmolality to high osmolality. So fluid shifts from the brain cell out to the intravascular compartment, right? So what happens? The brain cell shrinks. So if there are bridging veins and stuff like that, can get torn, can cause hemorrhages. And at the same time, if you correct this this sugar very quickly with insulin boluses, sugar drops very rapidly. So the 320 sugar can drop very rapidly. That can again cause low osmolality in the intravascular compartment, right? Which will reverse the fluid shift and will cause cerebral edema, right? So always remember, if you give hypotonic fluids, it can cause cerebral edema. So n by 2 saline, n by 5 saline if you use can cause cerebral edema, right? Let's see now. So we have the extracellular fluid, right? That is, we'll say it's inside the blood vessels. So this is your brain cell. So this is the blood-brain barrier, right? And now, earlier, osmolarity is equal. So no cell shrinkage or no cell edema. Now, we are giving n by 2 saline, n by 2. Sodium is 77. Osmolarity is 144. Here it's 280, right? So, still hypoosmolar or hypertonic fluid, right? So, moment you start giving this, osmolarity in this compartment drops, reduces. Now, osmolarity drops to say about 150 or 200. Now, there is an osmotic gradient. Low osmolarity, high osmolarity. So, fluid shifts from low osmolarity to high osmolarity. Now, what happens? Brain cell gets edematous, causes cerebral edema. Now, what is the problem with the brain cell swelling? There is a thick calvarium, right? It's a thick calvarium which doesn't allow the brain to expand. Now, the only way out is through the foramen magnum. So, brain cones or herniates, compressing all the vital structures, the respiratory center, the vasomotor center, which are on the medulla oblongata, compressing them, right? So that will kill the patient. So that is the danger of giving isotonic fluids, hypotonic fluids or low osmolarity fluids like n by 2 or n by 5 or 5% dextrose, which will cause death, right? So most important principle in medicine or treating patients is do no harm. So the patient comes in dengue, we were treating that, he was all right, we gave just isotonic fluid, hypotonic fluid to drink, went into hyponatremia, and patient died. So we are doing more harm by giving something inappropriate, right? So now the next question. What is the IV fluid that we are going to choose? What sort of IV fluid then? What are we going to give? If we can't give a hypotonic fluid, we have to give an isotonic fluid. Then what are we going to give? Now, if you look at it, as we discussed earlier, if the sodium content is low, like in n by 2 or n by 5, causes hyponatremia. As we discussed earlier, hyponatremia causes cerebral edema, which can cause permanent brain damage and death. Also, low sodium can cause seizures. So it's very dangerous. So then why do we use, why people used hypertonic fluids in pediatrics? So people are worried. Are there any adverse effects? Does it cause hypernatremia if we use normal saline? So they had done studies and the conclusions were, okay, so there is no increase in risk of hyponatremia if we use normal saline. And there is no difference in percentage of any adverse outcomes, right? So the conclusion is we have to use isotonic fluid, no hypertonic IV fluids, please, right? So we should do no harm, give normal saline or lactated rigor or heart monitor, right? which are isotonic fluids. Okay, so and the other point here is in very ill children, right? They have SIADH, that is if they have CNS infections, respiratory GI infections, right? And all these conditions, there is inappropriate secretion of ADH. So what does ADH do? It retains water. So now there is a tendency for hyponatremia because it retains water and sodium is going with urine, but water is being retained. So high chance of hyponatremia, and you are giving n by 2 saline, which has 77 millimoles per liter of sodium, whereas your body has something like 135 to 45. So you are increasing the chances of hyponatremia and cerebral edema. So very dangerous, right? So always be careful about hyponatremia in patients like this, right? Right, now just to see what are the compositions of fluids that we use. So normal saline, almost compatible with the sodium level as well as the osmolarity is not mentioned here, but it's isoosmolar, right? Isotonic fluid, right? As well as Hartmann and Ringer's lactate, again 130, 131, right? And so the osmolarity is almost similar to the intravascular compartment. But here now, if you look at half normal saline, sodium is 77, going to cause hyponatremia, right? 1 by 5, like n by 5 saline, right? Again, 30, so very low sodium, again can cause hyponatremia, so very dangerous, right? So, right? So that's so the fluid of choice is 0.9% saline or Ringal lactate or heart. Right. So something additional just to show you. So these are the contents of the compositions of various fluids. Like, okay, if there's a lot of vomiting, gastric juice, right? We lose a lot of sodium as well as potassium. So when we are giving IV fluids, you have to think of this potassium as well. So you need to add that, right, to the fluids, right? Because there's a chance of hypokalemia, right? And so there is no bicarbonate loss. So instead, what is lost when there is vomiting? Does it cause acidosis or alkalosis? In a child with pyloric stenosis, is it acidosis or alkalosis? Can anyone say that, please? Acidosis or alkalosis? Vomiting. Pyloric stenosis? When you lose a lot of bicarbonate, what will happen? Sorry, when you lose a lot of H+, yes, let's see someone. Yes, alkalosis, very good, right? So it causes alkalosis. Whereas diarrhea and small intestinal obstruction will cause bicarbonate to be lost. So when bicarbonate is lost, it will cause acidosis, right? That's how it works. Okay. Now, these are some of the oral drinks that we use when we are rehydrating a patient, right? So now if you look at it, these various fruit juices don't have much of sodium. So, and milk has a decent amount. But again, with if you look at WHORS, it has the most amount of sodium. So that is the preferred fluid if you are rehydrating a diarrhea or rehydrating some losses, right? So remember that WHORS. Look at the sodium level, right? 70. Others it's very low, right? So this is the preferred fluid. So what is the amount? So two questions we have to ask. Is the child shocked, or is he dehydrated, or is he a normal child? You need some, pre-op, you need to keep it by mouth. Then of course the amount changes, right? So there is something called the Halliday-Segar formula. So it's dependent on these principles. I will not go into details since we are running out of time. So these are the fluid requirements. These are maintenance fluids. So in a child, otherwise, who is not vomiting, no diarrhea, right? This hydration state is all right. Not having shock. So we just want to put some IV fluids, right? In a non-dehydrated patient. First 10 kilos, 100 ml per kilogram per day. Second 10 kilos, 50 ml per kg per day. And each additional 20 kilos, each additional kilo, 20 ml per kilogram per day, right? That is the fluid requirement, maintenance fluids. Then electrolytes, of course, requirement is sodium is 3 milliequivalents per 100 ml per day, right? And then per kg per day, right? And then potassium also 2 milliequivalent per kg per day, right? Okay, now let's go into shock. Now, if a child comes in shock, the bolus is 20 ml per kg. Either we use Hartmann or 0.9% or normal saline, right? Only these two fluids. Nothing with dextrose, no normal saline plus 5% dextrose, right? It's just normal saline and Hartmann. What are the exceptions? Where do we use 10 ml per kg boluses? Can anyone say that? Any other? So if a child comes in shock, you don't give 20, but you give 10 ml per kg. What are the instances? Can anyone guess? I'm sure you are taught in your medical schools. Can you put up in the chat box? Yes, someone said. Okay. Yes, good. Heart failure or cardiogenic shock, dengue hemorrhagic fever, that is compensated DHF instance, compensated shock, right? And then DKA, okay, 3 are ticked. Then what else? Okay, neonates, very good. And the other thing is trauma. A patient with trauma comes into shock, right? Okay, not less than 1 year, generally neonates, right? Okay, so that's very good. You all know everything. Great, right? Okay. So Always, if you have a patient in shock, airway breathing circulation, give the bolus, reassess airway breathing circulation. See whether that bolus is enough or not, or whether you need to repeat. Okay. So if it's a patient who's dehydrated, once the shock is treated, you might need to have a rehydration plan. Let's talk about it, right? Okay, so this is dehydration. So percentage of dehydration. So this I won't go into detail. Just remember, if these features are there, say just dry mucous membranes, but the output is not so bad, right? Maybe the eyes are also a bit dry. Then there is some no dehydration or mild dehydration, you call it. So the deficit is less than 5%. So this is moderate dehydration or some dehydration according to WHO, 5 to 9, right? So here there is oliguria as well as sunken eyes. But here the child is not in shock. Here also child is not in shock. Here also child is not in shock. But when you go for severe dehydration, when the dehydration is like when you had lost 10% of your pre-illness weight, then it's a severe dehydration. Then you can have shock, right? So delayed capillary fill, acidosis, lethargic can rouse the child, right? And then, right? And then there is hypertension, right? So all those things are there. It's a severe dehydration. This is so when you by those clinical signs, you know whether it's a 5% dehydration, 10% dehydration. So mild, severe. Moderate is in between 5 and 10. That is 7.5. So what? So for a 5% dehydration, you have to give the deficit is 50 ml per kilogram. Here, again multiply by 10. So 75 ml per kg. Multiply by 10, 100 ml per kg. So this is the deficit. And this could be given over maybe 24 hours or 48 hours, depending on the sodium levels, right? That you have to be very careful about. Okay. So this is just an example. A 25 kilo child, how the fluids are done. So I'm sure you're all right with that. And this for a dehydrated child with 10% dehydration, right? What is the deficit? So when you calculate that like this, so 25 kilos, first 10 kilos, 1,000, 100 into 10. Next 10 kilos up to 20, 15 to 10, 500. So next, it's a 25 kilos. So every subsequent kilogram, it's 20 ml per kg. So 5 into 20 is 100. So 1,600 is maintenance. Then the amount of dehydration is 10% dehydrated. So 100 ml per kg. Weight is 25. So the deficit is 2,500, right? So add it up. So this is the total amount of fluids to be given, right? But careful, we might not give this over 24 hours, right? This deficit might be given over 48 hours, depending on the sodium levels, right? So remember that. Right. So because that's as I said earlier, hyponatremia, if corrected too early, hypernatremia corrected too early can cause cerebral edema and death. So be very, very careful when you have a patient with abnormal sodium levels. Hyponatremia, both are life-threatening. Okay. These are WHO formula, which I will not go into detail, which we don't do much because we go according to the APLS method. And here you are giving a huge amount of fluid and you have to monitor the patient very frequently, right? So fluid management is treat shock, calculate maintenance fluids, deficit fluids, and ongoing losses. So if there are any more other diarrheal losses, you might have to give 50 to 100 ml, right? Depending on how many stools he passes, right? Per each stool. Then start your infusion, keep reassessing every 4 hours. So fluid management in a critically ill child, it's always isotonic fluid, normal saline or galactate or heart, right? So then amount decided depending on the underlying disease. So if it's a meningitis with cerebral edema, we have to give 100% maintenance. I will explain to you in the next few slides why we do that. Heart failure, we cut down to 80% of maintenance because if there's a lot of fluid, more work for heart, right? So heart has to pump a lot of fluids, heart failure worsens. So we generally cut down to 80% of maintenance, right? Okay. So meningitis and encephalitis, main point is to maintain cerebral perfusion pressure. That is, you need to give blood to the brain. Otherwise, brain becomes hypoxic, right? So this is the formula, right? So map the mean arterial pressure, that is between systolic and diastolic, right? So mean arterial pressure, right, tries to perfuse the brain, but ICP, the intracranial pressure due to cerebral edema, various other things, right, tries to put pressure on these blood vessels and reduce cerebral perfusion pressure, right? So MAP minus ICP is the cerebral perfusion pressure, right? So we have to increase MAP to increase the cerebral perfusion, and we have to take measures to decrease the intracranial pressure to increase the cerebral perfusion pressure. If you look at it, how do we increase the cerebral perfusion pressure? Increase MAP by giving good volumes. So that's why we don't cut down fluids. So if you cut down the volume, anyway the MAP will drop, and then cerebral perfusion pressure will anyway be low, which is going to be detrimental, right? Then inotropes and vasopressors. Then how do we decrease ICP? We can use 3% saline, mannitol, or you can put a external ventricular device or do a craniectomy, right? Those are neurosurgical maneuvers. So as medical people, what do we give? What do we prefer, mannitol or 3% saline? So both have its own merits, right? Some people prefer this to this, right? But generally they say if you use 3% saline, it increases the MAP as well because it's additional volume, and then decreases the ICP. That way, so as we said, increases MAP, reduces ICP, so good cerebral perfusion. Here, if you take mannitol, it's osmotically active. So it again reduces ICP very good, but it reduces MAP as well because it dilates vessels and causes diuresis. It's a diuretic. So then your MAP falls. So ICP also falls, MAP also falls. So theoretically 3% saline is better, unless of course the neurosurgeon wants this mannitol before surgery. We generally prefer to give 3% saline for cerebral edema in a pediatric patient. Okay, quick word about acute liver failure, hepatic encephalopathy. They are more prone to hyponatremia. So remember, no hypotonic fluids, and they are more prone to cerebral edema, right? So when we are giving N-acetylcysteine as a therapeutic modality for acute liver failure, always don't dilute in 5% dextrose. Use normal saline. Right. So summary, we talked about normal maintenance, Holiday-Seger formula. So if the patient in shock, there are most of the instances we give 20 ml per kg, right? Normal saline, right? In shock. And also if for normal maintenance, it's either normal saline or ringalactate or Hartmann, right? So in shock, it's always normal saline. Bolus is 20 ml per kg, unless in the 5 instances where we give 10 ml per kg. And reassessment is always necessary. Then we talked about dehydration, various degrees, the 3 types of fluid: maintenance fluid, deficit fluid, and ongoing losses. And then we talked about special circumstances, heart failure where we restrict fluid, renal failure, again, be worried about potassium, right? And then again, you might need to restrict fluids. DK again, can more chance of cerebral edema when you treat meningitis, right? And SIADH, right? So meningitis, actually, we do not restrict fluid. We maintain keep the maintenance, right? So burns, you might have to give more fluids, and always be careful about electrolytes, especially sodium and potassium. Even low calcium can cause shock, right? Think about sugars and think about bicarbonate, like acidosis when you have a child with diarrhea or intestinal obstruction, right? So those are the things that we discussed about. So the take-home messages: use only isotonic fluids, right? And the amount to be decided upon depending on the clinical condition, whether it's shocked, whether it's dehydrated, whether there are associated clinical conditions, right? Like heart failure, meningitis, right? And then always after resuscitating fluids, and when you are giving IV fluids, keep on reassessing. And electrolyte abnormalities could be life-threatening. Okay, so thank you very much. I hope there are no questions. Anything in the chat box? Right, okay, ringalactate will worsen the acidosis in shock. No, because lactate, actually it's not lactate in the sense, it's a weak base. If you go and read about it, it's something like acetate. It's not lactic acid, it's lactate. So no H+, only the lactate is there. So it will bind to H+ in acidotic patients and then help the acidosis, right? So in diarrheas and all, it's better. Just go home and read about it. Lactate, it's not acidosis, it's helpful in acidosis, right? I hope I answered your question. So thank you very much. Dr. Krishant Dalbadaz is here to take you all on to the next lecture. Thank you very much. Over to you, Krishant.
Thank you, Thank you Viraj. very much, sir. Nadishan, can you let me share the screen?
Can you share it now, sir?
Can you see the screen? Sorry. Good evening, everyone. My name is Dr. Krishant. I'm the pediatric neurologist at Kurunegala Teaching Hospital. Can somebody just confirm that they can hear me and see the slides?
Yeah, can see it.
Oh, okay, good. All right, so I am tasked with doing two brief discussions. One is assessment of a child who is having decreased consciousness. Secondly, a child who is having a prolonged convulsion. And both are what you call neurological emergencies. Now, I learned that you are pre-interns, so you have not worked on your own in wards, but I'm sure during our medical school days, you would have seen what happens when a child like this comes to the ward. Say a child who is suddenly unconscious is brought. Imagine the atmosphere in the ward. On one hand, you have a highly agitated, inconsolable parents who had a child who's normal a few minutes back and is now unconscious. They are shouting, they're howling, they're crying, asking you to do something. On the other hand, you have this whole other medical staff, nurses to minor staff, rushing around trying to do something constructive to revive the child. And this is confounded by all the other mothers in the ward, crowding around, trying to see what's going on. So you are at the middle of all this, and you have to lead a team of healthcare workers to, resuscitate and revive the child. So what the idea behind doing these two lectures, or what you have learned from the whole day, is to get some competencies, or maybe to think about some of the things you need to know in handling such children. So my task is first to discuss about disability and decreased level of consciousness. Right. So components of the brain who requires neurological assessment, type of neurological assessment. significance of pupils, muscle tone movements, recognition of seizure activity. All right. So these, you know what brain is made up of: tissue, CSF, and blood. Skull is a fixed volume, and inside you have these three components: brain tissue, blood, and CSF. I'm sure Viraj told you about the brain perfusion. He discussed that cerebral perfusion pressure equals mean arterial pressure minus intracranial pressure. So the target here is to maintain cerebral perfusion pressure. You do that by pumping blood in, and the resistance against the blood going to the brain is the pressure exerted on the blood vessels by the intracranial pressure. So neurological injury can be primary or secondary. Primary meaning spectrum, something that happens from outside. Secondary meaning that insult that contributes to worsening also. There are some systemic illness that is causing something in the brain. So primary is a direct injury to the brain. So these are the causes of this thing. So Monroe Kelly we have discussed about. What I want to quickly go through is, so we discussed about cerebral perfusion pressure. Now, when you see a child who has a neurological problem, you do not rush in and try to revive the neurological deficit immediately. So, I mean, think about a child who's, having a convulsion. You're not going to rush and try to stop the convulsion by giving diazepam or whatever, but you try to do a systematic revival of the child by going through airway, breathing, circulation, and disability. You do so keeping in mind your neurological deficit, or you say so central neurological failure is not the first thing that will kill the child. The first thing that will kill the child would be an airway obstruction or a breathing problem. Hypoxia per se is going to be the killer that is going to come first. And then comes your hypoperfusion or circulatory issues. That's why you need to then assess the circulation. So assess the circulation. Is the child in shock? And then you put the two white book cannula. If the child is in shock, you have to resuscitate the circulatory issues by giving, in a previous lecture you heard, you need to give a volume, you need to give inotropes, you need to give vasopressors. So circulation means arterial pressure, then comes your disability. Now, assessment of disability or assessment of the central nervous system in an acutely ill child can be done by looking at only three components. This gives a large amount of information and tells you whether the brain is affected. Firstly, you have to look at the conscious level. So what you can say, you assess and rate the conscious level. You assess and rate the conscious level using the ABPU scale or the modified Glasgow-Coma scale. Secondly, you look at the pupils and see whether what the pupil responses are. You look at the consensual and the direct pupillary reflex. Thirdly, you look at the arms and legs. So these are the three things that will tell you whether a child who has reduced conscious level is having some significant pathology inside the brain. Okay, so general behavior, you have to look at, must be age appropriate, fixing and following, moving all limbs. If it's a baby, it'll be crying, speaking sentences. And then we come to assessment of conscious level. So assessment of conscious level, as I said, has two components. One is the AVPU. So AVPU stands for, A stands for alert, V for voice, P for pain, U for unresponsiveness. And you see some corresponding values on the other side. So if a child is alert, that means if the child is fully alert, GCS is 15. But if a child has, responding only to voice, it can be from 8 to 14. So that is a big range. If the child is responding only to pain, then 4 to 8. Again, a big range of about 4 points. And if the child is unresponsive, 3 is the lowest mark you can get in GCS. Now, the use of AVPU is that it is a very rapid assessment. You don't need to be a doctor to do this. You can even train your nurses to do this. And here, what is significant is we are trying to see whether the child is responding to voice or is just responding to pain. That is the demarcation here. That is very important. Anybody knows why that demarcation is important? You can type in or you can shout out. Why is it important that we know whether the child is responding to voice or a child is responding to pain? I'm asking a few questions because I don't know whether you all are there or not. So let me ask Timira Lamahevage. Not sure? Anybody wants to answer that question? If you don't want, you are shy, if you are very shy, you can type in the chat box. For immediate intubation.
The patient's GCS is lower than 8, it means the patient needs intubation.
If can you tell that again? If the GCS is?
If the GCS is less than 8, it means the patient needs intubation.
About the AVPU. So if it's AVPU, voice and pain is, I said, is the demarcation we are looking for. Is there any reason for that? You might, you can correlate the answer you gave with the numbers on the left, you're correct, but I want you to correlate that to AVPU. So just, now turning that answer to AVPU. So we know that if we are looking at GCS, if it's less than 8 or 8 or less, we need that is the airway is not secure, and the child might be prone to aspiration, airway block, or hypoxia. And the same thing with you can see if it's voice, the less if the child is responding to voice, GCS is above 8. If the child is responding to pain, GCS is 8 or less. So that is why it is important in a rapid assessment to know that and to teach your junior staff. That way, the nurse might come and tell you, doctor, this child who was responding to voice earlier is now not responding, and is responding only to pain. You know that the child's conscious level has now deteriorated, and you need to go and quickly see this child to do something about his airway, and maybe see why the GCS is gradually dropping. Is the intracranial pathology rapidly expanding or rising or becoming worse, whatever? Now the Glasgow Coma scale, we use the modified Glasgow Coma scale. I'm sure you know that there are 3 main subcomponents there. Eye response, verbal response, motor response. We say the best eye response. So you are it's the out of the 6, what is the best response that you can get? That is why it's called the best eye response, best verbal response, best motor response. And you can see some the points there. For motor response, you have 6 points. For verbal response, 5. And for motor response, 4. Now, total out of 15. I can't remember this, so I don't try to remember this. What you should do is have this at the bedside at your admission table or admission bay or admission, the place you admit patients to, or in your HDU, so that you can easily look at the chart and mark the components for each of the give the points for each component. What usually happens is, when I go and ask somebody in the ward what is this child's Glasgow Coma scale, they give a subjective answer. So they can't give the individual components. That is because they haven't assessed the. They give what it feels like. I mean, his thesis is around 12 or whatever. That's what usually that is the usual answer that I get. Now, when I go to the ward or to the HDU or to the the ICU and ask the GCS, what I expect you to do is give me the individual components and then give a total answer. So I would say eye response is 3, verbal response is 4, and the motor response is 5, and the total GCS is 12. So that is how you should communicate GCS to a colleague, and that is how you should write the GCS down in the bedhead ticket, because it's a legal document. Now, the other thing about GCS that you need to remember is that usually people, tap like this and ask, Baba, how are you? Now, you should only give one stimulus at a time. So when you are touching, if there's a shoulder injury or whatever, you are eliciting either touch or pain, as well as you are giving verbal stimulus as well. So you should only give one stimulus at a time. You can see this also looks at voice, pain, in assessing the components, and then only you need to write down the best response that you get. The other thing about eliciting these responses, so when it comes to pain, so when say localizing to pain, sometimes you try to put pressure or pain on the middle or the middle of part of the body, like on the mid sternum or maybe forehead, like that. And when you do that, it is very difficult to decide whether the child is localizing or withdrawing, because he'll just be wiggling around. So it's always best to put pressure or pain on the periphery. Usually, we don't encourage putting pressure over the eyes. It is the thumb. You can put deep pressure by pressing the nail bed like this. Those are some simple things that you need to remember. And I talked about how to document or how to communicate GCS to a colleague. And so this is the first component, assessing and rating the conscious level. So the next one is posture. So here we are looking at two things. We are looking at the arms and we are looking at the legs. So think about it as you are just, having a glance at the child's arms and legs. Decorticate posture means upper limbs are flexed and the lower limbs are extended. Decerebrate posture means upper limbs and lower limbs are both extended, and this is a sign that the brain matter is involved with raised intracranial pressure. You can remember this by, decorticate means like somebody who has caught the ball. Think about a rugby player holding the ball and running, right? So caught the ball. You can easily remember. Decorticate is better than decerebrate. So usually they progress from decorticate to decerebrate, and decerebrate is a means there is ongoing damage inside the brain. Now, the third aspect is to look at a child's pupils. Now, there's an English idiom which says, eyes are the window to your soul. I'm sure most of you know that. I'm not sure why that idiom came about, but I have now changed that idiom to say that the pupils are the window to your brain. So look at the pupils, you know what's happening inside the brain. So you can check the reaction, you can assess the size, you can see whether it's direct or consensual, you can look at the shape. But basically you are trying to see three patterns. That is what I always say. You need to only remember three patterns. One pattern is whether it is unilaterally dilated, is only one side dilated. The second pattern that you need to remember is both sides dilated and not reacting. And the third pattern that you need to remember is, are both sides pinpoint. So if you remember these three patterns and say you check the pupils and you identify one of these patterns, you are certain what is going inside the brain. For instance, if it's pinpoint, that means it is either something happening in the brain stem, or the child has taken some poisoning, it's iatrogenic. If it's unilateral dilatation, there's something happening on that side of the brain. So if right side is dilated, something abnormal is happening on the right side. It might be local, it might be on the brain. So it can be something like somebody putting atropine drops to the eye on that side, to extradural hemorrhage on the same side. But if it's bilateral dilated, which is the worst one, that means the whole brain is affected by something global. Something is affecting the whole of the brain now. So easy to remember, easy to know the patterns, and easily identify what is happening inside the brain. So looking at arms and legs, this is what I talked about. Caught the ball, decorticate posture. And then the second picture is where all limbs are extended, decerebrate posture. All right. So once you have assessed the conscious level, the posture or arms and legs and the pupils, and this tells you that the child's brain is affected with some pathology, it is now time to see whether there is raised intracranial pressure ongoing due to the insult. Now, most of you, when I say raised intracranial pressure, think about the Cushing's reflex. So Cushing's reflex is hypertension, bradycardia, and abnormal breathing pattern. Now that is a Cushing's reflex or the Cushing's triad. But this is quite pre-terminal. Before that happens, the conscious level will go down. The pupils will become sluggish. There will be other signs of behavioral changes, neurological effects. And another thing is, you can see that the cardiovascular changes are a late sign. Other thing that some people do, trying to identify raised intracranial pressure is to take the ophthalmos scope and poke into the eye and try to look at the fundus. Now, in acute situations, we are talking about acute situations here, acute causes of drowsiness in children. You are unlikely or you are not going to find papilledema in these children. So papilledema is a sign of chronic raised ICP, not acutely raised ICP. So don't go looking for papilledema. One thing is it is so difficult to for a novice or somebody who has not got used to looking at the fundi to identify it. The other thing is, I mean, it will not be there at all as well. So papilledema, don't look for it. Bulging fontanel, yes. If a child is less than 1 year, then you can the fontanel may be bulging. Absence of venous pulsation in retinal vessels, that is very theoretical. I don't think anybody looks for that to see raised ICP. So we talked about these things. So main thing is you look for the pupil size and reactivity. You might see abnormal oculocephalic reflexes. You might see something like a 6th nerve palsy. So now when you have extradural hemorrhage, what happens is that in that side, due to the pressure here, there would be initially what is called an uncal herniation down the tentorium. That is where the 3rd nerve is compressed. And then once the pressure builds up, the whole brain herniates down as given in the uncus herniation is given in 1. Then 2 is where the whole brain goes down through the tentorium, and then when that happens, you get bilateral dilatation due to hypoxia, ischemia of the brainstem. I'm just going fast because of time. Movement and sensation, fontanel, which we need to look at if the child has an open fontanel. Okay. Now, so I'm sure I heard Dr. Viraj discuss about reducing raised intracranial pressure. There are 2 main arms to managing raised intracranial pressure. One is the general principles. So in general principles, what you are trying to do is you are trying to maintain a good flow of venous blood flow from brain to heart. So that is one thing. So you do that by elevating the head end to 20 to 30 degrees. You do that by making sure that the neck is not kinked to sides, so that the veins on that side are blocked. So head in the midline, head tilted to 20 to 30 degrees. That helps venous return to the heart, venous flow to the heart. So it does not, cause a back pressure and reduced perfusion. The next thing is trying to keep the environment quiet as possible. No noises, no frequent interventions with to the child. So free of disturbances, that you do not disturb the child. And the other one would, the third component here in general principles is to reduce the metabolic rate. You reduce the metabolic rate by trying to get down the temperature to low normal levels. If the child is having a high fever, high temperature, you need to get it down. If the child is having seizures, you need to control the seizures. If the child is agitated, thrashing around, you need drugs to sedate the child. So those are general principles. And then If the child is hypoglycemic, you need to treat that. Electrolytes, you need to normalize the electrolytes. We talked about convulsions and hypothermia. Now, specific management of raised intracranial pressure involves intubating and ventilating the child. Why do we intubate and ventilate a child who has raised ICP and reduced conscious rate level? One thing is to get control of his oxygenation. So once you put the tube in, you can increase the oxygenation rate, the amount of oxygen that you give, the rate that you give, to maintain normal oxygenation. The other component here, important component, is you gain control of his carbon dioxide levels. Now, carbon dioxide in high doses is a vasodilator. So if the carbon dioxide goes up, there will be vasodilatation inside the brain, which is a reason for raised ICP. But if the carbon dioxide goes down too much, it's a vasoconstrictor. Then the brain perfusion is affected. So you have to strike a balance here. And the balance is maintaining carbon dioxide at a low normal rate. 30 to 35 is our target. Support circulation, I'm sure you remember cerebral perfusion pressure equals mean arterial pressure minus ICP. Viraj said that in his lecture. So you support circulation by giving volume, giving inotropes, giving vasopressors. So you support the circulation and try to increase the mean arterial pressure. Osmotherapy, mannitol and 3%. Both have their uses. Mannitol you cannot use when the blood pressure is low because it brings down the blood pressure further because of its vasodilatory and its diuretic effect. So it will reduce the mean arterial pressure. In 3% sodium chloride, you are not going to use it if the child is having skyrocketing sodium levels, hypernatremia. So each has, its own school of supporters who say this is better than this one. But definitely in certain situations, you will have to use either of the two. But your medical management is going to last only or gives you or buys you only time sometimes. You know that you are not winning the battle when the child is gradually deteriorating. The pupil starts to become sluggish, one side starts to dilate, and then it is going to affect the other side. Or if it's dilated on one side, it's not coming down. Your medical management is not working. And to know that your medical management is not working, you need neuro-obs to be done very, very meticulously and very, very carefully. You need to do that because you need early neurosurgical intervention if your medical management is not working. Sometimes the neurosurgeons are not available because they are very busy doing a very long surgery that goes on for hours and hours. So you need to have them informed, you need to keep them informed that there's a child like this who might need their intervention very quickly if the medical management fails. So what they do is they will do a craniectomy or they will put a EVD as in earlier lecture. And that is the specific management in reducing ICP if the ICP continually rises. So treat the treatables. I'm just going through this. Right. So now for the next few minutes, I'm going to discuss convulsions. Right. So convulsions in children. So what do you need to know about convulsions? So a prolonged convulsion. What is a prolonged convulsion? I'm sure most of you are now fast asleep. So can you tell me what is meant by status? Anybody? What is meant by status epilepticus, not status asthmaticus? Yes? Does anybody know what a convulsion lasting for 30 minutes? Any more answers? Convulsion lasting for 30 minutes. Any more answers? No? So there is a definition by the International League Against Epilepsy, but now they are asking for 5 minutes. Who said? Okay, so now International League Against Epilepsy put out a definition saying that in 1993 that a status is a convulsion that lasts for more than 30 minutes, or you have short lasting convulsions for 30 minutes without the child coming to baseline. Baseline meaning his pre-morbid self. So he is not fully gaining consciousness. So that is a definition that is about now 30 years old. Now they have not recently, they have changed that definition in 2015, about 7 years back, to say that a status, what they have done in that definition is to put in timelines. So they have put in a timeline called T1 and T2 to the status epilepticus definition. Now the T1 time is 5 minutes for a motor convulsion, and T2 timeline is 30 minutes for a motor convulsion. So why T1 and T2? T1 is what is called impending or early status epilepticus. All pre-hospital data suggests that if a convulsion lasts for more than 5 minutes, it is very unlikely to stop on its own or stop spontaneously. And that is why after 5 minutes, it's called impending or early status epilepticus. After 30 minutes, the 30-minute definition used earlier, it's called established status epilepticus. That is there because they have found in animal models that a convulsion going on for more than 30 minutes starts to destroy your brain cells. So any child who is having a convulsion that is going on for more than 30 minutes is likely to have lost some brain cells or brain matter. So that is called established status epilepticus. So your target is to intervene at 5 minutes because this convulsion is unlikely to stop on its own, and try to stop this convulsion going beyond 30 minutes. So you are trying to stop brain cells from dying. So that is the use of the new definition. So common causes of common causes of convulsion. The common causes of convulsions: fever, febrile status, can be hypoxia, can be infection, can be metabolic problems. A child might be a known epileptic on anticonvulsants, might not have taken anticonvulsants, or might have been put on a gradual withdrawal of anticonvulsants. So what do you do when you see a child with convulsions? So you have 5 minutes. That's why I said Don't rush in and try to give diazepam. This is what usually happens in hospitals. As soon as you see a child convulsing, you give him diazepam or midazolam and end up giving a more than normal dose, and his respiration goes, and you have to ambue the child or intubate the child. See, you have 5 minutes to assess and secure his airway, assess and stabilize his circulation, and look for possible reversible causes. So what are these reversible causes? So in red it says, don't ever forget glucose. Glucose is what we commonly check when a child is convulsing. But also remember, there are other reversible causes that might be, causing this convulsion. Electrolyte abnormalities, sodium, potassium, which you need to, when you're taking blood, send for. It can be due to hypertension or high blood pressure. Make sure that you check the blood pressure as well. It can be due to infection. So you send for septic markers and blood cultures if history is suggestive. So all these can be done during the first 5 minutes. Right? So these are what you need to do. Make sure that, if the child is convulsing, it's very likely that there are a lot of secretions that are getting collected. So you have to make sure that you put the child on the left lateral position, maybe head little down, so that the secretions go drain through gravity. Child might be hypotensive, give fluids. And once the 5 minute mark, so you have to start the clock at the start of the convulsion, or maybe get a rough idea when the convulsion started from the parents. So once the 5 minute mark is over, you need to now intervene with anticonvulsant drugs. So the anticonvulsant drugs that we commonly use as first line are benzodiazepines. So there are 3 benzodiazepines: diazepam, midazolam, and lorazepam. Out of these, lorazepam is not available here. So you have 2 choices. Are you going to give midazolam or are you going to give diazepam? Which one? So if I go back to your medical school days, I don't know whether you remember, there is something called affinity for receptors. Now, midazolam has a higher affinity to the receptors than diazepam. That is, when midazolam gets attached to the the receptors in the cell membrane, it stays there for a longer time than diazepam. So what the clinical effect of it is, when you give midazolam, it is less likely, they have shown, that the child will get a recurrence than diazepam. The other thing is, midazolam has a very slight advantage with its respiratory safety profile than diazepam. So I would prefer to give midazolam over diazepam. That is one thing. The second thing is, during that first 5 minutes, you need to make sure that you have vascular access. Giving IV has proven to be far better in controlling the seizures than when you give it orally or PR. You can, if you don't have vascular access, you can give that, but it is far better to give IV to control the seizures, and that is why you need that 5 minutes to do the ABCD and give IV if possible. So once you have given your first benzodiazepine dose, you can wait for 5 minutes. Now, during that 5 minutes, what you do is you go back to your airway breathing circulation, you reassess, and you also reassess to see whether you have missed the reversible causes that we talked about. So have I checked blood glucose? Have I checked the electrolytes? Have I checked the blood pressure? Have I done an infectious screen? And that is what you need to do during the next 5 minutes. Once the 5 minutes are over the second 5 minutes, you go and give another dose of your midazolam or diazepam, depending on availability and your preference. So you can only give 2 doses of benzodiazepines for 24 hours. So during the acute phase of a seizure, so in a status, you can only give the benzodiazepine twice. Giving it more than 2 times, say so third dose of midazolam, third dose of diazepam, you increase the risk of respiratory depression or respiratory arrest by a few fold. So you do not give it. The third step after waiting for another 5 minutes, reassessing and looking at the reversible causes, is to give either phenytoin or levetiracetam. So levetiracetam IV is becoming gradually available in all hospitals, in private sector as well as in government hospitals. In major hospitals, definitely it's available. Phenytoin has always been available. Phenytoin, when you give, it's given over 20 minutes IV as an infusion, not as a bolus. You do not try to exceed 50 milligrams over 1 minute because of the risk of hypotension and ventricular arrhythmia. So you need to check the rhythm, have the child connected to the monitor, and also intermittently check the blood pressure as well to see whether it's going down. Levetiracetam you give over 5 minutes. Usually there are no major risks of giving IV bolus of a levetiracetam dose. Usual dose is about 40 to 40 milligrams. Sometimes people go up to about 60. Now, if the child is still fitting after giving levetiracetam or phenytoin, what you do is you now interchange. So if you have given levetiracetam initially, now you give phenytoin. So if you have given phenytoin initially, you give levetiracetam. So if levetiracetam is not available or phenytoin is not available, what you have is phenobarbital. You can give phenobarbital here. And then if the child is still fitting, that means child is still have an ongoing convulsion, then you will have to intubate the child and ventilate the child. But how do you know that once you give the muscle relaxant that the seizure has stopped? So intubate, ventilate. Once you give a muscle relaxant, you will not see the clinical seizures. So this is where it is important that you have EEG monitoring intermittently or 24 hours. So what you are trying to do is stop the electrical seizure from going on and on and on. For that, you need to start an IV infusion. 3 drugs we use: carpenton, propofol, or midazolam infusion. And we gradually escalate the infusion, looking at the EEG, trying to see whether the electrical seizure has stopped. If it has not stopped, we are trying to induce what is called a burst suppression in the EEG. So that will stop the seizure. So that is the management of status. So medical complications, you can get arrhythmias, you can get pulmonary edema, you can get cerebral edema, you can get muscle breakdown, you can get DIC. Those are just, I think, any 3 theoretical issues. After the seizure has stopped, you have to continuously monitor the airway breathing circulation. You have to continuously monitor whether the seizure activity will reappear. And you have to make sure that the underlying cause is justifiably taken care of. Okay, so if it's intermittent fever rash, so obviously an infection. If it's rapid onset, poisoning, CV, vague history, it can mean an unaccidental injury. Hypertension, it can I'm just going through this. Any question? Any questions from both components? Decreased child and a child with conscious convulsions. No? So patient was on phenytoin. Are we considering phenytoin in emergency management? Yeah, so if the patient is on phenytoin, you might, phenytoin has a very narrow therapeutic index. So that's why we are monitoring blood pressure. That is why we are connecting the child to the rhythm monitor. If the child is already taking oral phenytoin, we are not quite sure whether giving the bolus might, cross the red line and child might develop a complication. So that is why we have 3 drugs. We have levetiracetam, we have phenobarbital. So you do not need to give phenytoin IV bolus if the child is already on phenytoin. Any more questions? That is Danushka's question. Okay, so in the absence of any questions, just to summarize what we did, we discussed the management of a child who is having a decreased conscious level. So we are looking at a systematic approach, airway, breathing, circulation, then going on to assess disability, which has 3 components: conscious level, looking at the pupils, looking at the arms and legs, and trying to identify whether there's raised intracranial pressure and try to get it down by general measures, specific measures we discussed. And if they fail, you need to have early intervention by a neurosurgical team. Then we discussed management of status epilepticus. We discussed the new the 2015 ILA definition, T1 and T2. You are targeting to intervene with anti-epileptic drugs at 5 minutes. Before that 5 minutes, you have to do the airway, breathing, circulation, look at reversible causes and correct. But if the conversion goes on beyond 5 minutes, we discuss the place for benzodiazepines. We discuss the place for levetiracetam and phenytoin. We discuss the place for phenobarbital. We discuss the place for intubation, ventilation, and infusion, starting an infusion with midazolam, carpentanol propofol, and trying to induce a burst suppression to get control over the electrical activity inside the brain. So with that, I'm going to stop and hand over control of the screen back to SLCP. Thank you.
Thank you very much, sir.
Right. Thank you very much for participating today. So we have concluded today's program. So tomorrow also we have lined up some practical discussion sessions. So do join us tomorrow at 8 o'clock. Right. Thank you very much. So other thing is tomorrow when you log in by your Meritode and names with initials. So we're going to monitor your participation by the Zoom and on the YouTube as well. Right. Thank you. Yeah, ERPM, you can log in by your surnames and the initials.